हेलो। नहीं, स्पीकर नहीं चल हेलो। हेलो।
Dr. Kupreja sir, can you hear me? Dr. Kupreja sir, can you hear me?
Yes, ma'am. I think
Sir, hi Virgin. Kupreja sir, can you hear me?
yes, I can. Can
Okay,
you
sir,
hear
would you
me?
like to check your presentation?
Am I clearly audible?
Yes, sir, you're audible, visible. We can see you, we can hear you. So
Okay.
if you want, you can check your presentation, trial run.
Hello. 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 Hello.
Sir, you are not visible. Sir, we cannot see you.
Can you see the slides? I've shared my screen. Am I audible?
না ওইটা সিডিটা তোকে করতে হবে, সিডিটা করেছে। থেকে চালানোর প্রথমে আরটিকে অ্যাড আসছে। हमें करेक्टेड सीधी साइड का पाठा। हाँ बोलिए। हाँ देख रहे हैं, आई कैन सी यू, आई कैन सी द बैकड्रॉप। हाँ बैकड्रॉप दिख रहा है, फरेंट सर दिख रहे हैं, विजिबल। विजिबल।
কেমেৰাটো এইটো লোৱা নাই ন এতিয়ালৈকে তেতিয়া ওলাইছিলে যে সেইটো উলিয়া নাই নাই এইটোত লগাব দিছো ৰ'ব তোমালোকে ৰেডি কৰিলো আমি পাছত কি প্ৰব্লেম ইয়াতে লগাব দিছিল কি প্ৰব্লেম অডিঅ'টো ক'ত হ'ব কোনটো লেপটপ হ'ব यही লেপটপ यही से हो जाएगा वो ना ये उधर से हो जाएगा हेलो 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 শুনা পাইছা ন ডক্টৰ হেল্ল'
Yes,
মই
sir,
ইয়াৰ
you
পৰা
are
দিছো
audible.
यहाँ पे कनेक्ट कीजिए
Yes,
हेलो
Dr. Karim sir is audible.
आर यू
Yes.
लिसनिंग
Yes, visible and audible.
अरे यार क्लिक কৰিব লাগে थैंक यू मैम थैंक यू फॉर कंफर्मिंग हेलो वासिम सर आर यू लिसनिंग वासिम
Speak again.
ये वाला
Hello. Hello.
हाँ मैम बोलिए
Hello. Yeah, say something again.
यस मैम
Hello.
मैम सॉरी हेलो
Yes. আর জানা चाहिए না यार एचडीएमआई কোড না থাকলে কি করে জয় তো এটা কি ব্যাকগ্রাউন্ডটো ভালকে আহা নাই ভিডিও পজ হৈ গৈছে এটা কৰা নাই इसको हेलो ये दिया আছে না এটা दिया আছে তো সাউন্ড কোন আছে নাকি নাই আছে তো মেটাল নিচে ক্যামেরা লাগে ওই তুমি এটা কোন একটা মেনেজ রেডি ওই দে কি কইছ শুনা পাইছা এই যে কনভার্টার এটা থাকে না সৰু তাত লাগিব না নতুন ল্যাপটপ বুজি পাইছা ইয়াৰ পৰা এক্সট্ৰা এটা কনভার্টাৰ থাকে সেইটো মঙাই লব কনভার্টাৰ হেল্ল এর পাইছে না ওয়াশিং স্যার পাইছে না বল দিল আরে সাউন্ডও পাইছে না লাইভ দিয়া নাই ইয়ার পরা তাতে লাইভ দিয়া নাই তুমি বুঝা নাই সেটা ডেলিগেটে দেখা না পায় আপনি আরে ডেলিগেটে কথা বললে কম পাবো লাগিব না হয় এটা সংগ্রহটা করে স্টার্ট করতে মই হ্যালো ক্যান ইউ হিয়ার মি জয়েন হয় নাই নো জয়েন হয়েছে স্যার কোড জয়েন হয়েছে নাই জয়েনিং মিটিং দিব লাগিব তো করো না না বেলে আছে স্যার অলরেডি জয়েন নাই জয়েন মিটিং Sir, you are not audible.
मीटिंग आईडी तो की बोले या मीटिंग आईडी तो दिया
Karim sir, please say something.
Hello. Hello.
उसमें डाला हुआ है ना, कैमरा भी डाला हुआ है,
Yes, audible. Yes,
इसमें भी
audible.
डाला हुआ है। हाँ, आईडी तो नहीं चाहिए, इसमें डायरेक्ट लगेगा ना, आईडी नहीं चाहिए, ना लगा आईडी ना लगे होगा। ये फैकल्टी होने सर, ये फैकल्टी तो डायरेक्ट हो।
We are live. We can start the program.
Okay.
Hello.
Yeah, I can hear you. Hello.
Yes, sir. We are live.
Hello. Yeah, can you hear me now?
Yes, sir. We can hear you. You are audible.
Okay. Very good afternoon, everybody.
Sir, your video is not visible, sir. We cannot see you.
Hello.
So please start the video.
Video is coming.
Okay.
Yeah, good afternoon. Good afternoon. We are going to start the presentation. Dr. Wasim will start his presentation now. May I request Dr. Wasim to start his presentation? May I request Dr. Wasim to start his presentation?
এই ফোনবিলাক বন্ধ কৰিব দিয়া।
বেছি নেটৱৰ্ক কিবা হ'ব নেকি সেইটো MBPS বেছি লাগে স্পীডটো যোৱাকালি
একো নাই যিখিনি কৰিছিলোঁ যিখিনি কৰিব লাগে নকৰি দিলোঁ সেইবিলাক আমি কৈছিলোঁ মানে যদি ইয়াতকৈ হায়াৰ ৰিকোয়াৰ্ড হয় তেতিয়াহ'লে বাঢ়ক পৰা ইয়াতকৈ মই মেক্সিমাম পাৰিলে 1 MBPS ইনক্ৰিজ কৰিব পাৰিম তাতকৈ
চাওক না পাৰে যদি বঢ়াব পাৰে আছে এজন সুধি চাওঁ
কাৰণ কি প্ৰব্লেম কি হৈছে কালি তেখেতক কেনেকৈ কৈছিলোঁ
এতিয়া লাগে ন
এটা মোমেণ্টত নোৱাৰা ইটছ নট পচিবল মইতো তেখেতক কালিও মই প্ৰপাৰলি ক্লিয়াৰলি কৰিছিলোঁ আপোনালোক 20 ডেজৰ এটা কানেকশ্যন লাগিব এটা কানেকশ্যন লাগিব মই এটা জেগাত আপোনাক তিনিটা
এইটোতো বেলেগ সেইটো বেলেগ কথা কিন্তু MBPS স্পীডটো বেছি লাগে
স্পীডটো
এতিয়াতো বঢ়াব নোৱাৰে
Very good afternoon to everyone. Am I audible to everyone here?
Yes, you are audible.
Thank you so much.
Yes.
Should I start off with my presentation then in that case?
Please go ahead.
Thank you so much, sir. I have been given the opportunity to present cardiac risk stratification before a non-cardiac surgery. So I'll keep it very simple and short, and I will be dealing with the salient stratification points and how do we go about planning a non-cardiac surgery in a cardiac patient. So beginning with the introduction. So just a minute, the slide is not. Can you see the second? Can you see the introduction to the slide?
Yeah, you can see the introduction slide.
Okay, the introduction, I would like to start with that the cardiovascular morbidity and mortality is a special concern in patients who are having cardiovascular risk factors and or already known case of cardiovascular disease. And perioperative cardiac mortality increases the total burden of the cost and increases the hospital length of stay. So the actual purposes in this stratification is we want to know the current medical status of the patient as to what medications is the patient on, what is the risk posed by the surgery in which the patient going, and what are the methods by which we can decrease the risk of the patient. Yes, ma'am?
Sir, sorry to interrupt you. Your slides are not changing. Please change the slide. Make it full screen, slideshow, and then please change the slide.
Just a minute, ma'am.
First, sir, make it full screen. There is a sign on top left, slideshow. So right. So there is a button in the, yes, now it's okay. Perfect.
Shall I proceed now?
Yes, sir.
कंप्यूटर का माइक्रोफोन को और उसको चेक करना है तभी इनका वॉइस ऑडियो
Am I audible?
Yes, you are audible. Please go ahead.
I would like to start
वॉइस नहीं अनम्यूट हुए इसलिए एडमिनों का अनम्यूट करा है सर अनम्यूट को दिया है सर
So we can hear you.
host muted you.
होस्ट ने इनको
और वीडियो भी नहीं आ रहा.
Sir, we can hear you. We can see you. Sir, we can hear you. We can see you.
Hello.
Actually, Dr. Bharati is not audible. आप मत आप कर लीजिए आपका ये स्क्रीन शेयर कीजिएगा आप इसमें कर मत इसमें भी कर इसमें कीजिए इसमें मत कीजिए आप खाली इसमें रखे स्क्रीन शेयर कीजिएगा समझ गए ना नहीं कर लिया हाँ हो रही है हाँ म्यूट कर लिया हेलो मैं ऑडियो हेलो ऑटोमेटिकली होस्ट म्यूट को दिए
Presenter is right now Dr. Wasim Bharati. Computer is Dr. Pura. Just a minute.
हाँ हाँ
तो उधर से क्या हम
Wasim sir, I was calling you. Please pick my phone. Wasim sir, can you hear me? Hello, Wasim sir, can you hear me?
Interesting. Left.
Wasim?
Down. Yes, last.
And everyone see the presentation now?
Please share your screen. Screen to share will down there.
Wasim, you make it full screen and you start your presentation.
There again. Yes, yeah. No.
Wasim, you start.
Okay, sir.
Now it is on. Down arrow. Yeah.
Hello, everyone. I think now my screen is being shared onto the full mode, and then everyone can listen me. Okay, sorry for the interruption. Now I'll start off. I've already discussed the introduction. Coming to the approach and evaluation. So we have to look for some salient points that the first patient who is undergoing surgery, how urgent is the surgery by itself. We have to evaluate for any active or unstable cardiac conditions. On third point, we have to determine the risk of surgical procedure. We have to also evaluate the functional capacity of the patient in case it is required, that we will discuss further. And if patient has poor functional capacity, then the risk of surgery has to be determined, and the approach and evaluation for the further. So this is the basic algorithm when you plan a patient for a surgery, a patient who has got multiple risk factors and who is a known case of cardiovascular disease. If the patient is having a urgent surgery or it's an emergency, then we won't have time for initial workup. In that case, the patient has to be sent to surgery with only clinical risk stratification. In case or the patient has only unstable conditions like unstable angina or class 3 or class 4 stable angina or crescendo angina, then he has to be evaluated and treated according to the guideline directed medical therapy in case the surgery is not urgent. And after that, we have to risk stratify based on what is the risk of the surgery. If the surgery is low risk, then no further testing is required and patient can be posted ahead for surgery. if the patient is having intermediate or high risk of surgery, and if the patient is having a moderate or more than 4 METs functional capacity. That might be more than 10 or that might be 4 to 10. If it is more than 10, then patient can be posted for surgery. That's a class 2 indication. Or if patient has got a moderate functional capacity, which is from 4 to 10 METs, then patient can be, it's a class 2 indication to proceed ahead with surgery. Then in case if patient is having a very poor functional capacity, which is less than 4 METs, then we have to decide whether further testing would help us in decreasing or negating the effects of perioperative cardiac events by doing non-invasive testing in the form of exercise testing or dopamine stress echo or other stress thallium scans. If it is normal, then patient can be posted for surgery. Or in case if it is abnormal, if the patient is having will benefit from coronary revascularization or an intervention, then we have to proceed accordingly. So the type of surgery can be decided as emergency procedure. It is basically defined as or looked upon as if the patient is not taken up for the operation, the patient will lose his own life or the limb will be sacrificed. Urgent procedure says that if the patient is not operated within a span of 6 to 24 hours, then again he might lose his life or the limb cannot be salvaged. Time-sensitive procedures are the one in which we have a span of from 1 week to 6 weeks, in which we can stratify the patient and we can do the initial workup before posting the patient for surgery. And elective, you can postpone the surgery for at least 1 year. Every patient should be evaluated for unstable conditions like unstable coronary syndromes that include unstable angina, a recent myocardial infarction that includes a duration from 7 days to 60 days, a decompensated heart failure, any significant arrhythmia, or severe valvular heart disease, because these are the ones which have got increased MACE during perioperative period. Now, there are various calculators based on which we evaluate the risk of MACE in a cardiac patient. The most commonly used is RCRI, that is Revised Cardiac Risk Index. Other ones are NSQIP, that stands for American College of Surgeons, National Surgical Quality and Improvement Program, and Gupta Myocardial Infarction Cardiac Arrest Score. The most common is RCRI, which includes the following variables: high risk type of surgery, history of ischemic heart disease, history of congestive heart failure, history of CVA, perioperative treatment with insulin, and perioperative serum creatinine values of more than 2. The more the number of risk factors, the more the number of MACE. So according to Lee validation, if a patient has got a score of 0 to 1, he is having a low risk of MACE during the perioperative period. A score of 2 corresponds to intermediate risk, and a score of 3 corresponds to high risk for perioperative period. The other being myocardial infarction and cardiac arrest score by Gupta et al. It includes the various parameters as type of surgery, the functional status of the patient, abnormal creatinine levels, American Society of Anesthesiology class of the patient, and increasing age. Various other calculators have been formulated based on various surgical procedures and on a large number of population, like universal risk calculator. They have also shown their significant value in risk stratification. So surgical risk itself can be, surgery itself can be stratified based on whether it's a low risk, intermediate risk, and high risk. The high risk and the intermediate risk are the ones which need special consideration. High risk mainly consists of any vascular surgeries like abdominal aortic aneurysm surgeries, or maybe the patients who are for surgical vascular reconstruction or peripheral vascular reconstruction. Apart from that, any surgical perforation which we come across every day. So these are the ones which are high risk. Apart from that, low risk does not need much of consideration. So for functional capacity, that is a very good, it tells us the risk of MACE. This can be calculated based on just by history taking, or can be doing exercise testing of the patient. So based on the OPD, we can ask the patient who's presenting to us that can he take care of himself, or can he eat, dress, or use the toilet by himself, or can he just walk around indoor? That is equal to 1 MET. A patient who can walk around the house, he can do dusting or washing of utensils, or a patient who can climb a flight of stairs, or can walk on the level ground at a pace of 4 miles per hour, or do activities like scrubbing the floor, lifting the furniture. He is an individual who is having 4 METs of functional capacity. And strenuous activities like swimming, playing tennis, football, or basketball makes a person having excellent functional capacity with more than 10 METs. So based on that, we have
patients who have got functional capacity of lower than 4 METs, and when they are planned for intermediate to high risk surgeries, they need specific consideration and they need further risk stratification. So based on the calculators and there are various tests which improve the cardiovascular risk which are posed by the surgery itself. The ECG has traditionally served the first test when a patient of cardiac risk factors or cardiac disease is risk stratified for MACE. Patients with poor exercise capacity may not achieve an adequate heart rate or blood pressure for diagnostic purpose on electrocardiographic stress test. So if those individuals are the ones who are posted for pharmacological stress testing, that is the important way and a popular way of preoperative risk assessment. Stress echo can also be widely used for preoperative risk assessment. One advantage of this test is that it dynamically assesses myocardial ischemia in response to increased inotropy and heart rate during the periodic, like during the perioperative period. It's just like a stress given to the patient. The presence of new RWMA occurring during low heart rate is the best predictor of increased perioperative risk. Other risks are like electrocardiographic monitoring, ambulatory one, radiographic angiography, dipyridamole thallium imaging, and dobutamine stress echo. Now, one other modality is cardiopulmonary exercise stress testing. It is being evaluated by a means but to determine the need of prehabilitation in which strategy of exercise is advocated to increase the aerobic capacity of the surgery. So these are the recommendations on stress testing. Not every patient is posted for stress testing. Only individuals who are posted for high-risk surgery and those who have poor functional capacity of less than 4 METs are posted, or patients who are having high or intermediate risk of surgery, along with 2 or more clinical risk factors with poor functional capacity. And the ones who are posted for low-risk surgery, that's a class 3 indication, does not pose any benefit. Now coming to the invasive coronary angiography, by invasive coronary angiography, it is one of the established things in which we can look at the coronaries to look for any obstructive coronary artery disease or any disease in the coronary arteries. So, so the indications are basically the same as patients who are going for non-cardiac surgery, but it has to be a non-urgent one because in urgency we do not have time for all these evaluations. And also for revascularizations, the indications are similar. So this says that patients who are having STEMI, NSTEMI, or unstable angina, or CCS class 3 or 4, they have a class 1 indication for coronary angiography. And preoperative angiography is not recommended for cardiac stable patients who are going for low-risk surgeries. In summation, this is again the same methodology by which we risk stratify. The step 1 is urgency of the surgery. If urgent, then you have to risk stratify on clinical grounds and post the patient for surgery without further evaluation. Again, if the patient is having any active or unstable conditions, like patient is having unstable angina or patient is having ACS, and you can postpone the surgery if it's a well-planned surgery. So in that case, you have to go ahead with coronary evaluation and revascularization if needed, and the patient can be put on DAPT, and then for a particular duration, the patient can be kept on medical management before taking her for surgery. Or otherwise, if he is having urgency, then again you have to postpone the surgery. Now, based on the other parameters for risk stratification like score, if the patient is having low risk for surgery, then based on LVEF, based on the type of surgery, like is he going vascular surgery or is the patient is having heart failure symptoms, so various increment or various addition of drugs like ACE inhibitors or statins may be added. Now, if the patient is posted for intermediate or high risk surgery, then functional capacity is the most important predictor of METs, major adverse cardiac events. If the patient is posted for intermediate risk surgery and patient has good functional capacity, then there is no further stratification required. And patient if posted for high risk cardiac surgery, if the patient has got more than 3 or equal to 3 cardiac risk factors, then you have to go for non-invasive testing. If less than or equal to 2 are needed, then only echo and biomarker assessment can be done and the patient can be posted if no unstable condition is present. Then if after non-invasive testing, if there is stress-induced ischemia, which is just nil or mild, moderate, then you can go ahead with surgery. Or if there is extensive stress-induced ischemia and patient can wait for the surgery to be planned in future, then he can be posted for either PCI or CABG depending upon the coronary evaluation, and then can be posted for surgery. Then after this brief work of the patient and risk stratification, there are various strategies which will help to decrease the perioperative MACE. I will deal with them in briefly. Revascularization is one. Patients who have got coronary artery disease, they have increased risk of MACE during perioperative period. The main reason why I want to revascularize is just to prevent perioperative myocardial ischemia. So the substantial preoperation of patients have perioperative MI as a result of low flow, high demand ischemia because of stress, which results in decreased myocardial oxygen supply in the presence of fixed coronary artery stenosis. So this was the first registry. It was the CAS registry, which showed that revascularization results in reducing coronary events during surgery. But it was done at a time when we did not have the current efficacious treatment for the patients who had CAD. It was done long back when we did not have the current therapies. So later on, which came the CARB registry, which bifurcated or which kind of evaluated patients with opted medical management with revascularization, which consisted of CABG or PCI in stable ischemic heart disease before major vascular surgery. And it showed that prophylactic revascularization before vascular surgery does not improve clinical outcomes in stable patients. And beyond that, there are various studies which have been conducted which have revealed that there is no significant difference in patients who are revascularized but who are stable at the baseline in comparison to the medical management. So patients, this is just in summation that patients who have got CABG done and who are asymptomatic in the past 6 years, they can be posted for surgery if the surgery is non-urgent without any angiographic confirmation. In patients who have been given BMS, they should wait for at least 4 weeks or minimum for a duration of 3 months. That's a class 2 indication and they can be posted for surgery. Patients who have been given DES in the past, they should ideally be waiting for at least 12 months or minimum for a duration of 6 months before posting for surgery. And patients who have gone under just balloon angioplasty, a minimum duration of 2 weeks is required before the surgical intervention is planned. So here it becomes very clear, patients who have been treated with BMS and who are on DAPT, if you post them for surgery before 30 days of implantation of the stent, it's a class 3 indication that they'll have more MACE and they'll have no net benefit. So you have to wait for minimum duration of 30 days or preferably 3 months. For DET, for DES, for drug-eluting stents, at least 6 months or preferably 12 months should be ideally the time before proceeding with surgery. So there are various, now coming on to the various pharmacological methods like beta blockers, which are very much in use in cardiac patients. So there was this trial, which was the POISE trial, in which 8,351 patients were randomized to metoprolol, succinate, and placebo. And it did show that 17% decrease in composite primary endpoints of myocardial infarction and non-fatal cardiac arrest at 30 days. But this benefit was offset by increase in risk of mortality and doubling the risk of stroke. So coming on to the indications, it says that perioperative continuation of beta blockers is class 1 indications to patients who are already on beta blockers. It can also be considered in patients who have got more than 2 clinical risk factors or American Society of Anesthesiology status of more than or equal to 3. In patients who have got preoperative initiation of beta blockers may be considered in patients who have ischemic heart disease or myocardial ischemia. But perioperative initiation of beta blockers or titration is a class 3 indication in patients who are never on beta blockers. Statins. These are widely prescribed in patients who are at ischemic heart disease because of their plaque stabilization characteristics and also anti-inflammatory pleiotropic effects. They decrease the MACE, especially in individuals who are posted for vascular surgeries and who are having ischemic heart disease. So class recommendations tells that the continuation of statins is recommended for patients who are already on a statin treatment, and preoperative initiation and statin therapy should be considered in patients who are undergoing vascular surgery, and it should be commenced at least 2 weeks before the surgery. Coming to the ACE and ARBs, the data from various studies show that ACE did not decrease any 30-day or 1-year mortality in patients who are continued on ACE and ARBs. Perioperative use of ACE and ARBs also carries a risk of hypertension and acute kidney injury during the perioperative period. So patients who are on ACE inhibitors or ARBs, just for the sake of hypertension, it is ideally prescribed to stop ACE inhibitors 24 hours before the start of surgery. So in patients who are having LV systolic dysfunction and who have stable condition, it seems reasonable to continue treatment, but under close hemodynamic monitoring. So it says the same thing. The patients who are having LV systolic dysfunction, you can continue, but with close monitoring, along with patients who are having stable conditions with LV systolic dysfunction, they can be started on ACE inhibitors to decrease the morbidity and mortality, but that should be at least 1 week before the surgery. And patients who are hypertensive, just for the sake of hypertensive, they are on ACE or ARBs, they should be withhold of ACE or ARBs at least 24 hours before. Coming to calcium channel blockers, there is a significant reduction of number of myocardial ischemia and SVT on patients who are on non-dihydropyridines. And patients who are undergoing acute or elective aneurysm surgery showed that dihydropyridines use was independently associated with increased incidence of perioperative mortality. Patients with heart failure and systolic dysfunction, the continuation and introduction of heart rate reducing calcium channel blockers may be considered in patients who do not tolerate beta blockers. The calcium channel blockers can also be continued in patients who are posted for non-cardiac surgery who have got vasospastic angina, as they are the preferred drug for treatment the same. Coming on to alpha receptor agonist, the POISE trial randomized patients undergoing non-cardiac surgery to clonidine or placebo, and it showed that clonidine did not reduce any rate of death or non-fatal MI in patients undergoing vascular surgeries. On the other hand, clonidine increased the risk of clinically important hypertension and non-fatal cardiac arrest. So therefore, the use stands against these drugs. Diuretics are especially important when we are dealing with the case of heart failure, systolic dysfunction, those who have signs of congestion, but then they are ideally continued to maintain a euvolemic status. But one has to be very alert to look for the dyslipidemia, especially hypokalemia and hyponatremia, which can also adversely affect the outcomes of perioperative surgery. And one important which mandates a cardiological evaluation and very active intervention from the cardiology side is patients who are on oral anticoagulants. As we all know that anticoagulants increase the risk of bleeding during the cardiac surgery and non-cardiac surgeries. So these are, in some patients, the risk of stopping oral anticoagulations will be outweighed by the benefit of anticoagulations. These individuals are the following: those who are having AF with Chatwas score of more than 4, patients who are having mechanical prosthetic heart valve or newly inserted biological prosthetic heart valve, patients who have undergone mitral valve repair within a duration of less than 3 months, patients who have got recent venous thromboembolism, patients who have got thrombophilia. Discontinuation of vitamin K is hazardous, as these patients will need a bridging therapy with either unfractionated heparin or with LMWX, low molecular weight heparin. There is a better evidence for the efficacy and safety of LMWX in comparison to unfractionated heparin for bridging. So it is said that the last dose of LMWX should be administered no later than 12 hours before the planned procedure. And it is recommended that you should stop the patient on YKAs depending upon the half-life, as acetrom has got a half-life of 24 to 36 hours and warfarin has got a half-life of 48 to 72 hours. So you should stop the drugs 3 to 5 days before the day of planned procedure. INR has to be checked daily, unless the INR is less than 2, or maybe if the INR is in the normal range, you can start off with parenteral anticoagulants on the next day after stopping NOACs. When we are dealing with the case of prosthetic heart valves, the recommendations favor the use of unfractionated heparin. As for UHF, we have an antidote and it's a short half-life. So that way it gives the benefit. So unfractionated heparin should be stopped 4 hours before the surgery. And it should be resumed after surgery until the INR is in therapeutic range. One should postpone the procedure if on the day of surgery, if INR is more than 1.5. LMWX or unfractionated heparin is resumed at the pre-procedural dose, that is 1 milligram per kg body weight, twice daily, 1 to 2 days after the surgery, depending upon the patient hemodynamic status and depending upon the bleeding which you are expecting during surgery. Vitamin K antagonist should be resumed on day 1 or day 2 after surgery, depending upon the hemostasis. Low LMWX or unfractionated heparin should be continued until the INR returns back to the normal range. In patients undergoing surgery with low risk of serious bleeding, no change of oral anticoagulation therapy is needed. It is just wise to keep the INR in the lower range and go ahead with surgery. Coming on to the NOACs, now with the very few indications remaining, most of the indications now are approving the use of NOACs in indications where anticoagulation is needed. We have these in the form of dabigatran, rivaroxaban, apixaban, and doxaban. Since these drugs have a very short half-life, a very short onset of action and short offset of action, so breaching is not mandatory in all the cases, except in individuals who are having a very high risk of embolic events and whose surgical intervention is delayed for several days. It is recommended that it is wise to stop the NOACs for at least 2 to 3 half times of their respective biological half-lives prior to surgery in surgical interventions with normal bleeding risk. So it is said that NOACs should be stopped, and then because they have very fast onset of action, resumption of these drugs should be considered in the first or second day on the post-surgical time period. I'll just take just some more time, and I'll briefly discuss 3 conditions which are pertaining to cardiology and which we see across in everyday life. That is chronic heart failure, a well-recognized factor for perioperative and post-operative cardiac events, an important predictor for several risk scores. A reduced LVEF poses a very strong decremental prognostic risk factor for increased MACE. And the prognostic impact for heart failure with preserved ejection fraction has not well been defined. Routine preoperative echocardiography should be considered in high-risk surgical population. However, routine echocardiography is not indicated in every cardiac patient. Preoperative as well as post-operative use of natriuretic peptides has shown of incremental benefit to assess morbidity and mortality during the surgeries. And post-operatively, it tells us the morbidity and mortality at 30 days and 90 days. It is recommended that all heart failure medications to be continued with intra-op hemodynamic status. Heart failure with reduced ejection fraction with LVEF of less than 35%, with QRS of more than 150 being class 1 indication and 120 to 149 being class 2 indication should be evaluated for use of cardiac resynchronization therapy or CRT-D before major surgery. Diuretics are again given for you and maintaining euvolemic status, and patients should be free from congestive symptoms. In a patient who is having a newly diagnosed systolic heart failure with decreased LV systolic function, it is ideally recommended to postpone the surgery for at least 3 months if it is possible. The slides seem the same thing. In case of arterial hypertension, it's a very important prognostic independent risk factor for cardiovascular complications. Meta-analysis have showed that the preoperative hypertension increases by a factor of 35% in cardiovascular complications. One should search for target organ damage and evidence of cardiovascular pathology. In patients who are having grade 1 or grade 2 hypertension, there is no evidence of benefit from delaying surgery to optimize the therapy. Patients who have got poorly controlled blood pressure of grade 3 or more, patients who have got end organ damage that is newly discovered, or patients who have a suspicion for secondary hypertension, they should be the one who will have their surgery to be postponed for further evaluation. Coming to valvular conditions, severe aortic stenosis is a very strong adverse prognostic indicator of perioperative mortality. So in the cases of elective non-cardiac surgeries, the presence of symptoms is essential for decision making. In symptomatic patients, aortic valve replacement should be considered for elective surgery, and in patients who are having high risk, who are contraindicated for surgical AVR, they may be given TAVI for the relief of aortic valve stenotic symptoms. In asymptomatic patients, non-cardiac surgery of low to intermediate risk can be performed safely, but intensive hemodynamic monitoring is required. If high-risk surgery is planned, further clinical assessment is necessary to assess the risk of aortic valve replacement. In those patients with high risk for aortic valve replacement, elective surgery under more invasive monitoring is taken. In the remaining patients, aortic valve replacement should be considered as the initial procedure. Coming to mitral stenosis, patients with non-cardiac surgery can be performed with relatively low risk of who have got non-significant mitral stenosis, who have a valve area of more than 1.5 centimeters square, and in asymptomatic patients who have got a systematic pulmonary artery systolic pressures of less than 50 millimeters of mercury. In asymptomatic patients with significant mitral stenosis with a valve area of less than 1.5 centimeters square and with a pulmonary artery pressure of more than 50, the patient need non-cardiac evaluation. The patients who may need for these patients may be the ones for percutaneous mitral valve commissurotomy before high-risk surgeries. And for aortic regurgitation and mitral regurgitation, non-significant AR and MR do not independently increase the risk of cardiovascular complications. So asymptomatic patients can be posted, even if they have severe AR or MR, they can be posted for surgery without any additional risk, as it can be easily tolerated. But patients who have got severe regurgitations along with impaired LV systolic function are the ones who have high risk, and they are the patients who can be given aortic valve replacement or annuloplasty, and they need pharmacological therapy optimization for the control of symptoms and decrement of regurgitant lesions before posting them for surgery. So this is in brief how we evaluate the patients of common cardiac conditions, and this is how we go about perioperative evaluation and decrement of the MACE so as to have a better outcome. And
Wasim, you are requested to stop your presentation. You have already exceeded time. I now request Dr. Pankaj to start his presentation. Thank you for your wonderful presentation, Wasim.
Thank you, sir. Thank you, sir.
Dr. Pankaj is senior resident in the Department of Cardiology of Guwahati Medical College. So he will be speaking on the right ventricle. I request Dr. Pankaj to complete his presentation within 10 minutes. Dr. Pankaj, please go ahead.
One second, sir. Am I audible? Am I visible? My skin is visible. Good evening to my respected teachers and colleagues. Today I'm going to present anatomy of the right ventricle and assessment of the right ventricle function by echocardiography. Am I audible? Can I go ahead?
Please go ahead, Dr. Pankaj.
Okay, thank you, sir. Thank you, sir. As we know, the right ventricle is a low pressure working condition and complex geometry in comparison to the left ventricle. And earlier work by the Star and others showed that the RV is a passive conduit with the minimal pumping capability. But with the advent of the three-dimensional echocardiography and MRI, we have gained insight into the complex geometry of the RV. As far as the anatomy of the RV is concerned, RV is a thin-walled crescent separated structure, and it is coupled to systemic venous return on one side and the pulmonary circulation on the others. It is 10 to 15% larger in volume than the LV with a thinner free walls, and about 1/3 to 1/6 is smaller in mass. RV can be divided into the anterior, lateral, and inferior walls as well as the basal, mid, and apical segments. So this is the view in which we can see the inlet inflow tract and the apical trabecular part of the RV as well as the infundibular part of the RV. The three parts are there. The inlet includes the tricuspid valve, the tendinous cords, and three or more papillary muscles. The trabeculated apex is very thin, and the outlet or infundibulum, also known as the conus, this is the tubular muscular structure that supports the pulmonary valve leaflets. The size of the infundibulum accounts for approximately 20% of the diastolic volume of the normal right ventricles. So this is uniformly right ventricle has the special characteristics. It is uniformly coarse trabeculations. The multiple papillary muscles, usually more than 3 are there. It has got the moderator bands. The tri-leaflet atrioventricular valves with a septal leaflets that is apically displaced compared with the anterior mitral leaflets, and the muscular outflow tracts are there. In the myocardial architecture, there are 3 distinct myocardial layers of the aggregated cardiomyocytes. However, no proper middle layer can be defined in the RV. The superficial layer, it comprises of 25% of the wall thickness, and it has got circumferential aggregates parallel to the atrioventricular groove, whereas the subendocardial RV layers is having the longitudinal myocytes. The myocytes passes through the apex towards the papillary muscles, tricuspid annulus, and the RV outflow tract, and are continuous with those of the septum. RV and LV are closely interrelated, and they share the epicardial circumferential myocytes and the pericardial space. That's why there is the interrelated. This interrelated arrangement constitutes the anatomical basis for biventricular functional systolic and diastolic interdependence. There is also differences as far as the embryological origin is concerned in between the LV and RV. The first heart field, they constitutes the left ventricle, muscular IVS and atria, whereas the second heart fields, they forms the future right ventricles, most of the membranous interventricular septums and outflow tracts. So as we know, at birth, the RV is the predominant chambers, and by the age of 1 year, when the pulmonary vascular resistance decreases rapidly, the RV valve thickness regresses, leading to the normal cardiac morphology with rightward septal convexity. As far as the normal structure, metabolism, and perfusion of the right ventricle are concerned, they are different from the left ventricles, as the right ventricle cardiomyocytes are approximately 15% smaller than the LV cardiomyocytes. And despite higher compliance and probably because of the small myocytes, the RV also contains 30% more collagen fibers. Energy sources for the contraction in the RV is also with the fatty acid oxidation, and few studies which was done in the rodent models, they suggest expression of the anaerobic glycolytic enzymes which are higher in the RV cardiomyocyte, which can explain the relative RV resistance to ischemia. Blood supply of the RV has distinctive features in comparison to the LV. The resting coronary blood flow and conductance are lower in the RV, and coronary blood flow occurs both in systole and diastole in the RV. RV perfusion is more vulnerable to increased RV cavitary pressure and to the systemic hypotension. RV has also got a lower O2 consumption and extraction at rest than in the LV. RV increases oxygen consumption during exercise through increased oxygen extraction rather than the coronary blood flow because of the impaired autoregulations. So the majority of the individuals, 80% have the right dominance, the lateral wall is supplied by the marginal branch of the RCA, and the posterior wall is supplied by the posterior descending artery. Anterior wall and the anteroseptal regions, including the RV apex, they receive the blood flow from the LAD. And perfusion of the RVOT originates from the conus branch with a separate origin in 30% of the individuals. So as a result of this, the RV apex is often spared during RV infarctions or in acute massive pulmonary embolism with the RV strain, as we see in McConnell signs. And LAD infarctions or anterior infarctions can also involve the RV apex. So RV contracts in a highly synchronized fashion that occurs 20 to 50 milliseconds earlier in the sinus and the apex than the conus, resulting in the peristaltic-like motion. Conus acts as the buffer against high systolic pressure being transmitted to the pulmonary artery due to its late contraction. Helical flow develops in the outflow may also contribute to better flow stability into the pulmonary artery. And data suggests that flow patterns within the RV are relatively streamlined, following a smooth curved path from inflow to the outflow along the septum, largely circumventing the apex. Here we can see the streamlined motion which comes from the inflow and going to the outflow. So we can see the right ventricle acts as a conductance pathway, and there is interventricular dependence are also there. The left ventricle acts as the left ventricle contributes to 20% of the RV ejections. Coming to the guidelines of the echocardiographic assessment of right heart in adults, as given by the American Society of Echocardiography, it describes the acoustic window, the parameters of the RV size and functions, and the advantage and disadvantage of each measure's techniques. The recommendation of the right-sided measure should be included in the echocardiographic reports, and it also provides revised reference values. These are the basic views. We can see here are the parasternal long axis view, the parasternal long axis view of the RVOT and pulmonary artery, and the parasternal long axis view of the RV inflow view, and short axis view at the basal right ventricles, the parasternal short axis view at the bifurcation of the pulmonary arteries, and the parasternal right ventricle short axis view at the mitral valve levels, parasternal right ventricle short axis at the papillary muscles level, and the apical 4-chamber views, RV focused apical 4-chamber view, RV modified apical 4-chamber view, RV apical 5 chambers view, and apical coronary sinus view should be used to assess the right ventricular structure. In subcostal view, we can go for the RV subcostal 4-chamber view and the subcostal short axis view at the basal right ventricles.
Dr. Pankaj, you are requested to complete your session within 2 minutes. Dr. Rituparna is waiting for his presentation.
2 minutes, sir. Sir, right ventricle dimensions can be, we can measure the right ventricle in the at the basal level, at the mid level, and the right ventricle long axis level. Whenever there is the basal right ventricle diameter is more than 4.2 centimeter, it indicates dilatations. In the mid cavity, when there is more than 3.5 centimeter, it indicates dilatation. And when the RV longitudinal dimension is more than 8.6 centimeter, it indicates RV enlargement. There are a few advantages and disadvantages of each and every views, like the RV linear outflow diameters. We can have the RVOT proximal diameter, which is usually 25 plus 2.5 millimeter. Our RVOT proximal diameter in the short axis view is 28 plus 3.5 millimeter, and RVOT distal diameter is 22 plus 2.5 millimeter. But every view has certain limitations, like whenever we go obliquely and whenever there is skeletal deformity, we can't measure the dimensions appropriately. We can also go for the RVs area, including the by the planimetry method of the RV, and by the three-dimensional echocardiography, we can also measure the RV volume very accurately. And as it has been compared with the MRI, there is a good specificity and sensitivity of the 3D echocardiography as far as the RV volume is concerned. We can also measure the RV wall thickness in the subcostal view. We can also go for the RV function by the echocardiography. RV function of the echocardiography by the pulse Doppler myocardial performance index. We can judge the global function of the global function of the RV using the pulse Doppler. We can go for the
Thank you. I'd like to request Dr. Rituparna to start his presentation. We are going to have an interactive session on case presentation. Dr. Rituparna is a senior most faculty. He is a senior cardiologist of Northeastern region. He is working with Apollo Hospital, Guwahati. So he will have an interactive session with our postgraduate students. He will be presenting few cases. I request Dr. Rituparna to start his presentation. Thank you.
Thank you, Farin. Thank you, organizing committee, for giving me this privilege to speak on this forum. And what will be my time allotted for me for my presentation? Dr. Farin. Your voice is not coming. Hello.
Sorry. Dr. Rituparna, we have around 40-45 minutes time, so you can go ahead. For at least 40 minutes time we have.
Thank you so much. My slides are visible.
Yes, your slides are visible. Like to remind all our postgraduate students, this is an interactive session, and if you want to ask some question, you can put it in your chat box, or you can ask him directly.
Yeah. So anybody who wants to clarify certain clinical issues or regarding this this sort of intervention, so you can stop me at any time, and then we have some good discussion. So my presentation is to recognize and to know.
We cannot.
The classification and clinical assessment of the bifurcation lesion. As you know, the European Bifurcation Club, it is one of the strongest clubs that have all these clinical data, interventional data on bifurcation lesion. And this club defines a bifurcation lesion as a coronary artery narrowing occurring adjacent to or involving the origin of a significant side branch. So you have the three basic branches. I can say that vessels. This is one of the mother vessels, and one is distal mother vessel, one is the proximal mother vessel, and one is the side vessel. So these are the three important landmarks of the bifurcation lesion. And this is the most widely accepted classification system. We call the Medina classification system, and it is very easy to remember. So it basically concentrates on the proximal main vessel, distal main vessel, and the side branch. So if the stenosis of the side branch or the main vessel is more than 50%, we consider it to be 1, and then if it is less than 50% stenosis, we consider it to be 0. There are various classification systems. These are very cumbersome, so we do not remember all this classification system. But in clinical practice, we usually utilize this Medina classification system. So this picture defining different types of bifurcation lesion as defined by the Medina classification. So the true bifurcation lesion is that the main branch and the side branch both are significantly narrow. We call it Medina 111 classification. And if the stenosis is less than 50%, we consider it to be 0. So there are two basic types of bifurcation. One is non-true bifurcation, so there is not significant involvement of the ostium or within 3 millimeter or not beyond the ostial stenosis in the side branch, or the osteoproximal disease in the side branch is not beyond 5 millimeter of the side branch. So we call it a non-true bifurcation. But the only problem or limitation of this classification system is that it doesn't give the insight of the lesion length, particularly in the side branch, and also certain angiographic features which may be very important during the interventions are classification or bifurcation angle. For example, if the bifurcation angle is very narrow, we call it the eyebrow sign. So in that situation, there might be high chances of carinae shift or the black shift or the pinching of the side branch. So all these certain important informations are not described in this Medina classification. But during the procedure, while doing the interventions or bifurcation lesion, we need to understand in depth or in details of these different anatomical aspects and also the physiological aspects of the bifurcation lesion. So European bifurcation club basically concentrating more on this MATS classification in the recent years. So M stands for the stent implantation in the proximal main vessel. A starts with stenting of the proximal main vessel and to distal main branch. That means there is stent is placed across the side branch ostium, and B stands for involvement of the distal branches, and historically it starts with simultaneous stent placement at the ostium of both distal branches. We commonly call it as de-stenting. And the different strategies we basically adopt to do bifurcation stenting in true bifurcation lesion. And whether we place the stent exactly at the ostium of the side branch or we just pull the stent proximally so that there will be 1 or 2 millimeter protrusion to the main vessel from the stent that is deployed in the side branch. So here you can, this picture you can understand this different strategies we adopt in bifurcation stenting technologies. So the stent is deployed in the main branch, and then 2 stents deployed in the distal main branch and the side branch. So it is like extended B. And this is a very commonly utilized method of bifurcation stenting. And here we place the stent across the side branch ostium from the proximal main branch to the distal main branch, and the stent sizing is dependent on the distal size vessels, and accordingly, once the stent is placed across the side branch ostium in the main branch from this distal to the proximal across the side branch ostium, then we do what it is called proximal optimization. And so that in the proximal optimization strategy, we take 1:1 ratio of the balloon size to the vessel size in the proximal main branch. And while selecting the stent, we always select the distal main branch diameter. So, for example, if the proximal main branch diameter is 2.5 millimeter and the distal is 3 millimeter, so we take the stent size as 3 millimeter, and then for proximal optimization in the main branch, so we take 2.5 NC to dilate to the nominal ratio. So this is the commonly adopted strategy while doing the bifurcation lesions. There are various types of technologies or techniques we use during the bifurcation stenting. So there are classical T-stenting, there might be reverse T-stenting, there's modified T-stenting, and TAP that is commonly used, T and the protrusion. And the culotte technique is very important, and the main and the key point to understanding culotte technique is that we have to deploy the stent from the main branch to the side branch, and in particular those bifurcation diseases where the sizes of the main branch is almost equal to the sizes to the main branch. So that means in all this situation we cannot apply this culotte technique when the branches are bigger and it is almost comparable in size to the main branch. So in that situation we can use the culotte technique. The cross technique is there are different types of cross technique: the classic cross, the mini cross, the nano cross, and the reverse cross. So there are different types of cross technique. In my cases, at the end of this discussion, you can understand what is cross technique. So Kuloti, as I already described, that both the branches of equal size and it should be of good size, and the angles between this distal main branch and the side branch is narrow. And the decay cross is usually cumbersome, but in the trials or in the randomized control trials, this decay cross technique is showing the minimum restenosis rate in bifurcation stenting. FNT is T protruding, and CAP techniques or the T stenting are very commonly used, and it can be done in a faster way. And particularly in the bailout situation, when you intended to place the stent across the sideburns ostium, and suddenly you saw that the sideburns got pinched up, and then in those situations, we commonly use this CAP technique or T stent. And even in 6-trans guide also, we can commonly utilize this technique for the bailout. So important is that you should know the anatomy of the side branch, how big that particular side branch is, and then what is the significance of this stenosis. And the significance stenosis we define at more than 50% of the diameter stenosis in the side branch. And we call it the diffuse. It is if the side branch is involved from the ostium to at least beyond 5 millimeter by the atherosclerotic process. And whether this side branch is suitable for stenting or not is very important. So one important aspect is the diameter. So if the diameter of the side branch is more than 2.5 millimeter, it's considered to be large vessels, and then that means it actually supplying a very good amount of good myocardial territory. And while jeopardizing this side branch may lead to significant ischemic damage. That is why it is very important to, before starting the two-stent strategy, to exactly know the anatomical details of the side branch. Finet's law is very important, and you this in the learners and in the beginners, they should understand the Finet's law. So Finet's law, the left main is the two-third of the summation of the distal main branch and the side branch. So this is the Finet's law. So while during the angiogram, you can actually predict the sizes of the stent, because if the leg main, if the size of the distal leg main is near about 4 millimeter, and then if the L6 is 3.5 millimeter, and then in this situation the LID must be 3 millimeter or more than that. So applying the Finet's principle, we can actually choose your stent and what type of balloon, what is the diameter of the non-compliant balloon you can utilize or use during the post-stent dilatation is very important, because the stent expansion must be adequate. Otherwise, there will be high rate of stent thrombosis or restenosis after the bifurcation stenting. Anywhere in bifurcation stenting, the restenosis will be significantly high compared to the one-stent strategy. So in that situation, the adequate bed preparation of the coronary arteries and choosing the right size stent is very crucial for optimum result of this bifurcation stenting. So it is difficult to do bifurcation stenting. So initially we start with the one-stent strategy. The crossover strategy is very important, because in majority of the patients with bifurcation disease, we can resort to the crossover one-stent strategy. Otherwise, in those situations where the size of the side branch is more than 2.5 millimeter, and then it supplies a larger amount of myocardial territory. So in that situation, and there is a high risk for side branch occlusion or plaque shifting or canal shift. So in those situations, we from the beginning onwards, we start the two-stent strategies. So this bifurcation anatomy is highly variable, and the site of bifurcation is very important, whether you are dealing with left main bifurcation or LAD diagonal bifurcation, or whether you are dealing with LCX or distal L6 bifurcations are very important. Obviously, the left main bifurcation bifurcation are very risky and very critical disease. So we need to understand the anatomy and physiology of this bifurcation diseases. And you should understand the angle between the branches, whether it is more than 70 degree or less than 70 degree, but it depends on the carinal shift and the flat shift or side branch occlusion. And also important the size of the branches. So what type of devices you are using, whether you are dealing with a calcified lesion. So in that situation, you have to debulk the calcium with calcium debulking devices like rotablation. Or nowadays, you know that the intravascular lithotripsy has been widely accepted in the coronary intervention. So, and that is why the calcium debulking and adequate bed preparation is very important before doing this bifurcation stenting. I want to show some of the cases I have done in my clinical practice. Before that, this recently, 21, the BBC actually published their document on bifurcation strategy. They have adopted that they, and also endorsing that the crossover strategy with a single stent is most vital while doing the bifurcation strategy, and because the restenosis rate and the stent thrombosis rate or target basis failures is lower in single stent strategy compared to the two stent strategy. So that is why in the clinical setting, before starting this bifurcation stenting, we should exactly know the size, its length, and the territorial supply of the particular coronary artery, co-arterial supply, and the viability of the myocardium is very essential. As I already discussed, this presence of thrombus, whether you are dealing with a case of acute coronary syndrome or chronic coronary syndrome, this is very important in the presence of calcium and fibrosis, because nowadays we are doing bifurcation stenting with an imaging guided technology, and that actually helps you what the amount of calcium, what is the arc of the calcium you are dealing with during the bifurcation stenting. And the access to the side branches are very important. And then, as you know, that while accessing or rewiring to the side branches, we should always try to select the distal struts of the already deployed stent, and that is why so the carinal shift will be less and the neocarinal formation will be less. And accordingly, you have to select the different guide wires, hydrophilic or non-hydrophilic wires, and the balloons, whether as you know, the drug-eluting balloons to roll in bifurcation stenting is quite limited. And then the recent trial is showing that the restenosis rate or stent thrombosis rate were not significantly prevented by using the drug-eluting balloons. This is not very important. We always, whenever we try to go for a bifurcation stenting, we have to deploy the stent across the main vessel is proximal to the distal end, and then we try to do POT, the proximal optimization, so that we can adequately dilate the proximal stent in the main branch, so that we can rewire the side branch. Once your bifurcation stenting is completed with the kissing balloon, then you have to do again re-POT. So this is the final POT, so that you can take that your stent defining situation can take this shape of the circular rather than an elliptical shape. And this is one of the important, while using the POT, your balloon position should be just at the carina. It should not be beyond the carina or very proximal to the carina. The balloon tip for the proximal optimization, the distal tip should be at the carina. Otherwise, there will be stent deformations or there should not be adequate POT. So this is very important, and it is actually very well described in this recent 21 BBC statement. So let us first go to the cases. This is one 57 years case, and you can see there is clearly significant stenosis in the LAD and also in the D1. So as I already described, that it is a true bifurcation lesion, because in the you can see the side of the diagonal is quite good size, and it is actually supplying a good amount of myocardial territory. And that lesion actually extends from the ostium of the diagonal beyond 5 millimeters. So it is a true bifurcation lesion. So we opting for two-stent strategy. So you can, this is more clear in this picture. So this is LAD near about 70 to 80% stenosis, and the diagonal is near about 80 to 85% stenosis in the fluoroscope. So we, because the ostium of the diagonal is very significantly diseased, so we thought that while deploying the stent from the left main, from the main branch to the distal main branch, can sit the plaque, and there might be this diagonal might be occluded. So considering that, we actually dilated the lesion into 2 by 10 millimeter balloon, and then we again dilated the LAD, which is 2.5 12 millimeter NC balloon for adequate bed preparation of the body vessel. So then after that, we deployed the stent and swinging the side of the stent based on the distal LAD diameter, and then we did pot so that the proximal part of the stent can be well expanded, and that actually helped. Once you do the pot, the proximal LAD, that actually open up the stent cells, because most of the stents are nowadays become hybrids, and then so it opens up these stent struts, and then it will be easier to recross or rewire the side branches. So then we take a 2 millimeter balloon. Actually, we crossed over. We pull back the LED wire, and then we try to cross the side branch ostium, because that's a good technique, because while pulling out the LED wire, so and you can try to wire or to get through the struts of the distal stent struts. So that is what the recommendation. And then, or sometimes it is very difficult to rewire the side branch. You can take the help of the hydrophilic wire like Whisper or Fielder XT, where that actually you can glide that hydrophilic wire across the strands. But important is that while doing this, try to rewiring the side branch so you maximize the fluoroscopic image, and then so that you can visualize the stent struts quite clearly. And then we place one NC balloon, because we took this is a semi-French guide, so any bifurcation relation, it is better to take a semi-French guide. Otherwise, you may not get a good amount of rooms inside the guide catheter, so that because we have to negotiate a lot of devices, balloon stands, and multiple balloons, multiple wires. So in that situation, I think 7 French is the ideal guide catheter size while doing the bifurcation scan. But in certain cases where bailout, if you are dealing with a case of acute coronary syndrome, and actually you have taken a 6 French guide, and sometimes you see that your side branches get occluded. So in that situation, to bail out or to make the process very quick, so you do not have time. So with 6 French only, you can do the T stenting or the tap stenting, because these are very important, or you can do very rapidly during the bailout situation. So this is the final piecing after the diagonal stand. Once we place the diagonal stand, and then we cross with the balloon. So what we did actually, this is a reverse mini cross technique, and then the final piecing is very important, because final piecing is mandatory in any bifurcation stenting. And after that, we did the repot in the proximal part of the LED, so that we can make the stand more circular rather than elliptical, because if you use 2 balloons during the pitching, and then it actually makes the proximal part of the stand elliptical rather than circular. So that actually deforms the stand. So to make to bring back to this original circular form. So you use V port for the final port so that the osmosis rate and the stand thrombosis rate increases. So finally, we get quite decent result in this case, and so this is the final result. So you can see that both the stands are well expanded. And the second case, this is another case, 53 years patient. So this is what happened in this particular case is that it was very difficult to wire the distal part of the LAD. So initially I thought it will be easier, but while trying to negotiate the wire across the lesion, I found it very, very difficult. So I thought that there might be some CTO segments that is where it was very difficult. So we took a CTO wire, and then the rest of the things became easy. This is a very sick patient. The ejection fraction was 25%. So we were very scared at the time that the patient might develop acute pulmonary edema or patient might collapse. So we tried to do the procedure very fast. So actually, you can see first we wired both the diagonal and the LAD, and then we tried to balloon both the vessels. We prepared the vessels in both the diagonals and the LAD, and then we first placed the LAD stand, because the LAD is the most important vessel in this situation, because if you knock down the LAD, it is not going to survive. So first you have to, most important during the bifurcation stamping is that you have to save the main vessel. And then we parked the balloon non-compliant. After first I standed this LAD, and then I parked a non-compliant balloon in the distal, and then we placed the diagonal stand. So this is the diagonal stand we placed and deployed, and then I put back this NC balloon from the main branch and this semi-compliant balloon of the stand, and then we did the kissing. So actually, we can do this procedure in fast, because it is very important, because patient is if we take longer time during the process, the patient might develop ischemia. That ischemia can lead to acute pulmonary edema. So you have to be very fast. Otherwise, if you have end up intra-aortic balloon pumping or impeller device, so in this situation we can do for protected PCR. But because we do not have this impeller device, so it is why we wanted to do it as fast as possible. And I think this is the best way with the tap technique or the T-standing in bailout procedure, or in this situation where you want to do bifurcation stenting in a quicker way. This is another case where actually you can see that here we use Pelosi because the leg main size and this LCX almost of comparable size. So that's why I thought that we'll either select this Pelosi technique, and then accordingly we prepared the lesion, and then we deployed the stand from left main to LCX. And it was a 3.5 synergy stand, and then after deploying the stand, we did the pot, and then we crossed the LAD, which are hydrophilic wire. And then usually what in my clinical practice, because the hydrophilic wires like whisper and this filter exchange wires are very notorious for perforation, particularly the distal small vessel perforation. Whenever I try to use this hydrophilic wires, I always do it with the support of the microcatheter. So we take the microcatheter and then we accelerate a normal floppy wire like BMW or Xion. So we dilated the lesion, and then we crossed the wire, and then we dilated the struts gradually. While dilating the struts or try to negotiate any kind of stands or devices across the stand struts, we actually goes slow. And we do graded dilatation of the strand, starts with a 1.5 millimeter balloon, then 2 millimeter, and then NC 2.5 millimeter. So we will expand the strand so that it can take this strand, that radiating strand across the strand structure. So the lesion preparation and the dilatation of the strand strut across the side branch is very, very crucial for successful bifurcation stamping. Otherwise, any device or any balloon or stand it will be very difficult to negotiate across the stand struts in the main section. So here we place the stand just a reverse kind of that technique, and then we deploy the stand, and finally so we do DPC. So we there's a good result at the end. And this is the last case I want to show you. So here it was total occlusion of the LED, and this patient actually 45 years, male patient, is a chronic smoker and presented with unstable angina. And then while doing the angiogram, the LED was almost optical occlusion, and it's very difficult to negotiate where. So I did the support of the with the support of the microcatheter, we actually cross the lesion, and then we exchange it here normal floppy wear. So that this is a diagonal, good size diagonal. And then first, this is the mini cross technique. We actually deploy the stand in the side branch, and then we cross the side branch stand with the LED stand, and then we cross the struts of the LED stand towards the side branch stand, and then we dilate it gradually, and then finally the piecing is done, and then at a good result at the end of this bifurcation stamping. So to summarize, the bifurcation stamping is very crucial, and then we have to be very careful with what kind of strategy actually you want to adopt. Whether you want to do a single stand strategy or a double stand strategy, it is better so that you can predict it before starting of this PCI. But in certain situations where you have to do some bailout procedure, suddenly the side branch osteum gets pissed off. So in that situation, you have to bail out with the help of the teeth stanting or test stanting. But in the majority of the cases, so you should be able to predict whether you are going to place 2 stands or 1 stand strategy. That is why the DC, they say that the most important strategy while adopting the bifurcation lesion is that single stand strategy, because in clinical data, there's robust clinical data exists that the bifurcation standing, bifurcation lesion dealing with a single stand strategy, it gives good clinical outcome compared to this 2 stand strategy. But if you can adopt 2 stand strategy right before the procedure, before the PCI, so you have to exactly know the anatomical details and the physiological details of the side blocks. Thank you for your attention. If you have any questions, I would love to take.
Yeah, Dr. Rituparna, we had a very wonderful presentation. I request our postgraduate student, BM student, to kindly interact with him. If you have any question on the bifurcation stenting, please go ahead and ask him directly. It's a teaching program. Our postgraduate student, please interact with Dr. Rituparna and ask anything you want to ask.
Hello, sir.
Ritu, wonderful talk. Thank you for your.
Ritu, sir, can you hear me, sir?
Yeah.
Can you hear me? Am I audible?
I can hear you, but you are some echoes.
Am I audible?
Yes, sir.
Sir, I wanted to ask one question, sir. So patients left main bifurcation and who have got unstable
Wasim, please unmute.
Can you repeat the question, please? Can you repeat the question?
So the question was a patient who is having acute coronary syndrome and evaluation shows that he is having a left main bifurcation lesion. So what is the preferred methodology for revascularization in such patients, sir?
So if the patient is hemodynamically unstable, so in that situation, I think we can adopt the revascularization that we can do in a faster way. So because this discussion is basically for bifurcation stenting, I think if this patient is hemodynamically collapsing in that situation, we will try to go for the STS because that actually gives the fastest method. You wire both the sex and the LED, and then you dilate and then put it two stands across, and they simultaneously dilated both the stand and deploy the stand because if the patient is hemodynamically collapsing in that situation. But if you have some time, so I think in that situation you have to consider the certain anatomical details of the patient, like the angle, the left main bifurcation angle, the sizes of the left main in comparison to the LED and the LCX, and because these anatomical details are important. So if you have some time, so in that condition, I think the mini cross will be a better method because the decay cross will be very time consuming, so it will be difficult in acute coronary syndrome. Otherwise, if you don't have much time, but patient is not hemodynamically collapsing, so in that situation, I think if you have a good angle, good bifurcation angle, so in that situation, I think tap or maybe teeth stenting may be a good option.
Thank you, sir.
Ritu, wonderful talk. Very well spoken. Would suppose in acute scenario or versus a chronic scenario, would your approach differ in case of, say, for example, distal left main and LED insert?
In acute situation, if we do not have time, then if the angle is favorable, so in that situation, I think T standing over the tap is good. And mini cross may be a good option if you have a good amount of time. But in chronic, because we need to look into the outcome of the patient is also very important, long-term outcome of the patient. So as the restenosis rate and the stent thrombosis are numerically less in the decay, so I think the decay cross technique may be chosen in the chronic situation.
Okay, thank you.
Thank you, Rituda. Wonderful presentation. Now we'll prepare for the inauguration ceremony. We are going to start the inauguration at 4 p.m. Dr. Anup Varman, our CPS, has already joined. So we have another 5 minutes time. We will be starting the inauguration ceremony at 4 p.m. straight. Thank you, Dr. Varman.
अभी देख लीजिए एक बार।
আধাতকৈ কম এইটো
মানৱ মই ইয়াৰ পৰাই জয়েন কৰিলো
ঠিক আছে নীলা হ'ব ওয়েলকাম নীলা ওয়েলকাম
Hello. Good afternoon. Am I audible?
Good afternoon.
Good afternoon. Audible, no? I am audible.
Yeah, clear, loud and clear.
Your voice is echoing.
I think I can start. Hello.
Sanghamitra, can we start now?
Yes, we can start, but your voice is echoing.
Voice is echoing.
Echo first.
Sanghamitra, can you hear me now? Is it still echoing?
Sanghamitra, are we audible?
You're audible with a slight echo, but it's okay. You can hear.
Deepak, good afternoon. Welcome.
We can start.
Very good evening, everybody. Today, as we all know that because of the COVID pandemic, we couldn't start our academic program of Northeast Cardiology Society of India. So we have now decided to hold a virtual event, and we are very thankful to all our supporters, all our group members who has encouraged us to do this.
And now we have assembled to do the inauguration ceremony. For the inauguration ceremony, I would like to thank Professor Anup Kumar Barman, he is the Director of Medical Education, to give his kind consent for the inauguration ceremony. I now request Dr. Anup Barman sir to join the inauguration ceremony. At the same time, I would like to request Professor Pranab Bhattacharya, my guide, to join the inauguration ceremony. And also, I would like to request Dr. Omya Sharma, CSI NE President, and Dr. Neil Bodwell, President, CSI NE elect, and Dr. Deepak Sharma, who is the EC member of Cardiology Society of India, to join the inauguration ceremony. Now, I would like to request Professor Pranab Bhattacharya, who is the head of the Department of Cardiology and the organizing president, to give his deliberation. So, good afternoon to one and all. And first of all, greetings from the organizing committee. And we are indeed privileged to be able to host this cardiology update, Northeast Cardiology Update 2021. And this time we are co-hosting with the Northeast chapter. We as Department of Cardiology, Guwahati Medical College, along with CSI Northeast chapter, we have organized this two-day meeting, and I hope it will be a huge academic fest and benefiting all the practicing physicians, the postgraduate students, and one and all belonging to the medical fraternity. And we are extremely happy that we can hold this meeting this year in a virtual format, because unfortunately last year, due to the COVID pandemic, the Northeast CSI annual conference had to be cancelled. And so this year we have organized the Northeast CSI update in a virtual format. And this two-day academic feast, I hope we have will be beneficial. And as we have a galaxy of esteemed regional and national speakers, and as national faculty, we have 7 well-known cardiologists from all over India, and which include Dr. P.P. Mohanan, he is the President of the Cardiological Society of India. We have Professor K.K. Talwar, who needs no introduction, and he was the Professor and Head of Cardiology AIMS, as well as Director of PGIMER Chandigarh, and along with it, he is also a Padma Bhushan awardee. Apart from these people, we have Dr. M.K. Das, who is the past president of Cardiological Society of India 2019-20, and an esteemed national speaker. Apart from him, we have Professor Rakesh Yadav, we have Professor Rohit Manoj Kumar from PGI Chandigarh, and we have with us Dr. Manoj Agarwal from Hyderabad, who's going to conduct the prize money CD presentation, which we have organized this time. And last but not the least, we have Dr. P.C. Dutt, who's going to deliver one of the invited guest lectures. So this is in just a brief about the program. And we have 3 sessions, very interesting sessions. One is an open house prize money quiz competition, and that should be quite interesting. We have, as of now, a lot of registered participants for the open house quiz program. We will have a preliminary round from where those who qualify will go to the final rounds. And this will again be a prize money open house quiz competition. Apart from the quiz competition, we have the prize money CD presentation combination, and also the scientific paper presentation session, which will also be a prize-winning event. So overall, I think this should be an extremely good academic activity lasting for 2 days. And most importantly, this time, this 2-day CME program has been accredited by the Assam Council of Medical Registration, and all the registered delegates as well as the esteemed speakers will be receiving CME credit points. And so I think without wasting any further time, I would like to now proceed to the lighting of the lamp ceremony. And for this, I'd like to invite our chief guest for this evening's inaugural ceremony and for this 2-day Northeast Cardiology Update 2021 Guwahati, Professor Anup Kumar Burman, who is the Director of Medical Education, Assam. And sir has already joined us well in advance for this program. Welcome, sir, and your presence has really will really encourage each one of us. Next, I would like to welcome Dr. Omiya Kumar Sharma, who is the President of Northeast CSI, the CSI chapter. So, Omiya, I hope you are here. Yes. And next, Dr. Farin Iqbal is here. He is the Organizing Secretary for this Northeast CSI Update 2021. And then we have Dr. Neil Bordoy, who is the President-elect of Northeast CSI. Nilda, welcome to this inaugural ceremony. And last but not the least, we have Dr. Deepak Sharma, who is the EC member of Cardiological Society of India. And welcome, Dr. Deepak Sharma. So I would like to request Sanghamitra to please start off with the lighting of the lamp ceremony, followed by the Saraswati Vandana.
तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहार धवला.
Thank you, Sanghamitra, for this auspicious playing of the Saraswati Vandana and the lighting of the lamp. And now I would like to request our President CSI Northeast Chapter, Dr. Omiya Kumar Sharma, to kindly address the gathering. Omiya, please.
Respected chief guest of this inaugural program, the professor and head of the department. Am I audible?
Yeah.
You're audible, sir. You're audible.
Yeah. Respected this chief guest and director of medical education, Professor A.K. Burman sir. Then our executive committee member, CSI head office, Dr. Deepak Sharma. Then Dr. Neil Bordoy, the president-elect CSI Northeast chapter. Professor P.J. Bhattacharya, president of the organizing committee. Northeast Cardiology Update 2021, a good friend of mine. Dr. Parin Iqbal, organizing secretary and secretary of this cardiology update, Northeast Cardiology Update. My respected teachers, my seniors and juniors, and my dear colleague. First of all, a hearty welcome on behalf of CSI Northeast Chapter to all of you. It's a great occasion for Cardiological Society Northeast Chapter. We know that this it is a very challenging time for all of us. The same type of meeting we organized last year, but because of the COVID pandemic, we at the last moment we had to cancel it. This time, in spite of all the difficulties and the challenges, we are again holding this meeting in a virtual form. I'm sure this meeting will be very much informative because a galaxy of speakers from various parts of India are joining. At this moment, I express my deep condolences for those frontline workers and my health workers and doctors colleague who sacrificed their life while rendering the greatest service to the humanity during this COVID period. And I must congratulate this doctor fraternity especially, and the medical fraternity, and those who are the frontline workers, medical and health workers, who are fighting or who are sacrificing their health to fight this COVID pandemic. We know that our fight is still not over, and I request to keep their morale high. This meeting has been held by these companies also, and at this context, I must compliment my friends from Guwahati Medical College Cardiology Department, this led by Professor Dr. P.J. Bhattacharya and his team, who has nicely organized this program for the benefit of all our delegates, and they have arranged for this credit hours from Csi Ne credit hours for this meeting also. This is a great achievement, and they have turned no stone unturned to keep this or to make this function is a very informative. There are wide participation of papers and this wide participation of speakers from various parts of India. So I am sure this meeting will be very much this informative to us, and it will be benefited. So on behalf of Cardiological Society of India, once again, I thank all of you, and especially our esteemed guest who has spent time and joining in this meeting. And also I thank all the these delegates who are joining this meeting by the this virtual way. I hope this meeting will be, and wish that this meeting will be very much successful. Long live CSI, long live CSI Northeast Chapter. Thank you very much for giving me this opportunity to speak in this auspicious occasion. Thank you very much.
Thank you, Amita, for your very nice address to the gathering. Now I would like to request Dr. Deepak Sharma, EC member CSI, to kindly address the gathering. Deepak, please.
Thank you very much, Pranav, for asking this meeting, though it is impromptu. Anyway, I think Dr. Burman, the DME, the organizing chairman, Pranav Bhattacharya, Professor Parin Iqbal, the dynamic young secretary of this update, Neil Bordeler, incoming president, and last but not the least is Omnia. the president of NCSI. I think when I went through the agenda of the meeting, I mean the whole meeting, the topics of the whole meeting, it is excellent. I congratulate you both, Pranav and Farheen, for organizing such an important meeting. I think, as I told you, I think a couple of days ago, this will be path-breaking thing for our society, because we are hoping to host a hybrid meeting for the Northeast CSI annual meeting together with the CSI Assam Cardiology Society meeting in the hybrid form. And this will be like testing the waters, how you can do that. So we're looking forward to that. And I will be not very long in this, and I again thank you very much for organizing such a wonderful meeting. I wish the meeting a great success. I'm sure it will be a great success. I'm looking forward to take part in it throughout the whole meeting. Thank you, Pranav. Over to you.
Thank you, Deepika. Thank you for your encouraging words. And so now I would like to request our chief guest for the inaugural ceremony, Professor Dr. Anup Kumar Burman, the Director of Medical Education, Assam, to kindly address the gathering. Sir, please take over.
I hope I am audible.
Yes,
you are audible.
So it's a good evening. Good evening to one and all. So all my senior colleagues, my friends, and organizing chair, Professor Vijay Bhattacharya, the president of CSI NE chapter, my senior Dr. Amya Kumar Sharma, the organizing secretary, Dr. Farid Iqbal, and president-elect CSI NE chapter, Dr. Neil, my senior Dr. Deepak Sharma, the EC member, Central Committee of CSI, all my river teachers, if they're present here today, all my senior faculties, all the research personalities, and the participant, and my dear students. At the very outset, I must thanks Professor Bhattacharya and Farin for having me invited here today as one of the, your friend, as a friend, and also as a faculty. I'm really very happy to be a part of this CSI NE chapter. It is learned that in the midst of this pandemic, in this unprecedented pandemic situation, the CSI Northeast and then Cardiology Society, the Department of Cardiology, Guwahati Medical College jointly organized this wonderful CME, or whatever it is, CME or is a virtual workshop in cardiology. It's a Cardiology Update 2021. It is learned that there will be extensive and profound academic feast. There will be some competitive CD presentations, paper presentations, and also a open house prize money quiz competitions. I'm sure all the faculty will be immensely benefited. All the students, not only faculty, all the students will be immensely benefited. And I also heard that many, speakers from national level, or rather to say the galaxy of national and regional speakers are here today and tomorrow. They are delivering their various talk on recent advances in cardiology. So definitely this will be a wonderful feast. Once again, I am sure that you all will be immensely benefited from this deliberation. So with this, I wish my good wishes for a grand success of this feast. And with this, I again declare this CME is open. And now hand over my mic to Dr. Pranav for carry forward. Thank you very much for your presence here.
Thank you, Ananda. Thank you, sir, for your encouraging words. And next, I would like to request Dr. Neil Bodloy as President-elect Northeast CSI to kindly address the gathering as well as offer the vote of thanks. Dr. Neil Bodloy, please. Neil.
Thank you, Pranab. Respected Professor Anup Burman, who is also a close friend, and Dr. Deepak Da, the EC member, who made us proud by getting us the EC seat for the Northeast, and now who's occupying the EC member seat of Northeast. Dr. Amiya Sharma, he is really one of the stalwarts of CSI Northeast. Great contributions from him over the years, right since the time he was secretary, and now he's been the president in very trying times. Pranab, who's like a brother, and Farin, also very close. Both of them, I must say, they have actually built since the pandemic came. We were not being able to start any of our programs, and I think nobody had the guts actually to do a online program. And really, that is why we are going to be really grateful to Pranab and his team, Farin, and I think Rituparna also helped. All these guys who came together and had the courage to be the first in the region to have a cardiology conference. And really, this is going to really help us now, because once you have taken the plunge, you get the experience and it becomes easy to keep on holding these programs. So because of the trying circumstances in the last 1.5 years, there was so much of suffering, so much of pressure on the medical fraternity, trying to deal with this unprecedented COVID situation. Academics did take a backseat, but now I think all of us are slowly learning that we have to live with Corona, and because Corona is there, we cannot stop our business, we cannot stop our learning, we cannot stop our life. So therefore, this conference is so important, because it in one way it just shows how we must defeat not Corona itself, but also the fear or the inhibitions surrounding Corona. So once again, I congratulate the organizing committee for doing a great job. And as Deepak Da and Myoda, they also said, the academic agenda and the quality of the lectures and the quality of the people giving the lectures is absolutely marvelous, absolutely superb. So I think we're going to have a great academic feast in the next 2 days. And my best wishes with all of you. I was supposed to join you, but there was such a traffic jam that I didn't go up to the hotel and got down in my house so that I could be in time for the inauguration. There's so much of jam today. So thank you, and over to you, Pranab.
Thank you, Nila. And at the end, I would like to thank all those who have participated in this inaugural ceremony. And special thanks to Professor Dr. Anup Burman, Director of Medical Education, Assam, for giving his precious time for this inaugural ceremony. Thank you, Anup, once again. And with this, I think we come to the end of the inaugural ceremony. Please do join in this 2 days of academic program. Hopefully, everybody has received their links and would enjoy the 2 days feast of academic activities. So thank you so much. Farin, would you like to say a few words?
Thank you, Professor Dr. Neil Bodloy, Dr. Amiya Sharma, and our senior cardiologist, Dr. Deepak Sharma. Thank you for the joining in the inauguration ceremony. Your words will definitely inspire each and every one of us to go ahead and organize this event, and also
or who are participating in such event. Definitely, this is an area that we are working on it. We are trying to host a virtual event this time. Probably next time we are going ahead with a hybrid event. And we hope that this will set the agenda for doing such event in future. With this words, I would like to start with the academic session. So we are already 4 times, so we will be starting in next 10 minutes or so. The first session on preventive cardiology. I would now request if Dr. A.C. Kalita is there, Professor A.C. Kalita, if he is there, to join us for the
yeah, I am very much here.
Now we'll end this inauguration ceremony. Thank you, everybody.
So should I move to the academic session now? Hello.
I think are we ahead of time? That's why I think it's supposed to be under 4:45.
Right.
And now it is 4:25. So we're unusually ahead of time. That's very good, actually.
But I don't know whether all the speakers are ready. I suppose I could see at least Dr. Chaudhary.
Yeah, that is why probably that is why he's supposed to be here ready by 2:45. I suppose so. He may not be here 4:45. He may not be here.
No, I could see the Dr. Chaudhary, but I don't
Sir,
know.
Kolita sir.
নীলে
কৈছে না স্যার আপনার চেয়ারপারসন যে রফিক দা আছে নহয় রফিক দা just rang me that he is quite sick now মানে কোভিড হৈ পেলে আইসিইউত ভর্তি হৈ আছে তেওঁক নামাতিব
ঠিক আছে I hope Dr. Charup Barua, are you here?
He is joining in 5 minutes. I had a word with him. Dr. Barua and Dr. Bhattacharya both are joining in 5 minutes because we are running a bit ahead of time.
Yeah. That's good for us. Dipti.
Yes, madam is here.
Madam is here.
Yeah, madam joined.
Ma moderator saha cup khua parnamak bhal asile.
দি দিছো আপোনাক
Sir, yagile khabo sir.
You can enjoy a virtual tea.
Virtual tea.
So we'll wait probably for 5 minutes. Let Swarup and Dipen join. We can have an
yes sir. Whenever you want to start, you can start, Kulta sir.
Yeah, sure. Because let the other two chairperson should come and join. Because I could see Dr. Chaudhary is there, no? H. Chaudhary, Ahmed Hussain Chaudhary, I could see somewhere here. Dr. Chaudhary, you are here. Dr. Kukreja, Bharatda.
You can see in the participant list. Participants.
I see. Ibbo is there.
Participants file ole dekha pabi ta.
Participants tate ma kol Chaudhary ke dekhilo. Chaudhary dekhilo etia ton mat nai.
Alok ase niki Malaka ase. I think. Alok asa?
দেখাটো আলোকটো দেখা নাই
তাৰ নামটো দেখিছিলো মই মালাকাৰা
জয়েন কৰি থৈ বোধহয় আঁতৰি আছে এনেকুৱা হ'ব পাৰে
কাৰণ তাহাঁতৰ টাইম আছেতো বিচাৰে নাই
ডেফিনেটলি
মানে 4:42 গতিকে এতিয়া 4:30 হৈছে 4:30 হয় নাই
নাই মানে এই হেৰিটোত অলপ গ্লিচ হ'বতো গতিকে মই ভাবিছোঁ কি could have same time
আৰম্ভ কৰিব পাৰিলে ভালেই
আৰু অলপ ডিছকাছ কৰিব পৰা গ'ল
ডিছকাছ কৰিবলৈ পোৱা যাব
Hello, sir. Hello.
Hello.
Yes, sir. Please join. We are going to start in 5 minutes. Sir, I'm calling from cardiology update. You have joined in the morning and then, sir, your session is. Please.
दीपक दा आपने गुवाहाटी ने जोरहाट अच्छा अच्छा
जोरहाट
পাৰিন তোমালোকে ডিপাৰ্টমেণ্টৰ পৰা কৰিছা নে কোনোবা হলত কৰিছা
হোটেল নেকি
কন্ট্ৰল ৰুমটো হোটেল নভোটেলত আছে এতিয়া তেওঁলোকে নভোটেলত বহি আছে
তই ক'ত আছ ঘৰত
মই গৈ আছো অফিচত মই এতিয়া ঘৰত
ৰাতিহে যাবি
মই নিশাচৰ
সময়ত
দীপক দা যাব পাৰিলেহেঁতেন গুৱাহাটীলৈ
নাই আকৌ যাবলৈ মই ৰিচেণ্টলি গৈছিলো আকৌ আহিলো আকৌ যাব লাগিব নেক্সট উইকত যাব লাগিব কিবা এটা কামত নাই এতিয়া বৰকে যিমান দূৰ পাৰো ভাৰ্চুৱেলি কৰাই আৰু এই টেষ্টটো মানে মই প্ৰণৱতক কৈছো এইখন যদি আমাৰ এনেকে খুব ভালকে আমাৰ ন-হাও এটা হ'বতো পাতিবলৈ গতিকে আমাৰ যিখন হাইব্ৰিড কৰিম গতিকে সেইখন আমাৰ মানে মই যদি আমাৰ ডেটটো আমাৰ কোনোবাখন মিটিং আমিও শুনি আছো এখন মিটিং দিবিচোন অহা সপ্তাহ মানত যদি পাৰ কি হ'ল আমি ডিচাইড কৰিব লাগে ডেটটো প্ৰভিজনেল ডেট ভাৰ্চুৱেলি হ'লেও হ'ব মিটিংখন আমাৰ এইখন এনেকুৱাখন কৰিলে ডেটটো ফিক্স কৰিব লাগে নহয় আমি আৰু এইবাৰ পাতিমেই আৰু
ঠিক আছে আমি হাইব্ৰিড হলেও পাতিম আৰু এইটো
হাইব্ৰিড হলেও পাতিম
এইটো কৰি ল'ল দূৰবিলাকতো হাইব্ৰিডে কৰিব লাগিব চাগে হেৰি ভিডিঅ' কৰিব লাগিব আমাৰ ওচৰবিলাক কৰি পেলাই আৰু বহুত দিন লগ লগা নহয় নহয় পগলা লাগিছে
তাকে পাই আমি এপিআই যোৰহাটক দিছিলেতো এপিআই হেৰি মোক চাইণ্টিফিক চাবলৈ ক'লো যে আমি হাইব্ৰিডেই কৰোঁ হাইব্ৰিড কৰি পেলাই তাহাঁতি মোটামুটি ডেট এটা ঠিক কৰিছে ফেব্ৰুৱাৰীৰ এটা উইকেণ্ড ঠিক কৰিছে গতিকে এইটো ক্লেছ নোহোৱাকৈ আমাৰতো এনেকৈ কৰি পেলাব লাগিব
ঠিকেই ফেব্ৰুৱাৰীত হ'লে ঠিক আছে ফেব্ৰুৱাৰীত ভাল ডক্টৰজনৰ কি হ'ল খবৰটো
এতিয়ালৈকে ওলোৱা নাই এতিয়ালৈকে ওলোৱা আচ্ছা এপিআই অমিয় মন্ত্ৰী কি এপিআইটো তাহাঁতি এতিয়ালৈকে প্ৰপ'জ কৰিছে আমাৰ ইয়াৰ পৰা 12-13 হা
আচ্ছা স্যাটাৰডে
চানডে গতিকে আমি আৰু এটা স্যাটাৰডে চানডে ল'ব লাগিব আৰু
বন্ধ চন্ধ বিলাকো মিলাই চাই ল'ব লাগিব
পৰীক্ষা বন্ধ ল'ৰা ছোৱালী কিন্তু এই হাইব্ৰিড হলে সেইটোৱে ভাল বিচাৰে নাই যিবোৰ আহিব নোৱাৰে আমি হাইব্ৰিড কৰিব আৰু
এই ইভেন্ট মেনেজমেন্ট গ্ৰুপটো লৈ ল'ব লাগিব
সেইকাৰণে আমি মানে প্ৰণৱক মহিনাত কৈছো যে আমাৰ এইটো ডাঙৰ এক্সপিৰিয়েঞ্চ হ'ব এইটো পাতিলে আমি এই ইভেন্ট মেনেজমেন্ট গ্ৰুপ যদি are the event management people listening to us
yes sir
if you hold it
I'm
properly
not understanding everything
oh yeah okay so if you properly conduct it and to satisfaction you have another client online
so try to get some marks from this
yeah
this is that Sangamitra na she is in charge in Calcutta also
yes sir
she used to organize coordinate those Kolkata programs also
yes sir
It's the same Sangamitra, no?
Yes, sir, same Sangamitra. Thank you for remembering me.
No, no, no. What do you mean by same Sangamitra? The original one.
Not with Gautam Buddha.
Or the reincarnation of that. Anyway, whatever. Please see that you do it properly now, then so that we can get in touch with you for the next meeting.
Yes,
And
sir.
in fact, in that case, another meeting, as I told you, API meeting is also coming up. So, are you based in Guwahati or in Kolkata, Sangamitra?
Yes, sir. I am based out of Kolkata, but we do work pan-India, across India.
Okay, fine. So
Our head office is in Delhi.
we'll get in touch with you for both the meetings. And so do you understand Assamese, do you? Can you follow Assamese when you speak in Assamese?
No, sir. No, sir.
Part of it, whole of it.
So no, sir. I don't understand Assamese, sir. I can try, but yeah, I don't know Assamese. I should not say. I don't know.
But
I have been to Assam. I have been to Assam in March. I had a work there. I have been to Assam 2 to 3 times, but I don't know Assamese.
No, that's okay. Then we can discuss our secret things in front of you also. No problem.
Thank you, sir.
Okay, that's fine. I think we're getting there now. Another 10 minutes.
Sir, I think we can start. Dr. Barua sir has joined.
Okay, Dr. Sarup Bora has joined. So then
Two chairpersons are present, Madam and Dr. Barua sir. We can start.
Yeah, we can start then. Dr. Ahmed is here, no? Are you ready? Hello, Dr. Ahmed. I could see you once.
Dr. Ahmed is not well. Already, you were
No, not that Ahmed.
No. The speaker Ahmed.
Yes, he has joined.
Sorry, not Ahmed.
Chaudhary.
Sorry, Chaudhary. I could see him.
Okay, I'm Dr. S.K. Bora speaking. Can you hear me?
Sarup.
Can you hear me?
Yeah.
Yeah,
Loud and clear.
Yes, you are audible, Surubda. You are audible.
Yeah, am I audible? Okay, let's start the session.
Yeah, just let me see whether speaker is there or not. Speaker.
Sir, he is here. Dr. Ahmed sir has joined, but somehow he is not responding. I mean, I think his audio is not connected.
Can you call him directly once?
Yes, I'm trying.
Just call and.
Yes, I'm trying.
Sarup, can you answer?
Hello.
Hello, hey, Hamo. Sarup.
Hello.
Nisho.
Dr. Ahmed Hussain Chaudhary.
Sir, start with sir.
Okay, now
speaker ahi point nai no.
Speaker lekha nai no. Speaker ahi paisa nai.
No, second talk to start with your sir. Time. Okay.
Professor Sarup Bora.
Yes.
Dr. Deepak Sharma here dey tomar.
Asu to.
Yeah.
Just unmute korilo, apna বিচাৰি আছে তো.
Deepak da ko.
No, tundu neri bolo bhale aso. Nai tu retire karo hol bole? Retire karo hol bole?
All retire karo.
Hey, ami to tane kiman bura holo etue bhoy lage
Ha.
Ahmed.
Retire karo hol.
H. Chaudhary, I say. H. Chaudhary, speaker, first speaker. Once I saw him, but here I could not see him anymore.
Hello.
Hello, Sarup.
Chaudhary sir is not picking up.
So, Bharat Bhushan Chaudhary, Bharat Bhushan Kukreja.
He's coming to Novotel, he said. He's coming, reaching in 5 minutes.
I see.
Moderator.
Hey, Asu, moi koi asu.
Koi asu niki to.
Moderator tumak koi asu tumi khuna nai.
Khuna nai. Oh. Speaker nai jodi.
এতিয়া শুনিছ?
শুনিছো। স্পিকাৰ আছে নাই?
তাকে মই বিচাৰি আছো, স্পিকাৰ নাই, আমি বিলাক আছো বহি। মালাকাৰ আছা নহয়? আলোক Malakar, Dibbo. We could have started if anybody.
Asu sir, Asu. Good evening, sir.
Malakar asa. Till tomorrow armbo kodi honi ki? Karan baki kita speaker dekha na dekon moi.
Yes, sir. Just take minute, sir.
Sir, Ahmed Hussain Chaudhary bole ase bole koise sir.
Dekhilu kintu tekto etia moi dekha nai, eta screen ot dekha nai. Ebar dekhilu eta.
Ahmed Hussain Chaudhary are there. Dr. Ahmed Hussain Chaudhary.
Sir, I am here, sir.
We were
here. Okay, please start your presentation then.
Okay, we'll start. So, ladies and gentlemen, may I request all of you kindly to put in mute now so that we can listen to the speaker and chairperson. It's my earnest request, all of you kindly go to the mute form. So, we'll go to the first chapter, preventive cardiology. Everybody of us do know that this is the most important part in cardiology, though it is most neglected one. A few days back, I have read somewhere that Christian Barnard, who did the first transplant, cardiac transplant, at the end of his career, he said that I have saved 150 lives by doing cardiac transplant. But if I'd have spent my time, money, and energy for prevention of cardiovascular diseases, probably I could have saved 150 million people in my lifetime. So that implies how important is cardiac preventive cardiology. So we do have three eminent chairpersons. Professor Sarup Borua, who was head of the department, former head of the Department of Medicine, Guwahati Medical College. Professor Dipen Bhattacharya, who is the professor and HOD Medicine, Assam Medical College. And Dipti Rekha Borua from Tezpur, who is doing tremendous service for preventive as well as curative treatment of cardiovascular disease in northern Assam. So, unfortunately, Rafiq Da could not join because he is not well. So, I request the chairperson, considering Sarup is the senior most, why not to go ahead and introduce the first speaker. But just one thing, that every speaker is given 15 minutes. But I'd request to stick your time to 12 minutes and let 3 minutes come for discussion. So I'd be very happy if you stick to the time. And Farin, someone has to look into the time.
Yes, sir. We'll be doing that, sir. We'll be doing that.
Okay.
The time presentation is 12 minutes and 3 minutes for discussion, sir.
Yeah. So Professor Borua, kindly take over.
Yeah, fluctuating blood pressure approach to management will be delivered. He is known to everybody. He is working in Silchar Medical College, and I had the opportunity to work with him from 2002 to 2006. But only thing is this: I wonder regarding preventive cardiology. It's a very important topic. One should follow the preventive cardiology. The classical example is myself, because I didn't follow the blood pressure controls, the lifestyle modifications, considering my age, and the result was a very long stand in mild LAD. Basically, it goes to coronary artery disease. So, without wasting my time, I request Ahmed Hussain Chaudhary to continue with his deliberations on this fluctuating blood pressures or the level hypertension. Dr. Chaudhary, please.
Good evening, sir. Are you listening to me, sir?
Yes.
Okay, sir. I'm proceeding. I'm getting a little bit difficulty in showing my slides, sir. But I'm starting, sir. Everybody, fluctuating blood pressure is a very important topic, sir, and the clinical implication at the same time is very much important. So, at the outline, I want to say that show that hypertension and cardiovascular risk. Where do we stand? Variability of the blood pressure and cardiovascular risk. Key consideration for variability of the blood pressure. Second, blood pressure.
Dr. Chaudhary, your slides are not visible.
Sir, I'm finding difficulty in showing my slides. Actually, I am a beginner. I have not much experience.
Sir,
Samitra, you can share the slide for Dr. Dr. Chaudhary has probably shared it to you.
Sir, just let me guide you. Give me. Is your presentation open?
Yeah, my presentation is open, sir.
Can you go to the Zoom and there is a green button in the bottom called Share Screen.
So I'm looking into it, sir. Share screen, yes, sir.
Can you just press that?
Yes, sir.
Then you can see the presentation in one of the small tiles. Just press on that presentation and press share, which will be down in the bottom.
Sorry, I'm finding difficulty. Okay, sir. Try.
When you press the share screen button, could you see your presentation open?
No, sir.
Sir, I'll just give you a call on your WhatsApp video call. If you can just take that call, I'll just guide you through. Sir, can you just take the video call on your phone?
No, sir, I'm not getting any video call. 99545326330, sir. Launched files. Yes, sir. Yes, sir. Hello, sir.
Sir, can you just turn the camera backwards?
Hello. Hello. Volume. Doctor Chaudhary. Hello. Can you hear us?
Sir, I think Ambarish is guiding him on video call.
Okay. Can we go to the next speaker, please? And then we'll come back to Dr. Ambarish Chaudhary once he's ready.
Yeah, that will be better probably. By the time.
Yes, sir. If Dr. Alok is ready, we can start with Dr. Malakar's presentation because Dr. Kukreja is coming to Novotel for his presentation. So
I'm already here.
Malakar, you are here?
No, Dr.
Kukreja is here. Okay. Sir, Kukreja sir can start his presentation, I believe.
Listen, Kukreja.
Good evening.
Good evening. Are you ready? Are you ready with your slide?
Yes, I am ready.
Then we can go ahead with your talk because Chaudhary has got some problem, technical problem.
No problem. I'll just try to connect.
Yeah. Swaroop?
Yes.
To a Bhardak Sinai Goda?
Well, he doesn't need any introduction. Everybody knows him. And he'll be talking on the edible oil, what to take and what not to take. But actually, as far as my knowledge on edible oil concerned, is that this olive oil and canola oil is the best. They are costly, but nowadays the mustard oil is also coming to, that is said, for Indian population, mustard oil is the best. And this one, but mustard oil is approaching the price of olive oil and canola oil, which are very costly. So let us hear from Dr. Kukreja, which is better, which is for us.
Aradha, your time is for 12 minutes and 3 minutes for discussion.
I heard you telling us. I'm just trying to get to my screen. I'll get my PowerPoint ready. Unable to connect. What happened? Disconnected. Huh? एक मिनट मैं मोर PowerPoint तो खुली लो. Yeah. No. Yeah, but is it visible there? Are my slides visible?
No, not yet.
No. I'll just.
You are visible. Your slides are not visible.
Okay, sir. I'll try to do it now. I'm already in a meeting. No. Yes, no, let me leave this.
সবৰে ভিডিও বিলাক অন কৰি থৈ দিয়ক না মুখ এখন দেখি থাকিলে ভাল লাগে অডিওটো ষ্টপ কৰি পেলাই দীপক দা অমিয় ভিডিও বিলাক অন কৰি থৈ দিয় মুখ বিলাক অমল আছা নহয় দিব আহিলা
হেল্ল' শুনিছে
শুনিছো ভালে আছা ভিডিও বিলাক অন কৰি থৈ দিলে ভাল লাগি থাকে আৰু মুখখন দেখি থাকিব পাৰি নহয় দীপক দাৰ নামটো নীলাক্ষী হৈ আছে চবে চিনি পাই পিছে অনু ভালে আছা
আছো ভালে আছো শুনি আছো মই
ভাৰততো তাতে হোটেলতে নহয় জানো কিয় প্ৰব্লেম কিয় তাত টেকনিক্যাল পাৰ্সন নাই নেকি তাত
অলপ যোৰহাটলৈ আহিলে খবৰ এটা দিবাচোন
ঠিক আছে দাদা
বহুদিন লগ পোৱা নাই নহয় দেখা কৰিব
হয় যাম এইকেইদিন যাব লগা আছে
মোক খবৰ এটা দিবা প্লিজ এনেই দেখা কৰিলে ভাল লাগিব আৰু
আজিকালি ভাৰ্চুৱেলি দেখা হয় আৰু
তাকে পাই আমনিও লাগিছে আকৌ
হয়
হল এইফালেও নহল সেইফালেও নহল চৌধুৰীটো আৰম্ভ হৈছে নেকি আপোনাৰ স্ক্ৰীন ওলাইছে চৌধুৰী yes yeah Bharda you could see the slides
Bharda আৰম্ভ কৰক
I think he has to unmute.
Nothing could be
unmute কৰি ল
Sir is already unmute.
কিয় মানে এটা
वो लगाने से आपका देखिए ऊपर वो सपोर्ट नहीं कर रहा है
अभी देखो am I audible now
yeah you are very much audible
can I start then
sure we have been eagerly waiting for you
thank you namaste thank you Dr. Kalita I would remember that 12 minutes is the time. There is just 10 minutes left to 5. Thanks so much, CSI Northeast Branch organizers, for giving me this opportunity to speak something on edible oils. Not audible?
You are audible. The screen is not.
Is the screen visible?
Screen is not visible.
No. Yeah, they are trying to correct it. वहाँ चले. I have a pen drive. I can go and do it from there.
Your slides are not visible.
क्या डाउनलोड हो जाएगा डाउनलोड कर लो क्या होगा
Yeah, we could see the slides now.
Audible? Okay, apologies for the technical glitch. Edibles oil in Indian diet. What is right? What is wrong? As I was going through this preparation, I found it's very difficult to say what is right and what is wrong. So as you will see in my presentation, it's better we call it what is not right. Let me declare I have no conflict of interest. My agenda today is to give you a small introduction. Show you,
আমি শুনি আছো
then edible oils which are consumed in India. Tell us something to you about fatty acid composition of the edible oils. Discuss some of the clinical studies and meta-analysis on edible oils. Talk a little bit about Indian cooking conditions, then blending of edible oils, and then I will sum up so that you would be able to make for yourself the judgment what is right and what is not right. And before I close, I will give you some of the cartoons which will be worth taking home as a take-home message from this meeting. Now, friends, edible oils are what? They are primarily lipids, and lipids are what? Fats. Fats means fatty acids, and we are aware that they are essential part of macronutrient. So, along with carbohydrate and protein, fats are the essential macronutrients for human survival. Dietary factors, particularly edible oils, play an important role in the causation, treatment, management, and prevention of coronary heart disease. Cooking oils form an integral part of our diet. Right selection of edible oil is extremely important, especially in the Indian context where cooking methods as well as cooking vessels are different. Friends, clinical trials and observational and metabolic studies among diverse populations say that consistent association between quality and as well as quantity of fat intake and the coronary heart disease risk. So, effect of dietary fats on plasma lipid constitutes a key link that connects diet to cardiovascular disease. Coronary heart disease is the leading cause of mortality all over the world, and therefore the subject for today's discussion, the edible oils in our country, is very pertinent. Now, if we just share with you the edible oil constituents the consumed in our country, 60% of the edible oil consumed is 40% palm oil and 20% soybean oil. This is rather eye-opening because palm oil is the largest consumed oil in our country next to soybean oil, and the rest 40% is shared by this type of vegetable oils, and this is animal source ghee, butter, fat, fish oil, lard, and tallow. Can I remove this from there? Okay. So if you see the approximate fatty composition of fatty acids, edible oils have several fatty acids which can be grouped under three classes: saturated fatty acids, monounsaturated fatty acids, and polyunsaturated fatty acids. Saturated ones are short, medium, and long chain, and we have polyunsaturated fatty acids which are further subdivided into omega-6 or omega-3 and trans fatty acids which are produced because of hydrogenation of vegetable or vanaspati ghee. If we have a meta-analysis of randomized trials suggested the increase in the risk of CSD in studies that reduce saturated fat.
You are not
what
audible.
we see is
yeah, it's okay
not
now.
Okay.
I could hear.
Saturated. The SFAs have been considered harmful and a risk factor for atherosclerosis, and there is a question mark. This is now changed. Therefore, we have to have a real look at what is the present understanding. It is in the form that short and medium chain saturated fatty acids are not harmful as they do not affect the serum lipids. A study which was done to see the coconut versus sunflower oil on cardiovascular risk factors in patients with stable coronary heart disease, the randomized control trial looked at the various parameters like cholesterol, LDL cholesterol, triglyceride, and HDL, and it was found that after 2 years of follow-up, serum lipids were not altered by coconut oil, which is very rich in saturated fatty acids as compared to sunflower oil. And therefore, the myth that all saturated fatty acids are not good has been changed now. The systemic review which suggests that saturated fatty acid may not be harmful as considered earlier. This chart is self-explanatory. If you look at the parameters, the saturated fats are not associated with all-cause mortality, cardiovascular death, coronary heart disease, ischemic stroke, or type 2 diabetes. Omega-3, omega-6, and PUFA. Omega-6 and omega-3 are essential fatty acids which are required for proper functioning of the body. Omega-6 lowers not only LDL but improves vascular function and prevents sudden death. Omega-6 and omega-3 PUFA should be present in adequate and balanced proportion in the body because both compete for the same enzyme. And several dietary recommendations suggest that ratio of omega-6 to omega-3 should be 5 to 10:1 or lower to prevent heart disease. Trans fatty acids increase the risk. Due to undesirable effects on serum lipids, it is associated with an elevated risk of CSD and is considered worse than saturated fats. So it is trans fatty acids are produced by hydrogenation of vegetable oils or vanaspati ghee. So high intake of TFA is definitely detrimental to health. The effect of polyphenols in olive oil, as our chairman sir was mentioning, on heart disease risk factor, a randomized trial showed, it concluded that olive oil, apart from MUFA, its polyphenolic compounds confer beneficial effects on plasma lipid concentrations and bring. However, the main limitation is that olive oil does not have ideal omega-6 omega-3 ratio and may not be ideal or suitable for Indian cooking. If we look at the mustard oil, which is again a very good source of MUFA and its cardiovascular health benefits, mustard oil is considered healthy because it's low in saturated fatty acids, high in MUFA and PUFA, especially alpha-linoleic acid, and it's a good N6-N3 ratio, omega-6 and omega-3 ratio, which is 6:5. It is available in cold compressed form, and several studies also suggest that mustard oil may be associated with lower CSD risk as compared to other oils. This is one example. When mustard oil was compared, which is mustard oil which is rich in alpha-linoleic acid, it led to 71% reduction in CSD risk among individuals using mustard oil for frying as compared to sunflower. So here is a compare between sunflower, vanaspati, peanut oil, and mustard oil definitely scores better. In acute MI study, using mustard oil, there was reduction in arrhythmias, heart failure, and angina. A few words about canola. Canola, by virtue of its ideal Indian LA-ALA omega-6 omega-3 ratio, has been found to exert cardioprotective effects. Flaxseed oil, again, is the rich source of omega-3. It's not commonly consumed in our country because of the cost and not easy availability. Blending it with other edible oils is a good strategy to increase ALA intakes, and therefore flaxseed oil is now being taken as a good source for making a blended oil. If you look at the Indian cooking condition, which is subject oil to very high temperatures, sometimes it goes above 170 degrees. Refined oils with high PUFA can degrade easily to toxic components like free radicals, trans fatty acids, and malonodialdehyde, etc. Therefore, they become potentially mutagenic and atherogenic. Repeated frying of the oil further damages the oil and produces more toxic components which are harmful to the heart. This is one study done by IITians in Delhi, near about Delhi, which demonstrated that trans fatty acids content of oil samples drawn from the halwais was showing high level of trans fatty acids. So it is preferable to avoid refined oils and use cold pressed or extra virgin oils. Refined oils are heated repeatedly at high temperature, and that results in loss of antioxidants like tocopherols and sterols and produce free radicals and trans fatty acids and polymeric components which are potentially atherogenic and mutagenic. Oils high in saturated fat like ghee and coconut are ideal for deep frying as they are more stable. Blending of oil is another good source. It combines the potency of 2 or more edible oils, give a balance of fatty acid and antioxidants. Replacement of commonly consumed fats and canola with flaxseed oil or similar blends is a viable option in our country to achieve good edible oil. This is one study where they have studied the blended rice bran oil and compared it with sunflower oil, and all these blue bars show reduction in the blended is much more in all parameters, LDL, total cholesterol, and triglyceride. So the comparison in the mean lipid profile between test, that is this blue one, and sunflower and commonly used oil, it shows that blended oil can be utilized for its goodness by using goodness of each soil which is individually there and get it in one single use. So what is right and what is not right, friends? I have given you the whole book to you to look at it. I have shown you what is right and what is not right. If I now can sum up, Indian cooking conditions differ greatly since the oils are subject to high temperature. Stir frying is a routine process in our cooking, in every curry and other similar preparation. As a result, exposure to high temperatures not only destroys antioxidants like vitamin E and tocopherols and beta carotene, but also produces toxic components that become potential mutagenic and atherogenic. So it is advisable to avoid refined oils. Refined oils, particularly high in PUFA, degrade easily and therefore should be avoided for frying. On the contrary, oils high in saturated fats like ghee and coconut oil can be used for Indian cooking as they are comparatively safe during frying. Earlier, that means about 3 to 5 years back, oils high in saturated fatty acids were considered harmful, but the recent studies indicate that short and medium chain saturated fatty acids like coconut oil have not demonstrated adverse health effects. Mustard and rapeseed oils, because of their LA-ALA ratio, low saturated fatty acid and high MUFA content, along with their relative stability during cooking, are definitely better ones. In fact, epidemiological studies among Indians do suggest that mustard oil consumption can reduce the risk of coronary heart disease. Further, appropriate blending of edible oils such as rice bran and safflower oil, or coconut and sesame oil, or canola with flaxseed oil appears to be a good option to reduce the plasma lipids, inflammation, and thus the coronary heart disease risk. Before you go home, I have some good message to give you how to choose oil for Indian cooking. This is a big chart which has been very nicely made, but now if I show you the breakup, it is like for deep frying, use oils with high smoke point such as ghee or coconut oil or avocado oil or rice bran oil. For tempering, ghee or coconut oil, like for all South Indian food. For pan frying and sauteing, it is the peanut oil or olive oil and coconut oil, sunflower, safflower oil, or any cold pressed oil, whichever is of your choice for pan frying and sauteing. For stir frying, like making Chinese food, one can choose peanut oil, but to finish it off, one can use toasted sesame oil to give it a good flavor. For baking, nothing works better than coconut oil and olive oil because they are healthy substitutes, but butter is the best which is used for all baking purpose. And undoubtedly, for sweets, desserts, and biryanis, nothing like ghee and pure desi ghee. So to say thanks to you, I will just give you a final slide. Oils to stock in your pantry. Ghee should be there, available in the kitchen for tempering and deep frying or for making biryani or sweet dishes. Coconut oil, again for baking, tempering, South Indian cooking and deep frying. Or avocado oil or rice bran oil for deep frying. And one can pick up any two oils of choice for everyday cooking and alter between them, between peanut oil and mustard oil for making Indian pickles and North Indian and Bengali dishes, and sunflower and safflower oil or sesame oil or olive oil. Please avoid trans fat or vanaspati and refined oils. I profusely thank each one of you and Dr. Kalita and our chairperson, Dr. Barua, for allowing me to manage along with this commotion we had. Thanks so much, sir. Thank you. And I close my presentation. Thank you.
Thank you, Bharatda. It is an excellent presentation. And Sarup, please.
Thank you, Bharatda, for a very, very lucid and presentation. And you have touched the practical aspect of Indian cooking. What we eat, what should we eat, or what should we? Anyway, the common belief is that for the Indian cooking part, it is the mustard oil. It's commonly available, but price is going up and up. But anyway, that the refined oil and these things, you have demonstrated that the deleterious effects of refined oil and all these things. Thank you very much. Dr. Kolita, would you like to comment anything?
Yeah, it's a very, very lucid presentation and very practical presentation. Thank you, Bharda. It would definitely help everybody. Definitely from your slide, we could know that no longer ghee and butter are bad. In fact, regarding this cooking oil or edible oil over the period of last 7-10 years, there is dramatic change. So enjoy life. Nothing to worry probably.
Yes.
Yeah.
Eat in moderation. Eat in moderation.
Yeah.
It is the total quantity or calorie consumed rather than talking about desi ghee and olive oil and palm oil. So eat less.
I think the way of preparation is we should look for, which wonderfully you have described. I mean, quite often we used to have singara, kosuri in the same oil. They will keep on frying, and there is hydrogenation of all those good oils to bad form, particularly including trans fat, formation of trans fat. So that is very, very important probably. Otherwise, in our part, the consumption of fat from edible oil is otherwise also less. It is always better if we can have something which is backed and put their oil directly, mustard oil, which is not at all destroyed. So that is much, much better. Amar koka aita hote agote puri pelai, tar pisot tel di jitu hani khaisile. That is the yeah, we'll move on to the first topic. I think Dr. Chaudhary by this time ready. So may I request Dipen kindly to introduce our speaker.
The next topic is very interesting one. Approach to the management of an episode of acute rheumatic fever and secondary prevention.
No, Dipen. Kindly, first speaker, Amar Chaudhary, are you ready? Chaudhary, Dr. H. Chaudhary.
Are you ready? Ready hua nai niki? Dibbo
Okay,
ready
okay.
Sir?
Dibbo ready. Okay, go ahead, Dibbo.
Yes. So the speaker is known to all the members of the society. Dr. Professor D.J. Dotto. He was former professor of cardiology at Assam Medical College, Dibrugarh, and now a practicing cardiology in Guwahati. He has taken a very interesting topic which will be beneficial for the general physicians also, because many a times when the first management of an acute rheumatic fever is not proper, the secondary diseases like rheumatic heart disease, these things occur. So let's first hear Professor D.J. Dotto. Over to Professor Dotto.
Am I audible?
Yes. Yes.
Yeah, you are very much audible.
Okay. Okay.
Start up there.
At the outset, I must offer my thanks and gratitude to the organizers for giving me the chance to speak in this front of the August gathering. So management of acute rheumatic fever and the secondary prevention. Before starting, I thought the little bit of epidemiological aspect will be pertinent in this case, because rheumatic fever and rheumatic heart disease, as a clinician, we know is still prevalent in our country as well as in Assam. In a global scale, though their incidence has fallen dramatically over the period of these years, but as far as WHO, Global Burden of Disease, and World Heart Federation reports are concerned, this disease still persisted in Southeast Asia, Africa, and Middle East countries, particularly low-income group countries. Even Indian scenario is also not promising. As far as some eco-based study, particularly school health survey, the incidence of rheumatic was found to be 1 to 11 per 1,000 population across India. Of course, the number will be varying because of the various regional variation as well as socio-economic variation in the country itself. As far as global burden of disease 2017 report is concerned, 1/3 of global daily, that means disability adjusted life years as a result of rheumatic heart disease and death are seen in India only. And our Assam, we are also not far behind. As far as Indian Initiative for Disease Burden concerned, 2016 report, the death rate from rheumatic heart disease was found to be 9.7, only topped by Odisha and Bihar, which is topping the list by number more than 11. And echocardiography-based rheumatic fever study in 2017, they have found a prevalence of 5.4 to 11.4. As we know, echocardiography is very sensitive in picking up subclinical carditis. The next slide. So coming back to the disease continuation of the presentation again, if we have to confirm rheumatic fever, the 2005 revised Jones criteria is the mainstay. This is divided into high risk and low risk population mainly by the Australian guidelines. And one important addition is the polyarthralgia. Though we dismiss that arthralgia should not be considered as a major criteria, but in a population with moderate susceptibility or high susceptibility, polyarthralgia also should be considered as a major criteria. Then what are the echocardiography now is considered as a class 1 indication to detect and pick up subclinical as well as clinical carditis, just to define the diagnosis further, because neither we are supposed to overdiagnose nor underdiagnose rheumatic fever. An Indian series of 108 cases where has popularized the presence of rheumatic nodular verrucae has not been substantiated in some subsequent studies, so probably it has fallen out of favor. And regarding the specific Doppler criteria, World Heart Federation has given a criteria for mitral regurgitation and aortic regurgitation. As you know, the regurgitated lesions are the lesion in acute rheumatic fever because of valvulitis. So as far as MR is concerned, it should be seen in 2 views at least. The jet length should be more than 2, peak velocity more than 3 meters per second, and pansystolic jet at least in one envelope. All these 4 criteria to be fulfilled to be qualified as a rheumatic carditis or rheumatic MR. Then for AR, similarly, at least in 2 views, jet length should be equal to more than 1 centimeter, peak velocity be more than 3 meters, and pan-diastolic jet in at least one envelope. If one of these 2, if we see either MR or AR, all these criteria has to be fulfilled to be qualified as a criteria, echocardiography criteria for acute rheumatic fever. Now coming to the treatment proper, why should we treat rheumatic fever? Because we have been teaching our undergraduates the rheumatic fever itself is a self-limiting condition. So does it require any treatment? If we treat or do not treat, probably the sign symptom will disappear. But the aim of treatment is to prevent morbidity and to some extent mortality because of acute congestive cardiac failure. And the management goal is to manage an acute attack. At the same time, we have to prevent subsequent attack. As you know, the streptococcal pharyngitis, which can lead to rheumatic fever, it can have a recurrent episodes in a susceptible individual. So what are the different steps? The general steps are adequate rest, because majority of the patient will be those who are symptomatic. They will have either arthritis or carditis, so they will require rest, and rest itself is an important aspect of the treatment. The diet should be easily assimilable, and if the patient is heart failure, then it should be tailored diet as far as the condition demands. And specific treatments are basically to control the symptoms. Though the average duration is considered with 3 months, in India particularly it is seen, there are some people, at least 5% of the cases, they have a persistent or chronic carditis running beyond 6 months, with as defined by the persistent inflammatory markers. However, whatever treatment we offer, we cannot alter the course of the disease. Our aim is to prevent morbidity, which is also an important aspect of treatment of such a condition. The first step is we have to eradicate the persistent or residual infection of streptococci to reduce the antigenic burden. So this is important in the sense, though rheumatic fever, by the time patient comes to a doctor, it is almost 2 to 3 weeks after a preceding streptococcal infection. So probably the residual streptococcal burden will be minimal, but whatever is the burden, we don't want to take any chance. We just want to eliminate those bacteria to reduce the antigenic burden. Again, antibiotic is the main agent. And here, as you know, penicillin injectable is the drug of choice. If the patient cannot, does not like or injectable penicillin or cannot take injectable penicillin, oral penicillin is preferable. And if the patient is not suitable for penicillin, either oral or injectable, cephalosporin alternative, and erythromycin if he is allergic to penicillin. The dose will be benzathine is a long-acting drug because one shot is good enough. And there are one other indication is that if you give a first shot in acute rheumatic fever, there is a first step for starting secondary prevention. So if it is depends upon the weight also, if the weight is more than 27 kg, we should give 1.2 million in it, less than 27, 6 million in it. Oral penicillin, though it is not preferred because some people, because of non-availability or very painful reaction to the penicillin, oral penicillin has to be given sometimes with a dose of 500 ml twice daily, duration is 10 days. Amoxicillin, cephalosporin, duration is 10 days. Macrolides, out of this, azithromycin is not advocated by Indian pediatrics for in pediatric population, but duration is 10 days for erythromycin and clarithromycin in allergic situations, and clindamycin reserved for penicillin allergy and those who cannot tolerate macrolide because of gastric intolerance. Arthritis is the commonest manifestation. Aspirin is so far the mainstay. The dose is 80 to 100 milligram per kg both in children, 4 to 8 gram QID in adult. The duration, though it is stated to be 4 weeks, it is not a fixed panacea because the duration, the pattern of the severity will be variable. So since the duration of the entire disease itself is 12 weeks, so it should be stressed up to 12 weeks. Of course, you have to taper off after 8 weeks. And in persistent cases, we have to continue full dose up to 12 weeks. But there's a small studies with alternative agent with naproxen and ibuprofen for better safety and tolerability. However, the number of those studies are quite limited. That's why it cannot be advocated as a first-line drug. Steroid is sometimes reserved for, though it is reserved for severe carditis, can be used in arthritis, as our experiences suggested, because some of the arthritis, they do not respond to aspirin. However, the RCTs which are done from the Taki Jones days, 1950 to 2001, did not show any prognostic benefit of whatever treatment we offer for rheumatic fever as such. Carditis is considered as a gradient manifestation which can leave it sequelae and establish valvular heart disease. The incidence of carditis is quite variable from 40% to jump to 91%. The 91% is basically from recent outbreak in US in Utah, which is an which this study basically based was an echocardiographic criteria. And the carditis is seen to be particularly younger population. And carditis has been divided clinically into mild, moderate, and severe. In mild carditis is self-limiting, nothing specific is required. Steroid, aspirin, and IVIG had been tried in 6th trial in 1966 itself has defined that there is no benefit of treating mild carditis. Even for moderate to severe carditis, there is no randomized control trial, only it's an expert opinion. And that steroid, oral penicillin is preferable with a dose of 1 to 2 milligram per kg per day for 4 to 6 weeks. Again, the duration may be slightly variable. Maximum we can go for 12 weeks because many times it will, the disease itself have a natural tendency to remedy after 12 weeks. For congestive heart failure in a setting of acute rheumatic fever, there is an acute decompensated heart failure. So standard therapy for heart failure should be started except digoxin, because digoxin will have a high rate of toxicity in such situation, plus it can induce a complete AV block. Surgical intervention, in a series of patients with T54 in 1994 itself, it has been found that acute severe MR, which can sometimes aggravate the disease condition of acute carditis, mitral valve surgery may be life-saving. But and that happens as a result of ruptured body. But however, outcome was found to be better if the surgery is done after resolution of active carditis for the region which is obvious to everybody. And interestingly, there are case reports of maximum 20 so far detected. The patient required permanent pacemaker implantation in a setting of acute rheumatic fevers itself. And that happens as a result of valvulitis producing some injury to the common AV node. They're requiring permanent pacemaker. However, here in majority studies, case reports, they have waited maximum for 7 days. They did not wait beyond that period. Maybe the valvulitis would have resolved and patient would have done fair without a pacemaker. That remains unanswered so far. And other manifestation, chorea is one of the late manifestation where essential criteria fulfillment is not required. If it is persistent and troublesome, anti-epileptic drug can be given. And a pediatric neurology study has suggested, a journal which is published in Pediatric Neurology Journal 2010, in selected case share of unresponsive chorea, steroid may shorten the duration. Subcutaneous nodule and erythema marginatum, they do not require any specific treatment. Now coming to the prevention, as you know, rheumatic fever, even if we treat, since it is recurrent, so there is a high chances of prevention, high chance of recurrence. So in those situations, prevention is the answer, particularly for a country like us. So as a student of epidemiology, we know there are 3 levels of prevention: primordial prevention, primary prevention, secondary prevention. All these 3 apply to rheumatic fever as well. And prevention is always said to be better than cure. But for primordial prevention, improvement of this, if we can improve this socioeconomic condition, that will actually put all these other factors into place, proper places, and we can prevent the gas infection itself, which is the NIDAS, or the primary step in the hierarchy of development of acute rheumatic fever. But primary prevention, I feel, is an important concept in our country particularly. If we can prevent and promptly recognize and treat gasopharyngitis, that will go a far way in preventing rheumatic fever development. Again, antibiotic is the main therapy, and injectable long-acting penicillin is the drug of choice. And the same drugs actually which are used for an acute attack can be used here. But if we want to prevent, then we have to give a lower dose and for an indefinite, for a duration, which we'll discuss later. Now for secondary prevention, the main thrust, unfortunately in Assam particularly, maybe in other parts of India as well, majority patients, they come to us in this stage only with an established valvular heart disease, or we just cannot do anything about the primary or primordial setup. So our main thrust is to prevent a recurrent rheumatic fever by reducing the chances of having a gas pharyngitis. Again, the injectable penicillin drug of choice, oral antibiotics in selected situations, though it is a second-line drug. So what is the frequency of dosing? Frequency of dosing in orally, it should be given daily once, and parenteral, and there is some controversy. 4-weekly interval, though there is no RCTs as such, but it is endorsed by majority guidelines and is probably all over the world. 3-weekly interval has been advised in certain high-risk situations like pregnancy, recurrence on 4-weekly regime, multivalvular involvement, congestive cardiac failure, at the development of rheumatic fever and heart disease at the younger age. Here actually, any cause you want to prevent a recurrent attack, thereby reducing chances of further damage to the valvular heart disease which has already developed. And 2-weekly regime, actually there are very limited data, so it is probably not endorsed by any of the guidelines. What should be the duration of secondary prophylaxis? There are 3 situations have been described. The patient may have a rheumatic fever but may not have carditis. In that case, he is quite safe. But interesting question is that though rheumatic fever is called mimetic, in subsequent attack, he may develop carditis. So we have to prevent his second attack anyway. He may have a carditis, but may not be any residual valve disease. And third category, he already had an established valvular heart disease or post-valve surgery. The various guidelines we are advocating different durations are American Heart Association 2009, WHO 2004 expert consensus, Indian guideline, our very own 2008 guideline, New Zealand guideline is quite new, 2014, and Australian guideline 2020. So if you compare all these guidelines, the first category where rheumatic fever without carditis, ACCS suggests the duration of prophylaxis for 5 years or up to the age of 21 years, whichever is longer. WHO has reduced the bar to 18 years, and so also are Indian guidelines. But if the patient has a rheumatic fever with carditis, it should be 10 years after the last attack as far as the ASA guideline. For WHO guidelines, same thing, but they have raised the age bar to 25 years because majority countries where rheumatic fever is still prevalent, they are lower socioeconomic status, so they cannot follow the American guideline as such. And our Indian guideline also follows dicto WHO guideline. But as far as the third category, that means prosthetic established valvular heart disease or a prosthetic valve surgery, either 10 years after the last attack or 40 years, or preferably lifelong, which is in the bracket. But WHO says there is no doubt about that, a lifelong prophylaxis. And Indian guideline, there is nothing like 10 years. It's a 40 years or lifelong. And this New Zealand guideline and Australian guideline, they are slightly different. And what I personally feel, probably they are country specific. And first category is more or less same, but in second category, the age bar, there may be some questions. Though this has not been replicated in different other studies. Now, do we really have benefit of secondary prophylaxis? And interestingly, the classical paper by Jones himself in 1950 circulation, this is a longitudinal 10 years follow-up of 1,000 cohorts. What they have found out, who have used prophylaxis, there is 70% less chance of developing rheumatic fever as compared to 20% in non-users. So it is more or less established from 1951 itself that secondary prophylaxis works. And interestingly, the adherence rate, though ideally it should be 100%, but 100% is basically an elusive goal in clinical practice. So by and large, it is considered at 80%. If someone has an adherence rate of more than 80% or equal to that, that is supposed to be a high adherence rate, and that is considered gold standard. But interestingly, that was defined rather arbitrary. So in 2018, an Australian Northern Territory RSD registry, they have analyzed and reanalyzed, and what they have found out, if the adherence rate is 40% or more, and this 40% adherence rate is considered to be a threshold, below which the recurrence rate is very high, and above which the recurrence is dramatically decreases. Though we prefer a 100% adherence rate to long-acting penicillin. So now, apart from antibiotics, do we have any other option? One option is vaccine for rheumatic fever. This vaccine has done a lot of rounds in the last 40 years, but there was no concrete result so far. Though theoretically it is the most ideal agent, and probably is an eye-opener after particularly the recent pandemic with COVID. But the problem with antibiotic prophylaxis is that in 15 to 30% cases of group A hemolytic streptococci pharyngitis, they remain asymptomatic. Nevertheless, they can develop rheumatic fever. And even if we promptly recommend and treat gasopharyngitis, antibiotic may not be able to prevent rheumatic fever development in each and every patient. So still there is a chance that patient can have rheumatic fever. That's why the vaccine has done a lot of actually rekindled a lot of interest all over the world. And the target antigen was M protein, which is ubiquitously present in streptococci bacteria. And that was considered that if you can develop an antibody against the M protein, probably that will eliminate rheumatic fever. But the problem was, see why it was not successful. There are more than 240 strains identified on the basis of M protein alone. And even if we are successful in development of polyvalent vaccine, because of the frequent mutations, just like coronavirus, the same polyvalent vaccine may not be suitable for all different strains. And moreover, this M protein, which was considered as the antigen of interest, is not ubiquitously present in all gas infection, including toxic shock syndrome, nephritis, and pyoderma. And interestingly, there is no conclusive data to link the presence of M protein with carditis. So, then what are the challenges we are still facing? So this is my personal opinion, of course, the opinion might vary. We are still facing challenges, particularly in our country, creating awareness among the masses and the physicians regarding the gravity of the disease and prevalence. There are still diagnostic difficulties because the echocardiography facility is not widely available in our country. And particularly, probably many people are aware about the World Heart Federation criteria to detect rheumatic fever on the basis of echocardiography criteria, which was defined in 2012, just to prevent over and underdiagnosis of rheumatic fever. Because in clinically, sometimes we can pick up a murmur, which may be benign. Then for primordial prevention, improvement of socioeconomic status is a must, and is a glaring example is a dramatic fall of rheumatic fever in Western countries because of this effect. And even after so many years of independence, we are yet to see that kind of improvement. So primordial prevention is a far cry at this moment. So what I personally feel, we can go ahead with prompt recognition and treatment of streptococcal pharyngitis, either at individual level or community level. But the question is that how accurately we can diagnose streptococcal pharyngitis. Though associations have defined the guideline to diagnose pharyngitis on the basis of symptoms alone, which may not be sufficient, and people actually require appraisal, particularly physicians require appraisal on that aspect, and confirmation by culture will not be cost effective in our country. So can we be integrated in a national control program for this community-based intervention? That remains an issue. And the second and last, but second point is, can we have a better formulation of injectable penicillin? Because injectable penicillin, all of us who are responsible for treating rheumatic fever patients, they will swear that penicillin is really painful. Many people do not like to have a second injection. Plus, it has a very risk of death because of anaphylaxis. So, our challenge is to develop a better formulation which is less painful and less anaphylactic. Regarding anaphylaxis, I have come as well reviewing the literature. There are so far 10 cases of death has been detected as a result of taking injectable penicillin, and out of which probably one can be attributable to anaphylaxis. Rest were not because of anaphylaxis as such. The reason is given as those patients are particularly poor countries, multivalvular, for them very sick. A lot of them are dehydrated. The pain of the injection itself can induce a vasovagal symptom, leading to hypotension and hemodynamic instability. A patient can arrhythmia and die, not because of the anaphylaxis of the injection as such. But still, that risk is very real and it remains till today. And our last challenge is to develop an effective vaccine for all strains of gas. So to just summarize, rheumatic fever and rheumatic heart disease are still prevalent in our country as well as in Assam. Primary prevention, I feel, may be the best policy for our setup. And for involvement of government and community participation is important for premordial prevention. And if we have to eradicate rheumatic fever of our country, we have to overcome those challenges. Thank you very much for patient hearing.
Thank you, Dibba. Probably a very, very lucid and exclusive description. It is a neglected field in our specialty. So it is quite common. We do see the rheumatic heart disease, multivalvular disease, mostly in the poor community and remote area. But one thing is there that rheumatic fever and carditis, acute rheumatic fever has drastically reduced probably over the period of last 3 decades. When we were student or we were junior faculty, you could see half of the patients with heart failure in the ward are with rheumatic heart disease. Now we have to pick up some multivalvular disease during the time of examination. This dramatic decrease without any prospective government program to reduce rheumatic heart disease is probably misuse of antibiotics, because streptococcus is very, very sensitive to any form of antibiotic. So nowadays, best of best antibiotics are being used in children's moment they do have some sore throat or any fever. So probably this is the good result of misuse of antibiotics. But anyway, still we do have rheumatic fever, crippling valvular heart disease, particularly those very areas. I think Dibbo will agree with me. In Dibrugarh, if any rheumatic heart disease, multivalvular diseases are coming, means either they are from Majuli or from tea garden area or from Sore area. So a lot of things to be done in those very areas.
Yes, very rightly said. And I personally feel Dr. S.C. Kulleri wanted to be expert in rheumatic fever and rheumatic heart disease, because he was instrumental. Majority of the ICMR sponsored trial on rheumatic heart disease in school health program, and so many. And actually, he is quite right, because the incidence of rheumatic fever as such has come down. We are basically dealing with this secondary prevention point.
Yeah, in the ICMR school health program, my center, you were also there. We
Yes.
were part of that very scheme. Any of our chairperson would like to comment on this very topic, because we are probably short of time.
Thank you, Professor Dutta. It's a very nice presentation. My comment is, secondary prophylaxis or secondary prevention is in the domain of the cardiologist, but the primary prevention is for the general physicians. So these informations should be properly disseminated amongst other physicians, general physicians, including the general practitioners. It was a very vivid presentation, very nice presentation. Thank you very much.
Actually, rheumatic fever has become a neglected part in clinicians, particularly young cardiologists, because their entire training was angiography and angioplasty. So recently on the structural heart disease intervention has come up. Maybe it will rekindle some of the interest. And then thank you very much for your nice comment.
Thank you.
Thank you. So we'll move on to the next topic, exercise and heart, by Alok Jyoti Malakar. Deepti, are you here? Would you please take over?
Yes,
please
sir.
take over. Please take over.
Yeah. Now, this is an interesting topic, exercise and heart. Recently, we have seen some very healthy young people who exercise regularly, who eat healthy diet, they're dying of heart attacks. So this is an important thing to know, actually, what kind of exercises really help the heart. And let us hear from Dr. Alok Jyoti Malakar. He's a cardiologist in the Department of Cardiology, Jorhat Medical College. Dr. Malakar, I'd like to request you to start your slides, please.
Thank you, madam. Very good evening to all. Thank you, the organizer, for giving me this opportunity. So, am I audible?
Yes, yes, very much audible.
Thank you, sir. I am sharing my slide. So my topic is exercise and heart. How much is enough? So coming to the introduction, exercise and heart is a very important topic, as it has been established that exercise prevents many of the cardiovascular disease. So cardiovascular specialists require an understanding of exercise physiology, its benefit and risk, and the cardiovascular adaptation that occur with exercise training, because many of the symptoms of cardiovascular disease appear during stress of physical exertion. Patient with or without cardiovascular disease request advice on exercise from cardiovascular physiology specialists. Cardiovascular specialists are often consulted to decide whether abnormal findings in an athlete represent disease or it is due to some physiologic response to exercise training. And cardiovascular specialists must commonly evaluate symptoms in any active individual associated with exercise. So increased physical activity and fitness are clearly associated with reduction in the risk of cardiovascular disease, but the optimal intensity of or amount of exercise necessary for reduction in risks or risk factor is unknown. Studies that followed large group of individuals for many years have documented that the protective effect of physical activity for a number of non-cardiovascular chronic diseases such as non-insulin dependent diabetes mellitus, hypertension, osteoporosis, or also in colon cancer. In contrast, we see a higher rate of cardiovascular event and higher rate of death in those individuals with low level of physical activity. So coming to some specific term, physical activity, it refers to any body movement that produce substantial increase in oxygen consumption. Exercise, physical activity designed to improve health or to obtain performance benefit is considered as exercise. Exercise requiring primarily an increase in oxygen consumption, and oxygen transport is referred to as aerobic exercise. Whereas exercise primarily stretching the skeletal muscle system is referred to as resistance exercise. So cardiovascular response to exercise. Physical activity increases oxygen demand, which prompts the cardiovascular system to increase cardiac output and also arteriovenous oxygen difference. 1 liter of increase in oxygen consumption produces around 5 to 6 liter in increase in cardiac output. Cardiac output is increased by augmentation of both heart rate and stroke volume. So several mechanisms is there that increase arteriovenous oxygen difference, include shunting of blood from renal and splanchnic vascular bed to exercising muscle. Then hemoconcentration from loss of plasma fluid into the extravascular space as a result of the osmotic force produced by metabolic release into the interstitial space during exertion, and increased arterial oxygen extraction by active skeletal and cardiac muscle. There is also increased myocardial oxygen demand and myocardial oxygen consumption. Myocardial oxygen consumption depends in part on heart rate and systolic blood pressure and increases with exertion because both heart rate and systolic blood pressure increases. This increase in oxygen demand can produce ischemia in individual with flow limited coronary artery lesion. Normally, in physiologic condition, coronary artery should be dilated during exercise, but with coronary atherosclerosis, inadequate coronary vasodilation or some vasoconstriction develop because of endothelial dysfunction. The cardiovascular response to exercise has both an external work and internal work rate. This external work rate is the oxygen consumption that is required by the exercise task. It is a direct determination of cardiac output. Then the internal work rate refers to myocardial oxygen required for the exercise tasks. First one, external was required for the exercise, required by the exercise task, and internal work is required for the exercise tasks and is directly related to increase in heart rate. Coming to CV, cardiovascular adaptation to exercise. Intense and prolonged aerobic exercise produces an array of cardiovascular adaptation. Commonly, this is referred to as athlete heart. So in athlete heart, there is increased vagal tone and decreased resting sympathetic tone. So mainly in highly trained endurance athlete. This is associated due to this increased vagal tone and decreased sympathetic tone. There is resting bradycardia, marked sinus arrhythmia, and sometimes there may be first degree AV block and Mobius type 1 AV block. Sometimes there may be asymptomatic third degree AV block in during the time of sleep. There may be fourth chamber enlargement, mild increase in LV wall thickness, and small increase in aortic dimension.
Your slides are not moving.
So
yes,
in contrast to the extensive cardiac changes reported in endurance trained athlete, strength exercise training produces modest increase in LV wall thickness. So here there is some difference of endurance training and strength training, the cardiovascular response, CV adaptation. In endurance training, there is mild to moderate eccentric left ventricular hypertrophy, and also there may be RV dilatation and biatrial enlargement. There may be normal to slightly reduced resting LV ejection fraction. In contrast to strength training, there is mild concentric LVS but no RV remodeling, normal to mildly enlarged left atrial size, and normal to hyperdynamic resting LV EF. So this is a study. Here the upper limit of physiologic cardiac hypertrophy in highly trained elite athlete has been shown. They have found that among 947 national and international caliber Italian athletes, only 16 had LV wall thickness more than 12 millimeter. Another study, physiologic left ventricular cavity dilatation in elite athlete. LV end-diastolic chamber size was greater than 55 millimeter, the upper limit of normal value, in 45% of 1,300 elite Italian athletes. So in this study, an young athlete start his national competition at the age of 22 years. So during that period, his internal dimension, LV internal dimension was 55 millimeter. After 4 years, at the age of 26 years, he attained Olympic Games, and during that period, his internal dimension was 57 millimeter. And after detraining, so this is very important, after detraining, 6 years of detraining, this dimension was reduced, and also the thickness, intraventricular septal thickness also reduced. So detraining may help in clinically differentiating adaptation of exercise training to pathologic hypertrophy or pathologic dilatation, say due to some hypertrophic cardiomyopathy or other diseases. In another study, serial hemorrhagic in a 26-year-old Olympic rower, at peak training, the ventricular septal thickness had decreased from 15 to 10 millimeter after detraining. So clinical effect of exercise training is there is increased consumption, increase in cardiac stroke volume, increase in maximum exercise cardiac output. There is increase in resting parasympathetic tone and decrease in sympathetic tone, decrease in resting heart rate. So benefit of regular exercise on cardiovascular risk factor, there is increase in, as the exercise capacity increases, so there is increased exercise tolerance. Increased exercise duration and increased intensity will lead to in more calorie burn, and there is reduction in body weight. There is reduction in blood pressure, reduction in bad cholesterol, increase in good cholesterol, and also there is increase in insulin sensitivity. So effect of habitual physical activity on cardiovascular risk. Study shows more active participants have lower cardiovascular risk than sedentary counterparts. Approximately 40% reduction in risk with habitual physical activity. Even small amount of physical activity reduce the severe risk. So severe risk falls progressively with increasing physical activity until approximately 9 hours per week of moderate intensity activity, such as brisk walking. So implementation of exercise training, the type of activity, frequency, duration, intensity, and progression determine the effect of an exercise training program. Moderate intensity activity confers cardio protection to both men and women. High intensity exercise programs are often associated with poor adherence to more musculoskeletal injuries. That is why moderate the emphasis given on moderate intensity activity. So what are the cardiovascular risks of exercise? This is very important. Vigorous physical activity transiently increase the risk of sudden cardiac death to susceptible and also acute myocardial infarction to susceptible individual who have pre-existing cardiovascular disease. Exercise-related sudden cardiac death in young individual has been attributed to some inherited and congenital conditions such as hypertrophic cardiomyopathy, anomalous origin of coronary arteries. Acquired conditions like myocarditis and cardiomyopathy also may be responsible to some extent in sudden cardiac death during exercise. So recent study shows 40% of SCD in young athletes remain unexplained, maybe due to inherited channelopathy. Hypertrophic cardiomyopathy is responsible for only 6% of death. However, the risk is extremely small. For adults without existing heart disease, the risk of cardiac event or complication ranges between 1 in 4 lakhs to 8 lakhs of hours of exercise. For patient existing with existing heart disease, an event can occur in 1 in 62,000 hours. Importantly, the risk of cardiac event is significantly lower for a patient for a person who exercise 5 times in a week. Atherosclerotic cardiovascular disease causes most exercise-related acute myocardial infarction and SCD in adult. AMI during exercise in previously asymptomatic adult usually associated with acute coronary arterial plaque disruption, but fortunately, exercise-related CV event appears to be low. So, exercise and risk factor modification. There is decreased blood pressure, both systolic and diastolic, blood glucose decrease, increase good cholesterol and decrease bad cholesterol. There is also reduction of weight. So, other effect of exercise in secondary prevention. It halts the progression of coronary artery disease as there is some effect on systemic inflammation. Exercise reduce the systemic inflammation, ultimately reduce the endothelial function, reduce the bad effect of endothelial one, ultimately improve endothelial function. Now, how much is enough? So current guideline, any physical activity, usually those who are not in sedentary habit, any physical, if they start any physical activity, that may be helpful for reducing cardiovascular risk. So current guideline suggests a minimum of 150 minutes of moderate intensity activity such as brisk walking, swimming, or at least 75 minutes of strenuous activity. The moderate intensity is around 3 to 5.9 metabolic equivalent, and strenuous is more than 6 metabolic equivalent. The same physical activity levels are recommended for patients with type 2 diabetes by the US and European guideline to reduce atherosclerotic cardiovascular disease risk, improve glycemic control, and to help with weight loss. 2016 European Society of Cardiology guideline cardiovascular disease prevention in clinical practice recommended minimum of 150 minutes of moderate or at least 75 minutes of strenuous physical activity per week. ESC guideline also include recommended bouts of exercise with a preferred recommendation of 4 to 5 times per week, preferably daily or at least 10 minutes in length. So how should we begin if we want to become more physically active? First, if anyone currently have heart disease or are over 45 years of age, have or having 2 or more conventional risk factors, cardiac risk factors, should consult physician before starting any type of exercise. As guideline says, most people derive significant benefit from integrating an half an hour of moderate intensity activity. If half an hour is difficult for anyone, then try to work more activities into day by day, adopting shorter period of activity such as 10 minutes duration activity, frequent 10 minutes duration of activity. The most important thing is to get started, as any type of activity other than sedentary habit may have beneficial effect in cardiovascular health. So in conclusion, exercise or proper physical activity is an important component of cardiovascular health or cardiovascular disease management. Such activity must be individually prescribed as per the age, sex, and pre-existing cardiac condition. For being healthy, we must adopt active lifestyle. Thank you.
Thank you, Dr. Malaka. That was an excellent presentation. Now, the thing is, what about the role of yoga? Yoga comes under what kind of exercise? Like,
yes, yoga actually, in yoga, most of the yogas are called asana. They have improved some by other way. Also, before going to yoga, some amount of warm up is also done before going to yoga. So that warm up may be that activity, physical activity, and yoga is the mechanism of yoga and this physical activity is different. But both yoga and physical activity should be simultaneously go on. If we can adopt yoga, that may improve our mental health also. That may reduce our anxiety, and also like brisk walking or like the other physical extraneous activity, it may help in reducing our most of the cardiovascular element.
It is our experience. Probably many of the people, if you ask, do exercise? Yes, I do yoga. So in our perception, aerobic exercise must be, whether they do yoga or not, that is different. So that is most important. Probably the importance of exercise has been since early part of 19th century by William Haberden, who himself was the man who coined angina pectoris. Because one of his patients, who was a woodcutter, he used to saw the woods in spite of his disease to the limit of his symptoms. And he described that that very person recovered subsequently. So that's how probably the importance has come. And now there are ample evidence that both in primary and secondary prevention, exercise is definitely important. Only on 27th of August this year, the latest ESC guideline has come, where they have increased that exercise duration from 150 to 300 minutes per week, moderate exercise, and strenuous exercise 75 to 90 minutes. And frequency should be at least 5 days in a week. And at no point it should be, I mean, your exercise should not be stopped more than 2 weeks, because the benefit of exercise is not carried over. If you do exercise, it will maintain. If you stop for a month or 2 weeks, the benefit of exercise is gone. So exercise has to be carried on. Thank you very much. It is a very lucid and very descriptive, well presented.
Dr. Malakar.
Yeah. Please.
Dr. Borua.
Yes, sir.
Yes. Okay, that was an excellent talk with a lot of things to know and a very lucid presentation. But what I say, nowadays,
You are not audible, sir.
I'll just unmute.
Yeah.
Sir?
Now you are audible. Sarup.
Okay.
Hello, Sarup. We could not hear you.
Dr. Malakar.
Yes. Yes.
Yeah.
Hello.
Hello.
Dr. Malakar. This is Dr. Bhattacharya.
Sir.
What should be the ideal duration of morning walk, which is undertaken every day? It is a very general question asked by the patients very frequently. What should be the ideal duration of the morning walk?
Yes, sir. It is actually, it should be individualized. If anyone starts for the first time at the up to the tolerated level, he can continue his morning walk, and gradually he should increase his duration and intensity of the exercise up to the tolerated level. And guideline, as if he starts first, then he may be able to walk for 10 minutes initially, but gradually he will have to increase up to at least 30 minutes a day. That should be also brisk walking. That should not be like a lazy walking. So at least 30 minutes for 5 days. And if it is more than that, that will be also beneficial. As Sir has told, up to 300 minutes of brisk walking per week. After that, one thing is very important, that after that amount, say more than 300, say 400 or 500, after that amount, the beneficial effect is not increased linearly. It may be decrease, there may be diminution of the beneficial effect.
Yeah. Again, another important point in exercise program, that you have to have an warm up and cool down period. At least nearly 10 minutes you have to warm up, gradually increase the speed, go to the peak. Then again, once you completed 30 minutes minimum, then cool down for another 7 to 10 minutes. Otherwise, sudden increase and sudden stoppage of exercise may have detrimental effect, particularly arrhythmia. I think we will close them because we are, yeah, Saurabh, would you like to comment anything?
Just one more, 1 minute. This
Sure.
one, because with the available smartwatches, you can quantify your exercise with steps. 1,000 steps contain around about 1 kilometer. So is there any restrictions up to how many kilometers you have to walk? Because on emergency days, my postgraduate students had to walk around 14,000, 15,000 steps, 14 to 15 kilometers in Guwahati Medical College. I keep track on them. Up to 18 kilometers they have to walk. So is there anything they quantify or so many kilometers you have to walk? Because you can quantify.
These steps is basically, yeah. Saurabh, I think I will answer your questions. These steps are basically more important for sedentary habits, those who are basically sedentary. 4,000 steps, wherever he is going somewhere, going to the market, climbing upstairs, 4,000 steps per day at different times is much better than a sedentary life. I mean, he may not have the capacity or time to go for regular exercise. But going beyond 800 steps, you do not get an additional benefit.
8,000.
So, yeah, 4,000. It should be per day. Everybody should have at least minimum 4,000 steps at different times. At different times, walking in the level, climbing stairs, or going to the office. So if you're 4,000, then it's good.
One thing, sir, as you have told, as we have increased the upper limit, as we have crossed the upper limit, say more than 300 minutes per week. So a person with this upper limit or more than that may have some skeletal injury. So
yeah,
ultimately, it will
injury,
lead to the non-adherence to the exercise.
Okay, we'll move on to the last topic in this brief session. Dr. A.H. Chaudhary, fluctuation of blood pressure, approach to management. Dr. Chaudhary, please.
Slide, please.
Yeah.
Yes, sir, I am here.
Yeah,
Am I audible, sir?
Please go ahead.
Yes. This is the fluctuating blood pressure and its clinical implications, sir. I'll generally keep myself with the variability of the blood pressure and the cardiovascular risk of it. Sir, we know it doesn't move. Yes, sir. Leading blood pressure is a global burden, sir. Hypertension, as we see, sir, 69% of the first MI are associated with hypertension, 74% of the coronary heart disease, 77% of the first stroke, and 91% of the congestive heart failure are generally associated with hypertension. Then reduction of the blood pressure is so much important. Just 2 mm reduction of the systolic blood pressure reduces the ischemic heart disease by 7% and stroke by 10%. Then again, benefit of the BP control, we can see 10 mm reduction of the systolic blood pressure, 50 to 60% lower risk of stroke, 40 to 50% lower risk of coronary arterial disease, and 50% lower risk of congestive heart failure. Greater benefit with older age. Then this is CSI cardiac prevent trial, which was conducted in 21 states of India, around taking about 2 lakh people. 36% of the general population of Hyderabad were affected. Okay, sir. Then if we consider the blood pressure pattern of our country with the help of 142 meta-analysis, we can see that the prevalence in rural area is around 28%, in the urban area is 34%, awareness in 25% in the rural area, awareness is 42% in the urban area, treatment is 25% in rural and 38% in urban, control is only 10% in the rural and 20% in the urban. Then blood pressure, there are some important things which are actually not so much considered. BP variability is one very important thing, central blood pressure and the aortic stiffness and masked hypertension. Then these are actually some BP reactivity. BP reactivity is a very important phenomenon, sir. When generally our blood pressure responds to the various stressors, suspected to be predictive of future development of hypertension and cardiovascular risk. Studies have not found this to be very much true. Then BP lability. BP lability is another characteristic of the human blood pressure. It is always labile. Blood pressure is generally labile. No clear definition that differentiate normal than abnormal blood pressure lability. Labile hypertension widely used, lacks an accepted definition, and is more clinical impression rather than a specific diagnosis. Blood pressure experience transient but substantial increase in patient experience transient but substantial increase in blood pressure. This is likely due to the sympathetic activation. BP usually falls without any intervention. Then these are actually the various types of the blood pressure variability. There may be bit-to-bit variability of blood pressure. There may be 24-hour blood pressure variability. There are day-to-day blood pressure variability. There are visit-to-visit blood pressure variability. So these are the different types of the blood pressure variability. And each and every blood pressure variability is important. Each and every blood pressure variability, if it is there in that condition, there will be endocrine damage will go on increasing. So pronounced fluctuation in blood pressure can occur over short and long-term observation periods. Finding difficulty.
Sir, you have to tell me next to proceed.
Next. So blood pressure variability and CV risk. We can easily see from this particular slide that if there is abnormal blood pressure variability in that condition, all-cause mortality, non-cardiovascular mortality, CV mortality, everything increases. Next. So this is the blood pressure variability and hazard ratio for stroke. With the mean systolic blood pressure or standard deviation of the systolic blood pressure or the coefficient variation of the systolic blood pressure, in everything we see that the stroke incidence goes on increasing. Next. So for that actual reason, though classical definition of the hypertension comes from the official blood pressure measurement, but there may be elevated, it may be elevated when the true blood pressure is normal, white coat effect. There may be normal when true blood pressure is elevated, masked effect. Office measurement may not reflect the diurnal variation. For that reason, 24-hour ambulatory blood pressure monitoring is a precise method to quantify the blood pressure level and diagnose hypertension. Next. So this is where the 24-hour blood pressure, 24-hour blood pressure measurement. Several studies has compared ambulatory blood pressure measurement with the intra-arterial blood pressure measurement and mercury column sphygmomanometer, and it has been found that the 24-hour blood pressure monitoring is very much important for us to diagnose a host of problem, as for example, the BP variability, circadian changes, the effect of environmental and emotional conditions of the blood pressure level, etc. Next. So this is one 24-hour blood pressure, ambulatory blood pressure monitor. Next. With the ambulatory blood pressure monitor, another very important thing is that the home blood pressure monitoring. This is a self-monitoring tool that can be incorporated into the care of the patient with hypertension and is recommended by major guidelines. A growing body of evidence supports the benefit of the patient home blood pressure monitoring compared with the office-based monitoring. These include improved control of blood pressure, diagnosis of hypertension, diagnosis of masked hypertension, and prediction of the cardiovascular risk. Next. So recommendation of the home blood pressure monitoring is there. A nice guideline is that generally at least twice blood pressure should be taken if home blood pressure monitoring is considered, at least once in the morning and once in the evening. Next. This is the Omron digital home monitor. Possibly it has it is generally recommended now by Indian Hypertension Society also. Next. So which one is better? Is home blood pressure equivalent to ambulatory blood pressure monitoring? So ambulatory blood pressure monitoring, home blood pressure monitoring, and clinical blood pressure monitoring or office blood pressure monitoring. Supervision is present in ambulatory blood pressure monitoring. Supervision is not present in home blood pressure monitoring, may be present, and clinical blood pressure monitoring supervision is there. BP pattern, day and night time pattern can be seen, day and night time pattern, visit to visit pattern can be seen in ambulatory blood pressure monitoring. Only daytime changes can be seen in home blood pressure monitoring. In clinical blood pressure, in office blood pressure monitoring, only the office blood pressure, the patient visit blood pressure can be seen. The blood pressure variability 24-hour visit to visit blood pressure monitoring can be seen with the ambulatory blood pressure monitoring. Home blood pressure monitoring, day-to-day change you can see, and office blood pressure monitoring generally visit to visit change in the blood pressure we can see. Prediction of the outcome, best ambulatory blood pressure monitoring, nighttime hypertension is very much crucial, and that can be diagnosed with the help of the ambulatory blood pressure monitoring. Superior to clinical blood pressure monitoring, home blood pressure monitoring. And though the home blood office blood pressure monitoring is the standard tool for diagnosis of hypertension, guidance to the treatment most complete with 24-hour blood pressure monitoring. It is not actually complete, little limited with home blood pressure monitoring. Clinical blood pressure monitoring, it is limited and very much poor. Improving compliance may be very much helpful with ambulatory. Best evidence with home blood pressure monitoring and minor influence with office blood pressure monitoring. Next. These are the various guidelines of self-monitoring of the blood pressure is an important means of improving adherence. Next. These are Japanese Society of Hypertension recommendation of home blood pressure monitoring 2009. Next. This is how ambulatory blood pressure monitoring and the home blood pressure monitoring has given us the diagnosis and the definition of hypertension. With clinical blood pressure monitoring is generally 40 to 90 millimeter 90 millimeter of mercury. With ambulatory home blood pressure monitoring, it 135 to 85 millimeter of mercury should be considered as hypertension. Nighttime hypertension should be considered when the blood pressure is above 120 by 80 millimeter of mercury. Ambulatory blood pressure monitoring giving us this facility, and 24-hour blood pressure monitoring is giving us the facility that if it is more than 130 by 180 millimeter of mercury, according to the SEC and the AHA guideline, it should also be considered as hypertension. Next, where we are missing. Next, this is the out of clinic blood pressure, the masked hypertension, which is associated 70% increase in the cardiovascular risk, and white coat blood pressure, the clinical blood pressure, white coat hypertension. This is also associated with subsequent increase in the number of hypertensive patients and subsequent cardiovascular mortality. Next. This is the diapers and non-diapers. Generally, less than 0%. If it is generally 10 to 20% diaping should be there with at the night. If it is less than 0%, it is reverse diaping, very bad actually. 0 to 10%, it is also non-diaping. It is also very bad. 10 to 20% if it is diaping, and more than 20% it is extreme diaping. Next. 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 So this is the morning surge of the blood pressure. Early blood pressure, early morning blood pressure more than 135 to 85 millimeter of mercury. Pattern of morning hypertension. It may be extension of the nocturnal hypertension. It may be the BP variability, and there may be morning surge also. All are associated with increased cardiovascular risk, occurrence of various events, occurrence of target organ damage. They generally do happen, particularly when the patient is under stress, when there is obstructive sleep apnea, patient had drinking in the night, and old age, and the drug did not cover the 24 hours interval. So next. So therapeutic consideration little bit. Next. So NICE is actually giving us the guideline that whatever the underlying mechanism, systolic blood pressure variability appears to be important. Independent.
You have to cut short because we are.
Yes, sir. I'm going to the next last slide ultimately. So next. Yes, just before one. So the one before. So regarding treatment, actually, the amlodipine actually gives us the best facility of overcoming the blood pressure variability, and also the combination therapy, telmisartan and amlodipine. You can see from this slide actually. From this slide actually, this is the amlodipine arm, and this is the amlodipine and telmisartan arm. They actually give us the best control of blood pressure variability, daytime and nighttime, whatever it is. Next. So blood pressure variability control should be considered as a goal to guide choice of initial antihypertensive treatment. The mean blood pressure should be monitored as it is a potential marker for blood pressure variability. Calcium channel blockers are the antihypertensive class of choice for blood pressure variability control. Among calcium channel blocker, amlodipine as initial monotherapy has proven efficacy in reducing the blood pressure variability and mean blood pressure surge. Synergism between long-acting calcium channel blocker and ARB is definitely there. Next. Thank you very much, sir. Sir, time is very much less as a result.
Thank you, Dr. Chaudhary. It is a very long topic, I do understand. So within a short, limited time, you could cover almost everything. We do know that variability of the blood pressure is a risk factor, cardiovascular risk factors. But we are yet to know what is the threshold of this variability. Secondly, what would be the therapeutic module? Obviously, theoretically speaking, and also this one trial which has shown that amlodipine is a better drug to reduce the variability. In other words, any drug which has got a long half-life is the best drug to control the variability.
Yes,
there is only one trial that I could remember. It was published in 2019 from Spain, which is called Hygia trial.
Yes,
where they have given the antihypertensive dose at night time.
Yes,
and on 48 hours ambulatory blood pressure monitoring at different intervals has been shown that variability is reduced.
Yes.
But whether that this variability, reduction of variability is contemplated to outcome, that has not been proved at years because those very patients has to be longitudinally follow up. But anyway, this is a part BP variability, just like in diabetes, we may have a control HbA1c, but there may be strong variations. Mean blood sugar is not the importance, it is the variability of the blood sugar is important in diabetes. So also in hypertension, the mean control of blood pressure of several readings is better as on today. But at the same time, variability of blood pressure is also equally important for risk factors. Because of paucity of times, I do not like to allow any further. Yeah,
may I make a comment for 1 minute?
Yeah, please, and close the session.
Nowadays, for a variable blood pressure, labile hypertension, fluctuating nocturnal white coat hypertension, the biosensors of hypertension is coming up. That is optical, it may be an optical biosensor, it may be electrochemical, or it may be colorimetry. It can be worn in a ring, in a wristwatch, in an eyeglass. So continuous monitoring whatever the patient goes, it can be pushed in a ring also. So this will help definitely for particularly this for labile hypertension, nocturnal hypertension, postural hypertension, white coat hypertension. These are coming for biosensors in hypertension.
Yeah, right.
Thank you.
That will give better understanding and better detection of labile hypertension, fluctuating hypertension. But yeah, but we are yet to have long-term reports whether treating them we get the outcome. Expected to have outcome, but we probably have to wait for a few more years. Thank you. Thank you for.
Beta blocker is one of the important drugs for this one.
Yeah. Beta blocker particularly.
Not a good drug, sir. Beta blocker is generally not considered.
Yeah. Anyway, thank you all the speakers. You have covered the things very nicely, and in the preventive field of cardiology, this will help in many ways. Thank you, the organizers, for giving up some extra times. This is probably for the electronic glitches. We had to take a little bit more time. But anyway, I declare the session is closed. Thank you.
Thank you very much, sir.
Thank you.
Coronary artery disease. May I please request Dr. M.S. Chaliha to introduce the chairpersons. Over to Dr. Chaliha.
Good afternoon, everyone. The next session, which is coming up, is a very important session related to ischemic heart disease, coronary artery disease. As we all know, that in worldwide every year around 19 million people die from cardiovascular disease, and out of this huge population, 50% of them die from coronary artery disease. So here we in the coronary artery disease session, we have got some important topics related to the detection, prognostication, and treatment of coronary artery disease. And the session will be shared by Professor Anup Kumar Burman, who is the former HOD in nephrology, Guwahati Medical College, and Amal Dev Goswami, who is from Namecare Hospital, who is a very senior internal medicine specialist, and two young and dynamic cardiologists, one from Narayana Hridayalaya, Dr. Ritankur Baukotoki, and Krishna Narjari from JNRC. They will be in the chair. So I hand over the session to the chairpersons to start the first talk. I hand over the session to the chairpersons to start introduce the speaker and start the first talk. Am I audible?
Yes, you are audible. Chairpersons are not responding.
So the first, Anubda, you can call upon Dr. Manish Kapoor, who will be talking on a very important topic, that is optimal medical therapy for coronary artery disease, which is an up and coming topic. Although it is not a new topic, it has been there for ages. Since so many trials like Barry 2D and CARES, but nowadays after ischemia trial, it has assumed greater significance in the contemporary clinical cardiac practice. Dr. Manish Kapoor, please.
Yeah. Myself, Dr. Narjari here. Let me introduce our first speaker of this session. Can I have the previous slide, please? Let me introduce Mr. Kapoor. Yeah, our first speaker of the session, Dr. Manish Kapoor, is a senior cardiologist there in Shillong, presently working as an associate professor there. So he'll be talking on the first topic, medical therapy for CAD. What is optimal? So I request Dr. Kapoor to start his talk.
Thank you, Dr. Narji. Very good evening from Shillong. I hope I'm audible. At the outset, my gratitude to the organizer of this Northeast Cardiology update for giving me this opportunity. And when Dr. Rikipanna called me for this presentation, when he called me for this presentation on the topic medical therapy for CAD, what is optimal? So then it reminded me the fairy tale that we have read in our school days, that Goldilocks and the 3 Bears. Basically, the Goldilocks and 3 Bears is a story, fairy tale, which has been about the 3 bears and their girl. But basically, this is in modern context being used to describe a situation where something has to be exactly right. And also, the theme of story deals with how your actions might hurt others. I think I'm sharing my screen. So,
sir, I'm sharing your screen. You have to say next.
Next, please. Okay, you're running from there. Next, please. So, the optimal medical treatment is in coronary artery disease manifests as stable angina pectoris. That is, in the modern name is the chronic coronary syndrome or acute coronary syndrome, which is often being treated with the help of percutaneous coronary interventions or CPG. However, concomitant use of optimal medical therapy remain essential for these patients. Optimal medical therapy not only improves outcome in these patients, but it is very, very important in making the choice of whether one should go for percutaneous or surgical revascularization. Rather, this is more important to choose optimal medical therapy optimally, rather than the more stress should be on this part rather than on the interventional part. Advances in technology of invasive procedures historically have been compared always with the standard medical therapy available at that time. Next, please. So the comparative studies helped to establish the safety and efficacy of the newer treatment modalities, but also led to several fundamental misconceptions. Studies comparing intervention and medical therapies plus medical therapies were always compared with OMT alone. But when the result came, the superiority of these invasive therapies along with OMT was only shared with the invasive part of the therapy, rather than OMT was not given. The optimal medical therapy was never given its due credit. So this perception may have contributed to slow or delayed uptake of this concept of optimal medical therapy, as well as this has been looked at with some disdain, that probably using optimal medical therapy and not using the invasive arm is something not good. What constitutes optimal medical therapy now was not that which was used in clinical trials a few decades ago. OMT has also evolved as the coronary visualization procedure. Please click one more. So OMT is an evolving entity. Next, please. It's a moving target. Defining what constitutes its remain challenging, as Dr. Chalia was telling. Basically, as of now, optimal medical therapy is defined as 1 or 2 anti-angina drugs as necessary, along with drugs for secondary prevention of cardiovascular disease. And all patients, whether they are stable patients or acute coronary syndrome, should receive this optimal medical therapy unless contraindicated or not tolerated by them. Next, please. So, what is the aim of pharmaceutical management through optimal medical therapy? There are 2 aims that has to be clearly distinguished. One, to obtain the relief of symptoms, and to prevent the cardiovascular event. Click, please. So, relief of anginal symptoms, that is needed for immediate treatment or prevention of the angina. Rapidly acting formulations like what we have been using, sorbitrate or nitroglycerins or long-acting one, are providing immediate relief of angina once the episode has started or symptoms is expected. before any work. To prevent the recurrence of cardiovascular events like MI or death, we have to focus primarily on reducing the incidence of acute thrombotic events or development of ventricular function. And these aims are achieved by pharmacological or lifestyle interventions like reducing the plaque progressions or stabilizing plaque or preventing thrombosis. Next, please. So the primary target, that is the angina relief, is achieved through the first line therapy, that is short acting nitrate plus. That is the first step. Along with that, one can add beta blocker or calcium channel blocker depending upon the patient's heart rate, or titrating the doses, and then can consider adding on top of beta blocker, one can add the calcium channel blocker, specifically the verapamil or diltiazem like medicines to reach the heart rate control target. And once it has been, still it is not there, then one can add the second line drugs, that is the newer ones like ivabradine, long-acting nitrates, nicorandil, ranolazine, or trimetazidine. So this was to just control the angina. But the second and the more important is to prevent the event. That involves the use of aspirin, antiplatelets, dual antiplatelets, statins, and to prevent the LV dysfunction to set in, we may need, or to prevent the endothelial dysfunction to set in, we need the ACE inhibitor or ARBs. And along with that, angiography plus minus invasive therapies can be considered. Next, please. So here the standard therapy, how to build up is that the first is to prevent the angina. We are building up with the, can you click this one? Next, please. So standard therapy will be that. Standard therapy will be that there will be a beta blocker or a calcium channel blocker. That will be the first step in any patients of chronic stable angina you are going to build up. And then if heart rate target is not achieved, then one has to add the diltiazem or maybe the verapamil to achieve the target heart rate. If still patient is not angina free, one can consider adding the sorbitrate like a long-acting nitrate or the third line drug subsequently. The nicorandil, ranolazine, or trimetazidine being the part of the third line drugs. Next, please. So antiplatelet drugs in CCS, one may start with the low dose aspirin to prevent the event. These are the most important therapy to prevent the event. So low dose aspirin in the dose of 75 to 100 milligram per day, with or without myocardial infarction, or along with that, oral P2Y2 inhibitors can be added. DOPT in combination with the aspirin after PCS, for CCS, we are using up to the 6 months post PCI. And if patient is having high risk of bleeding, a consideration for just 1 month of therapy can be given for post PCI patient. But greater than 1 year after PCI, if it is given, it may decrease, although it may decrease the risk of stent thrombosis, but increases the risk of bleeding. While in atrial fibrillation, in chronic coronary syndromes, the newer oral anticoagulant are performing better than the warfarin, like the Epexivan, Dabigatran, or Ebroxavan can be given in their optimal doses. Next, please. So antithrombotic therapies in acute coronary syndromes, the after loading dose of aspirin indefinitely, the DAPT low dose aspirin has to be used indefinitely, while a DAPT may be used for primary PCI for 12 months. A patient has been subjected to fibrinolysis but not undergoing for the invasive therapies, one may recommend only from 1 month to up to 12 months. And these are debatable, and the newer generation of stents, the duration of dual antiplatelet therapies is being shortened, and anything in between one month to 12 months, depending upon the bleeding risk as well as the anatomical risk profile, can be taken care of by the thoughtful physician. Fibrinolysis with the subsequent PCI. If we have thrombolized the patient as well as offering the PCI therapy, then you need to continue the dual antiplatelet therapy for almost 12 months. Maybe if more than 1 year, there is also no formal recommendation for the use of aspirin on clopidogrel or aspirin plus prasugrel, but ASA with ticagrelor might be used for more than 1 year, up to 3 years. Next, please. So if a AF patient is undergoing PCI for ST elevation or non-ST elevation MI, the default strategy will be to use a triple therapy in the form of newer oral anticoagulant plus dual antiplatelet therapy, any of aspirin plus P2Y2 inhibitors like clopidogrel or ticagrelor or prasugrel. After 1 week of active therapy with the triple medications, if this is the default strategy, one can continue using, one can take out one of the one antiplatelet and a single antiplatelet along with NOS can be continued. But if there is an increased risk of bleeding, then one have to tailor the medications early, and after 7 days of intensive therapy, double therapy of any neurooral anticoagulant along with a single antiplatelet can be continued for 6 months, and then subsequently after 6 months, neurooral anticoagulant can be continued alone up to 12 months. While a triple therapy can be given if patient is at higher risk of ischemic events. Next, please. So when will we consider that the medical therapy is just right? Subclassifying medical therapy is important because whereas some seeks to assess, some treating physicians or some patients are seeking to assess the impact of revascularization only on cardiovascular risk prevention, whereas other addresses change in symptoms or quality of life. So it is, you have to draw a line what you are looking for, whether you want to minimize the symptoms in a particular patient, like suppose someone is elderly and doesn't want to go for any interventive procedures, you know that your symptoms, you want to address to the symptoms of that particular patient. But when you are looking for the prevention of the event, then the revascularization might be an important thing. And then the choice will depend upon the choice of decided by the physician as well as the patients together. Of course, we all want to address both the problems, but we have to make certain restrictions. OMT must be divided according to its two distinct goals. Whether you want to receive you want to have the optimum risk reduction therapy, or you want to have the optimum anginal therapy, and then somewhere adjusting in between two might be the best way to achieve the things. Stresses must be on the reaching predefined target by predefined target of risk factor like cholesterol goals, LDL goals, or blood pressure goals optimally by using the optimal target dose, and where we usually fail. We starting medications does not mean that the work has been done, but we should aim for achieving the target that is needed for that, for the prevention of the events in these particular patients. Next, please. Go back, please. So OMT for the stable CAD, like in the patients with chronic coronary syndromes, is recommended is the initial choice for all stable angina pectoris patients, especially if they are having low ischemic burden on stress test. Then the MAST-2 studies, this was underpowered for the clinical outcome, but there was in that study where they compared the OMT as well as revascularization versus between these two therapies, then they found that OMT was causing 60. On follow-up, they found that at 10 years, there was a OMT was able to have event were 69%, while the CVG was having approximately to the tune of 75%. So the difference was despite increase in the rate of MI and repeat revascularization in PCI and OMT groups. So survival was not affected. Basically, the invasive procedures have not affected the survival. They are just providing you the reducing the repeat revascularization or reducing the rate of reducing the chances of angina, but survival is not being affected. So the fear that if I'm using OMT and then I'm doing something inferior in terms of increase affecting the survival is should not be there. Next, please. In the Courage landmark trial, which was another trial that randomized more than 2,300 patients with 1, 2, or 3 vessels disease with left ventricle involvement to OMT or to the optimal medical therapy versus optical medical therapy and PCI, and that made lots of news. No significant difference was observed in the composite endpoint of death or non-fatal MI at almost 5 years of follow-up. Both groups were also equal in terms of freedom from angina. In its nuclear study, however, the reduction in ischemic myocardium was greater in the those who were subjected to interventional therapy. Next, please. In a meta-analysis of 8 randomized clinical trials involving more than 7,300 patients comparing initial coronary stem implantation versus optimal medical therapy over a follow-up of 5 years, found no difference in mortality non-fatal MI, or persistent angina. However, CABG confirms a better survival benefit in these patients with unprotected left main. Next, please. Therefore, it is appropriate to treat patients with stable CAD with optimal medical therapy, and the indication for risk-selection would be only to either persistence of symptom despite optimal medical therapy or improvement of prognosis. That is the improvement if LV dysfunction is going down because of the hibernating myocardium or the LV dysfunction is setting in, then they may be offered the invasive therapy. However, prior to risk-selection, patients must be ensured that they are receiving optimal medical therapy. And re-vascularization and AOMT, the optimal medical therapy should be seen as complementary rather than competitive treatment studies, and where we start feeling. Next, please. So there is, for acute coronary syndrome, as we know, aspirin and statins are needed for the substantial reduction. For the risk factor, DAPT comprising both dual antiplatelets, aspirin as well as the prasugrel or clopidogrel might be considered, and then subsequently aspirin alone may be. Okay. If DAPT is being tolerated, it should be continued for 12 months. AC inhibitor as well as mineralocorticoid receptors like eplerenone or eldectone are needed for post coronary syndrome patients with evidence of LV systolic dysfunction. Rather, AC inhibitors may be continued for the endothelial function promotion, and the beta blockers are recommended if there is a patient recommended in almost all patients unless patient is in cardiac shock or decompensated heart failure. Next, please. So, in post-revascularization, progression of atherosclerosis continues even after revascularization, and that has to be understood. And when this optimal medical therapy may give you benefit by producing or preventing the progression of the proximal diseases or the progression of coronary diseases in other vascular blood. Hence, optimal medical therapy is absolutely essential and complementary to revascularization, although it remains underused. Just two slides more. In EuroHeart survey, a sizable proportion of patients with chronic stable angina managed medically or invasively were not on optimal medical therapy, and that was associated with poor outcome. So, as I was telling, it remains underused. Next, please. So, in the most of the trial, you can see that the optimal medical therapy has been used. Like even in the Syntex trial, it was being used only in the 41% at the time of the discharge, and only 33% patients were taking it, receiving it after 5 years. So, all the components of OMT are important for reducing the adverse outcome irrespective of the revascularization strategies. Next, please. Therefore, it is essential that post-revascularization patients should continue to use AMT. For patients adherent to both AMT, both after revascularization offers similar outcome, whereas patient non-adherent to OMT, optimal medical therapy, CABG might be a better outcome, and that's why it is important to consider whether a person is going to adhere to the therapy or not. Next, please. Improving adherence with the therapy. It is well known that adherence is important, although with the chronic disease, there might be problems in adhering to the therapy. So important to address the patient-specific issue and trying to solve them. The uncomfortable truth remains that we are poor at attaining the optimal target dose for medication. Therefore, without proactive drug initiations and aggressive up-titration, we may be under-treating our patients and may never achieve the goal of optimal medical therapy. Next, please. So most of the post-ACS patients and post-revascularization patients are eventually followed up by the general practitioners. Therefore, it is important to convey the importance of optimal medical therapy to our clinical community, and long-term therapy is mandatory even after the complete revascularization. And getting medical therapy just right for clinicians requires community consensus, but for individual patient, it requires effort to initiate, review, up-titrate, and repeat the therapy again and again. Programs such as this may help to improve the OMT prescriptions as well as the patient's compliance. To conclude, next please. OMT for the vast majority of patients should include an antiplatelet agent, a lipid-lowering drugs for all patients, beta blocker, as well as any AC inhibitors. And along with drug, one must also address the cardiac risk factor and lifestyle management. Next, please. The last slide. So it is recommended as the initial choice for patients with chronic coronary syndrome as well as for the acute coronary syndromes. And for the institution of OMT is an intensive and iterative process where one has to have patients in which drugs need to be initiated, reviewed again and again, up-titrated, to meet the treatment targets and to reach the ultimate desired goal of our patients' well-being. Thanks a lot. Next, please.
Thank you, Dr. Kapoor. You have touched all the important aspects of this very important topic. And since we are running out of time, probably, although this topic invites a lot of discussion, we may not be able to have much discussion. If there is any quick comment or anything from anyone, from the chairpersons, that is very welcome. Dr. Narjari, would you like to say something? Dr. Narjari, would you like to say something?
No, Bigaganda, it was a very nice presentation, and as you have already said that we are running, we are going a little late, so we should move to the next topic if you allow. I think
we can have a discussion later on when all the topics end, if there is some time. Okay.
Yeah.
So we can move on to the next topic, isn't it?
Borman sir want to say something, sir?
Actually,
Borman sir, please.
Yeah, we can discuss all the subjects after finishing all our talk. We can straight away ask Dr. Rajesh Das to speak on his talk, the CT coronary calcium score versus the GMT for this. I think Rajesh Das is a known figure in Guwahati. He is currently practicing in Ampere Super Specialty Hospital. And so I thus would request Dr. Rajesh to kindly go ahead with his presentation, please.
Hello.
Yeah, please you can.
Okay. Good evening, our moderator sir, Soliha sir. Good evening, Bauman sir, Krishnada, and audience. Thanks a lot for giving me this opportunity to talk on a very important topic in the field of coronary artery disease. So I would like to share my screen. Is my screen visible here?
Yeah.
Yeah. Okay. Goswami sir, very good evening. Okay. Okay. So I have been given the topic of CT coronary calcium score versus treadmill test for prediction of obstructive CAD. So when we talk about investigating tool, we should know why we are selecting this investigating tool. And it depends on the selection depends on our purpose, whether our purpose is for diagnosis of obstructive CAD in symptomatic patients, or it is for screening of obstructive CAD in asymptomatic patients. Screening may be to identify a pre-existing CAD, or it can be needed to estimate the risk of future event related to coronary artery disease. First of all, I'll talk about diagnosis of obstructive CAD in symptomatic patients. So for diagnosis of obstructive CAD in symptomatic patients, first and foremost, the history is very much important. And depending on the symptomatology of the patient, we can classify angina or chest pain into three categories. First is typical angina. Second is atypical or non-anginal chest pain. Whenever all three criteria of typical angina is fulfilled, like constrictive discomfort in front of chest or in neck, jaw, shoulder, arm, which is precipitated by physical exertion and which is relieved by rest or nitrate within 5 minutes. Whenever these three criteria are fulfilled, then we would say the chest pain to be of typical angina in origin. Whereas if only two criteria are fulfilled, then we would say it is atypical angina. Whereas if none of these three criteria are fulfilled, then we would term it as non-anginal chest pain. Basically, before approaching any investigative tool for diagnosis of coronary artery disease, we should understand the Bayes theorem. The Bayes theorem is the pretest likelihood of coronary artery disease in a population it influences the post-test risk of having CAD. So we should be very careful in selecting investigative tool to avoid false positive as well as false negative result from their test. So the estimation of pre-test likelihood is very, very important before prescribing any investigation. Depending on the clinical likelihood, probability of the CAD, if we can choose our diagnostic tool, suppose the probability of CAD is very, very high. In that scenario, suppose the patient is having typical angina and is having multiple risk factors. In that scenario, we would rather advise invasive angiography to determine the therapeutic option for that particular patient. And on the other hand, if the pre-test likelihood is very, very low, suppose a very young female patient presenting with very localized precordial pain, that means there is very low clinical likelihood of obstructive CAD in that particular patient. So we should not advise any diagnostic test, whether it can be invasive or it can be non-invasive. And we know that advising unnecessary diagnostic test may sometimes show false positive result and can lead to further chain of unnecessary investigations and can lead to unnecessary anxiety in the patients. It is the intermediate clinical likelihood category where this non-invasive test like CT coronary calcium scoring as well as treadmill test helps us much in further stratifying or diagnosing the patient. So this is the pre-test probability of CAD, which has been given by European Society of Cardiology. Basically, it is based on the pre-test probability criteria given by Diamond and Forrester, which was given at least 33 decades back, and that has been modified in this recent guideline, 19 guideline of chronic coronary syndrome by ESC. They have included dyspnea in this estimation of pre-test probability. Dyspnea has been included as the clinical features. So here we can see that based on the age of the patient, based on the sex of the patient, whether male or female, and based on the clinical type of clinical picture, whether there is typical angina, atypical angina, or non-angina chest pain, or dyspnea, we can further stratify the probability of obstructive coronary artery disease. Here you can see the color coding. Any dark green are the patients, are the categories where there is high likelihood of obstructive CAD, whereas light green are the patients categories where there is intermediate likelihood of obstructive coronary artery disease. So any percentage in between 5 to 15% in this chart denotes the intermediate likelihood of obstructive CAD, and the percentage below 5% is termed as the low risk category or low risk pre-test probability of CAD. So when we classify a particular patient based on the pre-test probability, based on sex, age, and nature of symptom, we get this intermediate category where the percentage is around 5 to 15% of pre-test clinical likelihood. In this particular category, we can further reclassify patients depending on the presence and absence of various clinical features. Suppose the patient in intermediate category has got normal exercise ECG, normal treadmill test, or if we have advised coronary calcium scoring, if the calcium score is 0, that means there is very low likelihood of CAD in these patients, and we can avoid further testing and we can avoid pharmacological therapies in this patient. Whereas if there is increased likelihood, like if there is a modifier of pre-test probability like risk factor, dyslipidemia, diabetes, hypertension, smoking, family history of cardiovascular disease, resting ECG changes, LV dysfunction suggestive of CAD, and abnormal exercise ECG or coronary calcium score more than 0, in that scenario, we can carefully judge whether any pharmacological intervention may benefit this category of patient. So when we talk about screening of obstructive CAD in asymptomatic patients, then basically our approach should be a bit different. Here, we would stick to non-invasive testing with low risk. And what are the rationales for screening in any asymptomatic patients? Because we know that advanced obstructive CAD can exist with minimal or no symptom. some time, the first presentation of obstructive CAD can be life-threatening arrhythmia or sudden cardiac arrest or cardiovascular sudden cardiac death. So to avoid those kind of scenario, we can screen. The rationale for screening during the subclinical stages of disease is the hope that appropriate treatment may improve the prognosis. So with the hope of initiating a treatment which can improve the prognosis in a particular subset of patients, we can even screen in for asymptomatic patients. Screening may be appropriate for persons in certain high-risk occupation like pilots, bus drivers, when occurrence of any cardiac event, sudden occurrence of cardiac event may endanger lives of many people. Screening may be appropriate for individuals with higher perceived risk of coronary heart disease who are beginning an exercise program. So before beginning any exercise, before prescribing any exercise program, we can screen for a particular patient. Routine screening in asymptomatic diabetic patient is still controversial. So there are a lot of controversy regarding whether we should prescribe routinely treadmill tests or coronary calcium score in asymptomatic diabetic patients. So further studies are needed for this category. Now, what are the criteria based on which our choice of screening test would depend? So if a patient can exercise stress test is like TMT is preferred, because it gives us many physiological informations. It can give us the idea about the exercise capacity of the patients and help in prescribing the exercise therapy. Exercise test is the most appropriate and useful test for persons who are at high risk of CAD. Calcium scoring is most helpful in patients who are at intermediate to borderline risk with the presence of risk enhancing factors. So this particular category, intermediate or borderline risk, this category basically in all the recommendations, these are estimated by calculator. That calculator was derived from pooled cohort. So depending on the calculation risk estimation of the 10 years, we can divide the risk category of a patient. Intermediate risk means any category between 7.5 to 20% of risk of major cardiovascular event in the next 10 years, and more than 20% event rate is high risk category. So we should know where not to use calcium scoring. Coronary artery calcium scoring should not be used in high-risk patients due to the likelihood of false negative test. We all know that all lesion, all atheromatous plaque cannot be calcified. So if there are high-risk factors in a particular patient, if there is definite angina, then we should avoid prescribing calcium scoring as it can give rise to false negative test. And in patients with familial hypercholesterolemia, those who are very young, those patients have non-calcified plaque with significant stenosis. So in those patients also we can get false negative test. And then even in very high-risk patient with negative CT scan for CSE, there is very high event rate that is of 15 to 20% over the next few years. So in high-risk patient, we should avoid prescribing calcium scoring. We should use calcium scoring very judiciously in young patients, as I have already described. They can have non-calcified plaques, and in older patients, because in older patients, almost in females more than 70 years and males more than 60 years of age, they have extensive calcification without any obstructive CAD. So we should avoid prescribing in extremes of this category of these age groups. Let us come to some basics of these non-invasive testing. First of all, I'd like to discuss about treadmill test. The commonest protocol we use is the Bruce protocol, where there are different stages of 3 minutes each, and the speed increases with each stage, and the grade also, or the inclination of the treadmill also increases with each stage. The basic problem with Bruce protocol is that there is sudden jump of oxygen consumption in between these states. In this stage,
you may have to quicken up.
Oh yes, sir. So there are other protocols also. I would go into details here. so I would like to discuss what are the negative points with treadmill testing. We know that if there is baseline changes in the ECG like LBBB, LVH, WPW syndrome, or whether there is pacemaker in the patient, there is digoxin use, there is resting ST depression, then we can get false positive result, or the test can be inconclusive. So basic of calcium scoring, we all know that a CT scan is required for calcium scoring. It is non-contrast and it is triggered by ECG. It is a prospective acquisition of the scan. And the commonest quantification method is Agatston method. Based on the Agatston score, basically we can have an estimate of the plaque burden and the probability of significant CAD. If the Agatston score is 0, then we can say that there is no plaque and the probability of CAD is very low. And if the Agatston score is more than 400, then we can say that there is extensive atherosclerotic plaque and there is high likelihood of at least one significant coronary artery stenosis. So preparation of the patient is required. I wouldn't go into details. So here I would like to discuss about recommendation for use of CAC given in various recommendations like ACC, ESC recommendation. CAC calcium scoring is recommended for cardiovascular risk assessment in selected asymptomatic adult more than 40 years of age at intermediate risk by ACC AHA pool cohort risk calculator. So between the 7.5 19.9% of estimated risk, it is recommended. It is also recommended in selected adults with borderline elevated ASCVD risk, and it may serve as an arbiter of risk in this category. So why would we like to screen the patient in intermediate probability to know whether any specific therapy like statin therapy or aspirin therapy will help these particular patients. So basically, if the probability is very low, less than 5%, then no pharmacotherapy is indicated, only lifestyle modification is indicated. If the probability is very high, then of course we used to use highest intensity statin with lifestyle modification. We all know that this is for primary prevention of CAD, of course. And if risk category is borderline or intermediate, in this particular category, coronary artery calcium scoring will help. If the CAC is 0 in this category, then we can avoid the prescribing statin in this group. If the CAC is between 1 to 99, or if the CACS is more than 100, then of course we can add the statin in our prescription with the discussion with the patient. Whether we should use aspirin for primary prophylaxis in primary prevention in this group, no. Aspirin should not be used for primary prevention of ASCVD based on the calcium score. And aspirin okay, so when we compare with the coronary artery calcium score with HSCRP or HS-TROPI, it is seen that the 0 calcium score has a better negative risk prediction value than other markers like HSCRP or intima median thickness. So to conclude, these are some comparison regarding advantage of coronary artery calcium scoring and treadmill test. Advantage of CACS is that it can be performed in patients who cannot exercise. It is non-invasive and it is less time consuming. Coronary artery calcium scoring may be performed without any patient preparation, and patients do not need any beta blocker or nitroglycerin or any other medication, and they do not require iodinated contrast agent. Treadmill testing, of course, we know that it is inexpensive, it is widely available, it is more physiological, and no radiation is involved. The limitations on coronary artery calcium scoring is that the use of radiation, but it is very less nowadays. The cost, of course, it is more than treadmill test. High heart rate or irregular heart rate, we cannot prescribe coronary artery calcium scoring. And other non-vascular finding and incidental finding can give rise to anxiety in patients. Symptomatic patients, absence of CAC does not exclude obstructive CAD in non-calcified plaque. We have lack of randomized control trial, or all observations are from observational studies, or all evidences. And in treadmill, there are many limitations that if the patient are unable to exercise due to associated conditions like intermittent claudication, pulmonary disease. It is a drawback. And many patients fail to achieve 85% of THR and tests become inconclusive. Many drugs can interfere, like use of nitrate and beta blocker. And it highly depends on the pretest probability. And of course, we know that the assessment of treadmill test is observer dependent. Thank you. With that, I would like to conclude my topic.
Thank you, Rajesh. We can have a discussion later on because we are running out of time.
Yes, sir. Okay.
Thanks for the excellent presentation.
Thank you, sir.
I think moderator, sir, Dr. Solia.
Yes.
Can we start with the next talk?
Yes, we can start the next talk, Doctor.
So next is optimal management of acute coronary syndrome in a patient with altered renal functions at admission. And you all know that acute coronary syndrome is a well-known entity in a patient among the CKD population or in a patient with a renal impairment, not only even in acute kidney injury also. And but the approach is always a challenge, and most of the time. So let us hear without wasting time, because we are lagging behind almost 1 hour. So without wasting time, let us start. And the topic will be here by Dr. Ritupurna Borua. You all know him. He is a well-known interventional cardiologist in Guwahati. He is a bright student of modern medicine. So I would request Dr. Ritupurna to start his deliberation, please. You please be please unmute it.
Unmute the. You please unmute the.
Unmute your Ritupurna. You unmute yourself. Yeah, please.
Good evening to everybody, and thank you for giving me this opportunity to speak on this topic. And I find it's a very difficult topic because the next 10 to 12 minutes, I have to justify what is the best out-of-the-box treatment. We have the two treatment modalities. One is the pharmacological treatment, and the second is the interventional approach. And I mean to say that the revascularization it can be done through either graft surgery or it could be like percutaneous coronary interventions. As you know, so in patient who are having acute coronary syndrome in pre-existing renal disease is a very complex interplay of different hormonal system, like the sympathetic hormonal system, could be natriuretic peptide and the renin-angiotensin aldosterone system. So, and beyond that, there is significant oxidative stress and insulin resistance, because 70 to 80% of the patient presenting with acute coronary syndrome with pre-existing kidney disease and diabetes, and there is significant inflammatory response in this group of patients, and subsequently there will be endothelial dysfunction and then plaque erosions and plaque ruptures. And that is why the CKD is also associated with significant morbidity and mortality. And also importantly, that whenever we start in a pharmacological therapy, so there is a complex interactions of different molecules, and because of the creatinine clearance becoming lower, so the drug and drug interactions are significantly higher. So these are certain challenges we have to encounter in our clinical practice while treating ACS patient with existing renal dysfunction at the admission. Before proceeding to treat this kind of patient, we must know what is the stage of the kidney disorder in this group of patient, and we must know the stage of the CKD patient subject to the GFR and also proteinuria. So it is there are 5 classes, and the class 3 is again divided into 2 subgroups, and accordingly we decide the stage of the existing disease or CKD in this group of patients. As you know, once the creatinine clearance declines, the number of hospitalizations with acute coronary syndrome, cardiovascular mortality, and morbidity significantly or exponentially rises. There was some difference noted in terms of the pattern of the acute coronary syndrome in the symptomology. As the creatinine clearance declines, the patient become more, it is less of having angina and more of having shortness of breath and dyspnea. And the prevalence and the frequencies of STEMI comes down as the creatinine clearance decreases. But the STEMI and unstable angina proportion increases according once the creatinine clearance decline. And also, we have been seeing more frequent level grams blood patient once the fat decline. So one of the most fearsome and dreaded complications that can happen whenever we try to do interventions with giving contrast exposure to the patient, and then the patient can land up with contrast-induced nephropathy. So to exactly know the ablation status of the patient and the ZFR and the creatinine value, and also the load of contrast that we want to inject in that particular patient is paramount importance to prevent contrast-induced nephropathy in this group of patients. So as you know, the hypertension, congestive heart failure, the elderly population, if the patient is having anemia and diabetes, and as I already said about the contrast volume, these are the significant risk factors to develop contrast-induced nephropathy. Once the patient develops contrast-induced nephropathy during the PCI, so there is exponential rise in the mortality in this group of patients. One important syndrome that we must recognize is the cardiorenal syndrome. There are 5 types of cardiorenal syndrome. In patient with acute coronary syndrome is a type 1 because there is hemodynamic perturbation and there is hyperperfusion to the kidneys, or because of the increase in the cytolytic drive, natriuretic peptide levels, and also to the activation of the renin-angiotensin-aldosterone axis, the patient can develop a renal failure. So this is a type 1 cardiorenal syndrome we often encounter in patients with acute coronary syndrome. And once the patient is completely treated, then there was a significant improvement in KPI, and then the patient creatinine level become normalized. So what is the current management of this group of patients? So the most important is that we first stabilize the patient whenever they come with the acute coronary syndrome, and then we have to find out the strategy, what kind of pharmacological treatment to be started, and if the patient present with STEMI, and if it counts within a 12 hours time frame, so the best treatment we are having the thrombolytic treatment. But the problem is that in the CKD patient, once there is an increased risk of ischemic events, and the other way there is also increased risk of bleeding. So it is a double-edged sword kind of situation we are encountering. So if we have to thrombolyze this patient, and then there will be signs of critical organ bleed like intracranial hemorrhage, and then it might lose the patient. So we have to be very careful while choosing different type of regimen. This is the modification of diet in renal disease, and to find out the ZFR. And this is commonly used the Cockroach and Gold formula to find out the creatinine clearance in this group of patients. But once the creatinine clearance is significantly lower, and the use of this particular formula to precisely know the renal function is become more spurious. So the first is the antiplatelet therapy. So as you know, the aspirin is basically eliminated by liver and then excreted downstream in a very small amount in urine. So and there is not much of interaction in the CKD patient while using aspirin. And aspirin is a aged old molecule that can prevent ischemic heart disease, recurrent ischemic heart disease, and then acute coronary syndrome. We load the patient with aspirin so that we can immediately platelet as early as possible to get the maximum benefit. There are other molecules like tacrolimus. Tacrolimus can be safely given in moderate renal dysfunction, but in dialysis patient, so there is limited data while using this molecule. In one hand, we have oral antiplatelet. The other hand, we have the injectable antiplatelet. We call it the ZP2B3 inhibitors. Among the 3 ZP2B3 inhibitors, this is the abciximab, activopeptide, and the tyrosine. So it is the abciximab. This is mostly safe in patients with moderate to severe systolic in creatinine clearance, reduced creatinine clearance. But the tyrosine dose must be reduced in patient with CKD when the creatinine clearance is significantly low, if it is less than 30%. These are some of the data. Most of the evidence was collected from the antithrombotic trialist collaboration trial, where it was shown that there is not much of interaction in CKD patient with aspirin, and aspirin is safer, which is usual dose like 75 to 150 mg in patient in acute coronary syndrome with pre-existing kidney disease. So now come to the clopidogrel, that is the commonly used P2Y12 inhibitors, because given to patient with acute coronary syndrome. So most of the evidence was collected from the PO corridor and the clavitictomy. As you know, in most of the randomized control trial, the patient with creatinine clearance less than 30 are excluded. And that is why it is very difficult to substantiate the benefit of this antiplatelet therapy in patient with CKD. But these are some of the trials included some of the CKD patient with moderate renal dysfunction, and it was proven that the clopidogrel may be safe in acute coronary syndrome to prevent further ischemic events. But we have to be very careful by giving this molecule in CKD patient where creatinine clearance is significantly low, like less than 15 to 30. GP2B inhibitors sometimes we use in patient with HCS, particularly upstream PCI cases, or where in coronary angiogram we see that there is a lot of thrombus in the coronary arteries, and to prevent the propagation of the thrombus, and if we place a stent there to prevent radius strand thrombosis. So the GP2B inhibitors can be used, but mostly we have been using axicimab, and because the dose modification is not required in patient with moderate renal dysfunction. But in case of tirofiban, we have to reduce the dose by 50% if the patient having a creatinine clearance of less than 50. In case of thrombins, heparin can be used, unfractionated heparin, and given a dose of usual dose we given for heparin, and then if enoxaparin is used in patient with creatinine clearance less than 30, we reduce the dose to 1 mg subcutaneous in 24 hours. So this is the dose modification required in case of enoxaparin, but in case of heparin it is not required. Valvaluridine is sometimes used, particularly in patient during the PCI, and valvaluridine interaction with CKD patient is significantly low compared to the other molecules. But if the patient is having very severe renal dysfunction, if the creatinine clearance is less than 15, so it needs some modification. 50% reduction of the valvaluridine dose is required. Fondaparinux is because of once daily dose, it could be patient friendly, but if the creatinine clearance is less than 30, fondaparinux is not given. It is in fact contraindicated. So the pulmonary therapy is a very important aspect in STEMI patient, but the problem is that it might lead to severe critical organ bleeding like intracranial bleed, and particularly the fibrin specific agent may be safer compared to the non-fibrin specific agent like streptokinase. Other anti-ischemic therapy in case of if we talk about the beta blockers, and bisoprolol may be safer compared to the others because its metabolism is not through kidney. And in all the randomized control trial, there are the 3 beta blockers like metoprolol, bisoprolol, and carvedilol. They are shown to produce good beneficial effect in ACS patients. So earlier we can start this molecule, more will be benefit will be obtained. Use of AC inhibitors or ARB, we must start these molecules within 24 hours. But the problem is not the worsening renal function, but it is the hyperkalemia, because it might lead to various complications and life-threatening complication. So in majority of the patient with ACS, there is in the initial phase there might be 30% increase in the creatinine, but usually 50 to 90% of the patient usually subsides. But the problem is hyperkalemia. It is a progressive hyperkalemia that can lead to life-threatening complete heart block or other arrhythmia events. Aldosterone blockade. So the problem is that in CKD patient with moderate renal dysfunction, might lead to hyperkalemia. And that is why in patient with creatinine 2.5 for man and more than 2 for women, aldosterone blockade are not recommended. What are the other means of therapy in patient with ACS patient who presented with the emergency department with pre-existing renal disease? So the revascularization process. So there are the surgical revascularization and this percutaneous method, we call it angioplasty. And the problem that we have encountered is that the contrast, because we have to inject the contrast. So there was some calculation so that the safe limit of the contrast injected in during the procedures can be evaluated. There is no definite data on this type of revascularization strategy, whether it is CABG or whether it is percutaneous coronary intervention is safer. Because this patient not only having high ischemic events but also having high bleeding risk. So what is the optimum loading dose of the antiplatelet therapy before the percutaneous interventions like primary PCI is yet to be recognized. But as there was robust data on primary PCI during the STEMI patient, so I think this is one of the modality that should be it is actually underutilized, but we in clinical practice should use this primary PCI if the patient comes at the appropriate time, and that might lead to mortality benefit. So after studying extensive literature, I have seen that the literature has been very consistent in showing an increased risk of percutaneous coronary intervention in patients with chronic kidney disease. And that there is only few data exist from randomized control trial to dilation. But important is that we need to assess whenever we are doing an angiogram in ACS patient, what is the coronary anatomy, what is the collateral supply, what is there a diffuseness of the disease, because in most of the patients with existing kidney disease, we have found diffuse coronary artery disease, diffuse atherosclerotic disease, and the calcium load is significantly high. So, and this group of patients putting a stent without preparing the bed might lead to more complications like stent thrombosis. That is why, and also important is that, so we need to do complete revascularization. Primary PCI patient is one subset of patient where we might get benefit in STEMI patient, but in STEMI patient, if we see the extensive disease, diffuse atherosclerotic disease, triple vessel disease, and if these are CKD patients having mostly calcified lesion, and that without preparing the bed and pushing the patient for stenting might lead to more complication. And also it is important that in the different trials, like the BARI 2D and Freedom trials, they are endorsing more of complete revascularization, and the complete revascularization can be done by CABG, and the chances of complication and graft population are significantly less if we adopt the complete arterial revascularization. In the recent era, because the stent spots are reducing, and using this kind of stent like Synergy or the Onyx, where the stent, the spot size is 60 to 70 micron, and there are this Synergy or other new generation stent and can be used in the high bleeding risk patient, and where we can even after 1 to 3 months of the DAPT, we can withdraw DAPT. Particularly the high bleeding risk patient might change the scenario of treating or revascularizing this patient, acute coronary syndrome patient with pre-existing CKD.
Dr. Ritiparna, you have to summarize.
To conclude, there are concerns about using the aggressive reperfusion strategy, which implies both fibrinolytic therapy and primary coronary revascularization procedure. Particularly in patients with STEMI, trials have shown the effect of the thrombolytic agents in reducing mortality, but analysis was not performing many for severe CKD on admission. The risk of bleeding, particularly the intravenous hemorrhage, constitute a reason for less frequent use of thrombolysis in patients with CKD. However, the primary percutaneous coronary intervention may be a good therapy by treating this patient. CABG may be conflicting, but in CABG in early CKD may be beneficial in this group of patients. Thank you for your kind attention.
Thank you, Dr. Ritiparna, for making this very complicated topic presented in a very brilliant way. Thanks for your brilliant presentation. Basically, as we know, this is a balancing act, the balancing ischemia versus bleeding risks. And I would like to have some comment from Dr. Anup Burman sir regarding this topic. Some comment from him.
Thank you, Dr. Soliha. First of all, I must congratulate Dr. Ritupono for an excellent and very lucid presentation. And it's a very difficult topic, in fact, because it's really challenging treating such patient and acute coronary syndrome or coronary artery disease in a patient with an underlying renal insufficiency. It's really a very, very difficult situation. And most of the time, you know, if you see the mortality and morbidity of a chronic kidney disease is coronary. Majority of our patients eventually succumb to a coronary events on a CKD population. I'm talking about the CKD population. And even many of the patients before reaching the end-stage kidney disease, they die because of coronary artery disease. And those who also reach the end-stage disease on maintenance, dialysis or transplantation, and many of them eventually succumb to coronary artery disease. So it's a major killer amongst the coronary artery disease, I mean CKD population. And treating also is very difficult, as I said. And because in such patients, when you treat the patient or when you're going for the establishment of your diagnosis, sometimes it's a very challenging, because in most of the time in having a renal failure or renal insufficiency, going for a contrast study is very, very hazardous, maybe hazardous. And most of the time it is not advisable. But sometimes we have to take a risk. Why we have to take the risk? Because we have to balance. We have to take a risk and benefit, and you have to take a balance, see the balance. But thing is that when a patient with having a definite prospect for transplantation, or definite prospect means I'm talking about the transplantation, then definitely we have to go for this invasive interventional therapy like angioplasty or whatever it is. But when a patient is not having prospect for transplantation, thus they want to remain on some conservative treatment, then better to avoid all the contrast study, because if you use a contrast, eventually it will cause further deterioration of the residual renal functions. So preservation of the residual renal function is very, very important in a chronic kidney population, those who wants to remain on conservative or some home dialysis, because this is very important, because they will give to some support to their life. But those who are going for transplantation, it's a different chapter, because if going for transplantation, definitely you have to diagnose the coronary disease, and definitely you have to treat before going for a transplantation, if required, even bypass surgery. So this is depends on the patient population, patient's age population. So this is a very nice presentation. I would again congratulate Dr. Ritupono. And the thing is that the management with the medicine management also challenging, as we said, how much dose of aspirin you have to use, what is the downside, you all know, but still we have to use sometime, we have to take a risk. Similarly, the other medication also. So this now open for discussion. If you have any comments, and because the other topics are also very well known, well discussed topic, but my interest of topic definitely the last of, because this is because being a nephrologist, this is very interesting topic. Thank you, Dr. Soliha. I think we can hear from you some more comments or from the senior faculties.
Mriganko, good evening. Mriganko, can you hear me?
Yes, I can hear you.
Dr. Manoj Agarwal here. Hi.
Yes, hello.
Hi, Manoj.
Hi, how are you?
Hi.
I wanted to make a comment. I mean, see, when we are doing invasive procedures, adequate hydration and the contrast burden are the major determinants of worsening of kidney function in such patients. And while doing the PCI, we can take the help of imaging technology like intravascular imaging, where we can cut down the contrast burden. And what happens sometimes, we will try to profile 10 views, which may not be required. If the aim is just to diagnose coronary artery disease, just take 3-4 views, give good hydration, keep patient under follow-up for next 1 week. I think many of these kidney function deterioration we can avoid.
Yeah, there are another option also.
I have one Yeah, please.
Yeah.
After that,
Actually, nowadays, as coronary artery disease is quite prevalent, as you said, in CKD patient, even cardiologists and interventionists are also going in favor of that by using a novel strategy of zero contrast angio, or by using those imaging devices. So ultimately, the field is growing, and this contrast induced nephropathy is some quarter thing. Maybe it's a myth rather than a reality. So there are so many issues to this aspect. But as you have said it quite correctly, we should try to preserve the residual renal function as far as possible.
Yeah, Manoj, you are very correct, rightly mentioned. But thing is that again, challenge is maintaining the hydration status in a chronic kidney disease population, because they are already, most of them are already fluid overloaded. Again, on top of that, you want to pour some more fluid to hydrate them. Sometimes it may again precipitate heart failure. So this is again challenging. So this is again a very controversial issue. Again, whether we should, how much we should hydrate, or what is the use of neck, whether an anesthesial system is really helpful in such situation or not. This is also doubtful. So these are some gray area in this petition, but as much as possible, we should avoid the contrast, because definitely it will deteriorate your residual renal functions.
May I come in? Myself, Dr. Ajay here. Burman sir, thank you so much for all the important points you have mentioned. I want to ask, sir, once again, we are lucky that you are with us at this important topic. Sir, once a patient develops CIN by definition, like as Ritu said, CIN contrast, by definition, as Ritu said, from the baseline, if the level increased by 0.5 milligram per deciliter, or by more than 25% from the baseline of within 48 to 72 hours. What should we do when a patient develops CIN? And one more question to Rituparna, not question actually. Suppose we have a patient with massive MI, anterior MI presenting in cardiogenic shock, and patient is coming within time, like within 3-4 hours, and creatinine is baseline getting high, suppose 4 or 5. Rituparna, what will you do in that situation?
So should I answer after Sir, or I'll take my question? In that scenario, obviously, if the patient is dying with heart attack, not safely patient, so I think the primary decide because if we don't do invasive in this category of patients, so we might lose the patient. So because our catheter is ready, we have all the facilities, and why not we should take up the patient for primary PCI, and we'll try to remuscularize as fast as possible. And then rest assured that we definitely need to save the kidney also. But first, because the clinical symptoms is acute MI with failing heart, so we must stop that.
Thank you.
And if you don't save the heart, kidney will be cooked because of the hypotension.
Yeah. Any other question regarding the other two previous speakers?
Sorry to interrupt. We can close this session, I believe, because we are almost running 1 hour late.
Okay.
Yeah, fine.
Thank you all.
We would like to start the competitive CD presentation. I request Dr. Manoj Agarwal. He is already here, so he will be judging all the participants. I request Dr. Monwar Hussain to start his presentation. The presentation time will be 6 minutes, and 2 minutes will be allotted for discussion.
Can you hear me? Am
Yes,
I
sir.
audible?
Yes, sir, you are audible. Yes, please proceed.
Good evening, everyone. And I'm thankful to CSI Northeast Chapter for giving me the opportunity to present the case. So, as you see, the heading is coronary intervention in anomalous right coronary artery arising from the left sinotubular junction It's an uphill battle. So I thought this is a rare case. So I have the opportunity to do the intervention with this anomalous coronary artery. So I thought I'll share my experience with this. So as you all know, coronary artery anomalies occur in 1 to 5% patient undergoing normal routine coronary angiography. And the high origin of RCA above the left sinotubular junction and above the left coronary origin is very, very rare. It's almost 0.015 to 0.49%. So it's a very rare presentation. So if you see the origin of anomalous right coronary artery in relation to left coronary artery ostium and sinotubular junction, there are 4 types: the type A, type B, type C, and type D. And type A is the most common origin from the aorta above the sinotubular plane. And the type B is origin just below the ostium of the left coronary artery. And type C is the origin below the sinotubular plane, between the midline and the origin of left coronary artery. And the type D is origin along the midline of the ascending aorta. So my patient, patient was 55 years old gentleman, recently diagnosed due to diabetes mellitus, and presented to us with acute onset retrosternal chest pain for 2 hours duration with perspiration and episode of syncope. When he reached to our emergency department, his blood pressure was 110/60 millimeter mercury, and his heart rate was 52 beats per minute. And ECG, there was non-specific STT changes. And echocardiography didn't show any RWMA, and his EF was preserved. And his troponin was very high, it was 1917. So it was definitely ACS with NST, non-ST elevation myocardial infarction. So he was shifted to cath lab. And if you see the ECG do not have any definitive changes, but some minor changes in the interior leads as well as in the chest lead. So he was loaded with antiplatelet, statin, and other supportive medication. And as he was stable and he was shifted to the cardiac catheterization lab. So in the lab, so this was the left coronary shot. Actually, I'm because of reducing the slide, I just gave this slide. So this was the left coronary shot. So it was subtotal occlusion, and then circumflex is also having disease in the distal part, in OM. And most important thing is here at this point, I tried to engage the right coronary artery with the usual catheter, right RCA catheter, but I could not find RCA from the right coronary sinus. So as the patient is having chest pain and I'm getting this subtotal occlusion to LAD, initially I thought, okay, we'll go for intervention of this artery, but as a rule, we should not do intervention unless you see all coronary trace. So the next option, immediately we took the root angio, just handheld root angio by 10 ml. So the artery RCA was showing originating from the anomalous position. It was just above the sinotubular junction and above the left coronary artery origin. So next step was how to hook the coronary arteries now. So I tried all my catheters in the shell, like JR, multipurpose, M plus left, M plus right, but I could not hook the artery. So finally, I took TIG catheter. Teramo is very soft catheter, a malleable soft catheter. I took that catheter and it was hooked with this catheter. See, this was the right coronary artery. So I thought patient had syncope and some ECG changes in the both the inferior as well as anterior lead. So maybe artery may be the culprit artery, but both the arteries were significantly. We thought we'll intervene both of them. So temporary pacemaker was placed. So the wire was done with the BMW software, and then 2 millimeter balloon pre-dilation. So after pre-dilation, this is the picture. So I took a 3 millimeter, 3 into 28 millimeter onyx stent. Position covering the whole, and this was the result. I re-inflated it with high pressure. So after that, it was quite straightforward. So without pre-dilation, I straightly went for direct stenting. Stent was positioned, and it was deployed in nominal pressure, and then it was re-inflated with high pressure, and this was the final result. Good flow. Patient became asymptomatic. So the take home from the case, anomalous origin of the RCA high above the left sinotubular junction is very rare anomaly. So we all should be aware of the anomaly and its different locations, so that clearly, so that during emergency situation like this, procedure can be done. Take one more important take home here is, without knowing all the coronary tree during emergency situation, even at ST elevation MICT, one should not intervene without knowing the other, all coronary trees. And the last one is, we should use TIG guiding catheter if other catheter fails, because it may help you during the difficult situation. Thank you for patient hearing. I think I'm on time.
Yes, thank you, Dr. Manohar. Dr. Manoj Agarwal, you'd like to question him?
I mean, Manohar, I must compliment your lab that the TIG guiding catheter is available. We don't have TIG guide in our lab.
So actually, sir, I did 3-4 cases with this type of anomaly. All were, sir, from the left high origin, left side, and every time I succeeded with the TIG catheter. It is very soft and it's a straight way. You can just hook the coronary artery, anomalous coronary artery, especially in the left side. So it is very useful, sir. If you have some patient, you can try, sir.
We have done most of our cases are there with the left Emplas or left Judkins guide, going along the sinuses and turning it around.
Yeah, I have seen all the literature also. They have tried, but nobody has tried with this TIG catheter. So they have even done the angioplasty with diagnostic.
Yes. Nice case in a difficult situation. In acute setting, it's always a difficult thing to do.
Yeah, now we go to the second presentation. It is by Dr. Biplab Pal. He is from GNRC Hospital. He is a consultant cardiologist from GNRC Hospital, Guwahati. Dr. Biplab Pal, you can start your presentation.
Audio off.
Fareen, Dr. Rath also has joined us just now.
Are my slides visible?
It's pleasure to have you in our seminar and in our conference. We are just running late. So we will complete the CT presentation within 1 hour, then we'll have your talk, sir. Good evening, sir. Biplab, you can go ahead with your presentation.
Yeah, just a second, some technical problem. Am I audible?
Audible.
Slides are visible? Hello? Hello? Slides are visible?
No, no.
No? Now?
Yeah, it's visible now.
Okay. So my case is renal artery stenosis and subclavian artery stenosis in a patient of Takayasu RD intervention in these techniques are same like coronary or it's different. Actually, I made probably a lot of mistakes during this intervention. This was done in 2018. So a 14-year-old patient, he presented with fatigue on exertion for last 2 years, and he was hypertensive for last 2 years. BP was controlled despite 4 medications. So he is a case of resistant hypertension, and I have recorded pulse and blood pressure. There is a discrepancy in the pulse and blood pressure in the both upper limb. The blood pressure in the right upper limb is 200 by 100 millimeter of mercury, and in the left upper limb, it is 160 by 80 millimeter of mercury. The lower limb pulse and blood pressure was, there was no discrepancy, but definitely it was high. And I inquired about the family history. There is no family history of hypertension. So these are the investigation report. Hemoglobin was little bit low, 9.7 gram per deciliter. ESR was not very high, 16 millimeter at the end of first hour. Creatinine was normal, 0.9 milligram. Ultrasound KUB showed right kidney small and contracted compared to left, and left kidney there is slight corticomedullary alteration. ECG1 done, it was left ventricular hypertrophy, sinus rhythm, echo, there is good LV function. And I did right renal angiography, it was total occlusion, and left renal artery was 80 to 90% stenosis with presence of accessory renal artery, which was also stenosed. And left subclavian artery showed 80 to 90% stenosis, and coronary angiography was normal. So we plan to do a stenting to left renal artery and balloon angioplasty of the accessory renal artery, and also stenting to subclavian artery in the same sitting. So initially, I plan to put a coronary stent instead of renal stent, because the renal stent size was a bit, diameter was normally, the available one is 4 or like this. And in our area, it's very difficult to get it because these procedures are not routinely done. And my angiography vessel showed a bit little size. And that was my mistake. So I'll coming to the slides. So this is the left renal angiogram, which showed your renal artery stenosis and also stenosis in the accessory renal artery, and right renal artery almost total or subtotal occlusion, you can say. Then these are the coronary angiogram. It was normal. Then subclavian artery stenosis significant in the left side. So I used right femoral approach with JR6F catheter initially, then wet both renal artery and the accessory renal artery, then sequentially dilated with 2 and 3 millimeter balloon. Then this is the finding after dilatation, balloon dilatation. Then I put a stent of 3.5 to 23 millimeter mercury in the main renal artery, left side. And I got optimized result. But if you see the last slide, there is, even after this stent dilatation, there is stenosis in the under dilatation in the mid part. So that again, I tried to dilate, post-dilate with 4 millimeter balloon, then 4.5 millimeter balloon. I have also taken small balloon so that I can give the radial strength in the mid part, but still I did not get the favorable result. Although it is acceptable, but the result was not very good. So this is the main thing, which is the difference in comparison to coronary. These lesions are very much fibrotic because in Takayasu arteries we got the intimal fibrosis, and this the situation in coronary, it's not similar in the Takayasu arteritis or especially in renal artery. Then again, I took this left subclavian artery. So this also I used JR catheter. So initially I dilated with normal PTCA balloon. Then I dilated with peripheral balloon. Then I implanted a 18 to 80 millimeter peripheral stent, and the result comparatively good. So the take-home message is that renal artery stenosis is an important cause of hypertension in young individuals. In Takayasu arteritis, multiple peripheral vessel involvement is found. The lesions are more fibrotic than atherosclerotic lesion. Initial angiogram before balloon dilatation may underestimate the proper size. Coronary stents have less radial strength compared to renal stent. Stents may not expand properly and may need re-intervention, and long-term immunosuppressive therapy is needed to prevent the recurrence. Thank you very much.
Thank you, Biplab, for your wonderful presentation. Manojda, you want to ask him something?
Farin, let us hear from others, then I make a comment. Let us hear from other people also, if they want to make any comment.
Hello.
If no comments, Farin, I mean, scoring balloons can be used in such patients where, but that has to be before we put a stent in the renal artery, scoring or cutting balloon, just to break that fibrosis. And my personal experience and the way we treat such patients, we avoid putting stents in these aortoarteritis patients because the risk of restenosis is so high. And once you put a stent, there is no second. You do a balloon, come back again, do a drug, or maybe a simple balloon or a drug-eluting balloon. You can do multiple procedures, and stent is end of the road. And at the same time, right kidney function should be assessed. If the right kidney is still functioning and the renal artery is of good size, an auto transplantation of that kidney can be done to iliac artery to preserve the renal function, and treatment of hypertension will be much more effective in such patients. Now, this has been very well described in the literature also.
Sir, well, move to the next presentation, that is by Dr. Harisankar Pratap Singh. He is a pass out from Guwahati Medical College. Now he is practicing in Jabalpur. I request Dr. Harisankar Pratap Singh to start his presentation.
Good evening, everyone. Am I audible?
Yes, sir, audible.
Good evening, everyone, and thank you, organizing committee, for giving me this opportunity. I couldn't present the proper slide because I got information 2 days ago only, and I was out of town and still on the way to Jabalpur. So I'll straight away come to the case. I got a patient from nephrologist. He was a 50-year-old male. He diabetic, hypertensive, and was on the regular dialysis, maintenance dialysis since 10 years. He had AV fistula in the right wrist, followed by the left wrist, then right elbow, left elbow. All were blocked as per the nephrologist, and he was on the maintenance dialysis from the right femoral through permanent catheter. So he sent the patient to me, said, "Can you do something for him?" I auscultated all the 4 AV fistulas, and I realized there is a buoy in the right elbow. All other 3 AV fistula were silent. So I realized that this AV fistula is patent. So straight away, I took the patient for the intervention, and I took a shot for the subclavian vein, and I got it, the right subclavian vein, CTO 100%. Then there was no way for him, so I took him to open this vein. So first I took this straight tip demo, but it was not passing. We can see here, it was collateral, but it was like CTO. Then I realized that this is a true CTO, so I have to go like coronary CTO. Then I took the Felder XT. Then
Your slide is not visible. Your slide is not visible.
Not visible, sir?
Yeah.
Then I took the Gaia 2, then Miracle 3, followed by Miracle 6.
Harisankar, your slides are not visible. You run the video.
Okay.
So you have to share screen.
I have shared the screen.
You are visible, but your slides are not visible.
Okay. Is it visible, sir? No?
Yes, now it's visible. You go ahead.
Okay. So this was the first suit, right subclavian vein. We can see it was CTO. Then after that, I crossed the lesion, the Miracle 9. Then we took the CTO balloon. First I took the 1, then 1.5, then 2, did the serial dilatation 2.5. And then after that, I did the dilution with the 420 balloon, then followed by the 840 mm balloon, peripheral balloon. After that, I took him for a stenting. It was a Cook self-expanding bare metal stent of 10 by 120 centimeter, and I deployed it. So this was the final picture, and he got the flow. We got the flow from subclavian vein. So it took almost 3 hours to open this vein. So in intervention, perseverance is very important. We should not give up and try until we get success. Thank you.
Harisankar, the SVC also is totally occluded. It is filling from a collateral from the IVC, I suppose.
Yes, sir.
So you can see the drainage through IVC.
Sir, yes, there was another collateral, sir. It was filling. But after that, he started dialysis actually, sir. And it was difficult because he had the permanent catheter to the right femoral vein, sir. And only vein was left is the left side of groin.
Yeah.
So we did not touch this part, sir.
Since don't take it as a criticism, but it's a part of learning. I mean, we do good number of interventions of these fistulas and central veins. It is better to avoid stents in these vessels. The patency rate for any intervention without stent is hardly 6 to 9 months. And you can come back and redo it. You can maintain a Doppler surveillance of these patients. The moment it starts occluding again, you come back, dilate. So most of my patients, I say it is 6 to 9 months. Put a stent, that's the end of the road here as well.
Actually, sir, after balloon also, the vein was getting collapsed. Like we did the balloon from 2, 4, 8. After 8 also, there was no flow. Immediately, it was getting collapsed. So there was no other way apart from putting the stent in this case.
Maybe something in future, if you have biodegradable stents, will be wonderful to do it here rather than these metallic stents.
Yes, sir.
Wonderful, very nice case. And especially in a city like Jabalpur, you are able to do this kind of work is commendable.
Thank you, sir.
So we can now move ahead with the next presentation. That is by Dr. Aditya Bhaskar. He's a consultant cardiologist from Ayurveda Hospital. I request Dr. Aditya Bhaskar to proceed with his presentation.
Hope I'm audible.
Yes, sir, audible.
But I'm not able to share the screen.
Please share.
You have to press the share screen.
The share, I think some administrator has to allow me sharing.
Can you try now? You have to press the share screen.
But the share option is not coming. It's only cancel that is highlighted.
You log out and join back again.
Sure, sir.
Aditya, if you are having some problem, we can proceed with the next presentation of Dr. Malviya. He is waiting. You can join later if you have issues.
Hello, am I audible?
Yeah. Yes.
This is Dr. Malviya. Can my slides be shared? I had already submitted earlier. Can you please share my slides, Sangamitra?
Yes, sir, we are sharing.
Yes, sir.
Please.
So we have a presentation by Dr. Amit Malviya. He's a assistant professor of cardiology of Negrims, Shillong. Dr. Malviya, please go ahead.
Thank you very much. I thank the organizers for giving me opportunity to present my case. I believe innovations, ingenuity, and proper combination of skills is what makes a case rare and interesting. So I'll be presenting one interesting case of balloon mitral valvotomy, which I did in my lab. So I'll just start. Next slide, please. As we know, antegrade approach is a very effective and established method of doing BMV. And retrograde non-transseptal balloon mitral valvuloplasty was developed as an alternate procedure to avoid complications of septal procedure. Retrograde approach is also very safe and efficacious, but the limitation is that it requires very special hardware. I will be discussing further what special hardwares are required. And these hardwares are usually not available in most of the cath labs centers across India. So whenever some situation arises where retrograde BMV is needed, small innovations in cath lab using routinely available hardware are the only possible way out. Next slide, please. So retrograde BMV was first described by Stefendis et al. Next slide, please. And basically, it is indicated when there is a high risk of complications during transseptal puncture, like patients with previous cardiac surgery with patch closure of ASD, or a large atrial septal aneurysm, chest wall deformity, where it may not be technically possible to do the landmarking for septal puncture, or IVC, SVC malformation or occlusion, or in cases where you have failed to do a septal puncture. Next slide, please. But the hardware required for retrograde BMV it's very rare. Actually, it was, as you can see in the top panel, it requires a special deflectable catheter, which can be deflected using the knobs at the proximal end of the catheter and give it a shape to help it enter the left atrium. And it also involves one 14 to 16 French special dual lumen balloon catheter. These two items are usually not available in cath labs across the country. Next, please. So I had a case, there was a young female which was referred from severe symptomatic rheumatoid mitral stenosis, and she had a very large atrial septal aneurysm. And the patient was not ready for open heart surgery, and we decided pre-op that there's a lot of risk in trying for septal puncture with such a large septal aneurysm. So we tried to devise a new technique to do this BMV retrogradely. Next slide, please. So as you can see here, there was a very large atrial septal aneurysm, which we thought was we will not be able to do it safely, the septal puncture. Next slide, please. So what we did was we used a simple EBU guiding catheter, which is routinely available in all cath labs for coronary angioplasty, and prolapsed it into the left ventricle in the AP view. So once it is prolapsed, we pass the guide wire along with it. And the next slide, please. And then from LV to LA, we pass the wire. Now the technique involved here is because in the original technique, there's a deflectable LA catheter. So you can direct it posteriorly and laterally, and it helps the wire to go directly into the LA. But in this case, once you use a EBU guide, it will always direct normally anatomically towards the LV outflow tract only, and all the time the wire will go back to the aorta. So the technique to direct it towards the mitral wall and left atrium, we utilize the lateral view, because in lateral view, the left atrium is the posterior structure nearer to the spine. So we gave it a twist and directed it towards the left atrium and passed the wire and made this figure of 8 shape so that the wire is stable. Next slide, please. Then we used a tie-shaped balloon, 18 into 6 millimeter, positioned it across the mitral wall and inflated. Next slide, please. Next. As you can see, no, previous slide, the video. Can you play the video? No, it's previous to this. Yes. So you can see the balloon was inflated and the mitral wall opened nicely after one inflation. Then we again gave one more inflation. Next slide, please. Next. As you can see, the results of BMV was successful and acceptable. Next slide. So what are the technical considerations is the new technique we innovated in our cath lab. One is the selection of balloon size, because we cannot use the standard technique, height-based technique in selecting balloon size for these cases. So that the formula is used usually is the intercommercial distance. In our case, it was 18 millimeters. So we used the 18 mm tie-shaped balloon. And the second issue is involved is once you pass a prolapse EBU guide into the LV and try to pass the wire, you can always go through the submitral apparatus and then go into the LA. So while taking up your balloon, you might injure the submitral apparatus. To ensure that there is no wire entry through the submitral apparatus, we used a Swan gun catheter, semi-inflated, to see the free flow of the catheter so that no submitral apparatus is injured. And as I discussed the angiographic views, lateral view is the most important view for this technique. Next slide, please. So the take-home message from this case is that retrograde BMV is useful technique where risk of complications during transseptal puncture, normal antegrade BMV is very high. And in our technique, the special hardware is not required. We can use all hardware which are routinely available in cath lab. The arterial access is only 8 French, which is for the tie-shaped balloon, compared to 14-16 French access required in the conventional retrograde technique. And it is a simple and safe and low-cost technique. Next slide, please. I think it's done. Thank you so much.
Thank you, Dr. Malviya. Wonderful presentation.
Thank you, Dr.
Agarwal,
Farid.
you'd like to ask him something?
Very nice. I must compliment him for using normal hardware for doing such a difficult procedure. And as I already highlighted, we should be able to avoid injury to the submitral apparatus.
Thank you, sir. Thank you, sir.
We can now move ahead to the next presentation. Dr. Aditya, you are ready?
Yes, sir.
Yeah, please go ahead and share your screen.
Hope my slides are visible this time.
Yes, sir, visible.
Yeah. So thank you, and my apology for some technical difficulty last time. So today's my presentation is calcification and tortuosity, how I overcame double whammy. So my case is a 70-year-old diabetic hypertensive fragile male. He was a known case of chronic obstructive pulmonary disease and chronic stable angina since 2 to 3 years. He was on optimal medical management and he had presented with resting angina since 2 hours. He was hemodynamically stable, chest has bilateral minimal clefts and CVS has S1 S2 normal without any murmur. He had old angiography 3 years before that revealed calcified left main DVD, and he was advised for coronary artery bypass grafting, but neither the patient was not willing for that. His ECG at presentation revealed the LBB. The 2D echo revealed RWMA in LED territory with LV ejection fraction of around 35 to 40%. HS-TROP was raised, and in lab parameters, it was significant that his hemoglobin was little lower side 9.0, and is a patient of chronic kidney disease with creatinine of 1.8. So my diagnosis was ACS non-STEMI, LVB, and moderate LV dysfunction. So after initial stabilization, we took the patient for the coronary angiogram by right radial route with 5F seat and Tiger catheter. It revealed in this epicaudal view that the left main is long and there is mild plaquing in the mid part of the left main. Distal left main has some intermediate disease. The arocranial view revealed that there is significant 90 to 95% stenosis just after the diagonal in the LAD, followed by some intermediate disease. In arocaudal view, nothing extra could be appreciated. LCX appears to be healthy. In allocaudal view, the distal left main seems to be around 30%, 40% disease, and ostia of the CERV appears to be healthy. In RCA was dominant and diffusely diseased from the beginning to the end, maximum of around 90%. So the diagnosis is left main double vessel disease, but neither the patient and nor the surgeon was willing to do the coronary artery bypass grafting due to the poor lung reserve. So we planned for PTCF stenting to LAD, obviously with some debulking technology, and I think here the rota was the most suitable one. But there were certain challenges, like we do not exactly know what is the blockage in distal left main, and we do not have any imaging facility. The LAD was, apart from being calcified, it was very tortuous, and patient has some renal dysfunction, and RCA revascularization was difficult at the same setting, and fragile patient with poor lung reserve was another issue. But we finally planned for PTCA plus stenting to LAD by rota guided, and we planned only focal stenting to avoid touching the left main. So we took 7F right femoral arterial and venous seat. We put a TPI lead in IVC. We have also taken a 4 French contralateral arterial seat for emergency IABP, and our guide catheter was EBU 3.5. We planned to cross lesion directly with the rota wire, followed by rota ablation and pre-dilatation and focal stenting. So the lesion was crossed with rota wire without much difficulty. Then we took a 1.5 millimeter burr, and with a speed of 1,50,000 rate per minute, we rota ablated the lesion and followed by some polishing run. After rota ablation, the rota wire was exchanged with run through NS wire via microcatheter, and pre-dilatation of lesion was done by 2.5 into 8 mm non-compliant balloon at a pressure of around 20 millimeter of atmosphere. So our plan was, as discussed earlier, our plan was very precise length of stenting. First, we took 3 into 16 mm drug-eluting stent, but it was quite bigger, like we have to touch to the left main. So then we changed the stent, and then we took the 3.3 into 12 mm drug-eluting stent, and after confirming its position in multiple views, like we have to give so many contrast we wanted to avoid, but actually the calcium was so much, whenever there was any movement of guide stent or anything, the whole system tried to come back. But finally the best position was obtained, and the 3 into 12 millimeter of drug-eluting stent was deployed in the mid-LAD focal stenting. This was the result post-stenting. The stent appears to be well inflated with some like narrowing in the mid part, which was not very evident in the LAO cranial view. So, but we finally tried post-dilatation. Even the post-dilatation was not so easy, because anything ops we tried, it was not going through the LAD and stent. But finally we post-dilated with 3 into 8 mm NC balloon at around 14 to 18 atmosphere. And after this post-dilatation, we thought that there is still some narrowing in the mid part of the stent. So we finally post-dilated with 3.5 into 8 mm NC balloon. And this was our final result. There was no compromise in the diagonal. The stent appears to be almost well inflated. As I already told, we do not have imaging, so we could not say with confidence that what is the condition of left main and whether my stent is well inflated or not. So this was in another view, there was no dissection, no perforation. So my take-home message is rotablation can be performed in tortuous and heavily calcified lesion with some precaution, as there is high chances of complication, and focal stenting sometimes can be a good option in elderly fragile patient where you do not want to do perfect. And my last message is perfect is sometimes enemy of good, so I stopped doing at this point. I did not touch any left main, and my patient, it was done in January 2021. So in these 8-9 months, patient is doing good in the follow-up. There was some fall in hemoglobin post-procedure, which recovered after the iron infusion and all, and now the patient is doing good. Thank you for patient hearing.
Thank you, Dr. Aditya, for your wonderful presentation.
Thank you, sir.
Manoj sir, you want to ask something to Dr. Aditya? Okay. Then we can go ahead with the next presentation by Dr. Dipankar Das. He is a consultant of Narayana Hospital, Guwahati. I request Dr. Dipankar Das to start his presentation.
Am I audible, sir?
Yes, sir, you are audible. Please
Can you
proceed.
see my slides?
Yes, sir, it's visible. Please proceed.
Okay. Thank you, Northeast Cardiology Update, for giving me an opportunity to present my case today. I am Dr. Dipankar Das. I'm a consultant cardiologist at Narayana Super Speciality Hospital, Guwahati. My case is not that hi-fi case type, but it is just a feel-good factor for me. So I am going to present my case. So my case is a 49-year-old male patient who is a smoker and hypertensive, but he is non-diabetic. He presented to us in the emergency with one-day history of retrosternal chest pain associated with excessive diaphoresis. In the last 1 day, he was having intermittent chest pain. So there was no history of any breathing difficulty or palpitation. So on clinical examination, he had a pulse rate of 98 per minute regular. BP was around 158/92. His chest and CVS examinations were within normal limit. The respiratory rate was around 20 per minute. So ECG was done in the emergency, which revealed significant ST depression from lead V3 to V6, 1 and AVL. And then TROPI was done in the emergency, which was high, and NT-proBNP was although in the normal limit. So echo was then done, which revealed no RWMA, and the ejection fraction was near normal. So a case of CAD, acute coronary syndrome diagnosis of NSTEMI was then made. The patient was then loaded with ticagrelol, ecosprin, and rosuvastatin at requisite doses. Because of ongoing angina intermittently, he was shifted to the cath lab for coronary angiography. So coronary angiography revealed this we used a 5 French radial sheath, and 5 French tiger catheter was then used to hook the coronaries. In the RO caudal view, we can see that the distal left vein is significantly stenosed. It is around 90% stenosis. There is slight calcium present at the distal left vein. Also a large OM can be seen as having a slow flow, most probably with thrombus. This is the LAO caudal view, which revealed significant tight distal left main stenosis with involvement of ostial LAD being around 90% stenosis, and also involvement of around 60-70% stenosis of the ostial LCX. So this is the left main bifurcation disease with involvement of both the ostial LAD and the LCX. This is the PA cranial view. This is the RO cranial view. The RO cranial view is showing that the left mid LAD is also significantly diseased, around 90% stenosis with involvement of a diagonal. The RCA, however, was normal and dominant. So a diagnosis of NSTEMI with double vessel disease and critical left main bifurcation disease was made. Now, the question was how to treat this patient. So for this type of disease, we have two options: either go for bypass surgery or go for multivessel PCI. Because of ongoing acute coronary syndrome and angina on and off, PCI was favored. Now, again, LMCA bifurcation stenting can be done by mini crush technique or decay crush technique. But because of intermittent chest pain, the patient was in agony, so a choice of mini crush was then made. So immediately femoral access was gained and a 7 French sheath was inserted. JL 7 French 3.5 was then taken to hook the left coronary, and mini crush technique was then decided to do the PCI. 7,000 international unit of heparin as per the weight of the patient was given intravenously. So after hooking with JL, two run through hypercoat wires were then used to wire both the LAD and the LCX. Redilatation of LAD to LMCA to LAD was then done with 2.5 NC balloon, 2.512, and also the mid LAD was then dilated with 2.512 balloon. So post ballooning, we can see that the lesion has opened a bit in the mid LAD. Then even the ostial LCX was, LMCA to ostial LCX was then inflated with an NC balloon. Thereafter, 2 stents were taken. Into the ostial LCX was placed 3x20 Promas element stent, and into the LMCA to LAD was taken 3.5x20. In the mini crush technique, we take both the stents together, and hence the need for 7 French guiding catheter. So after placing the LCX stent in the ostial LCX with slight protrusion into the LMCA, the LCX stent was then deployed at 14 atmospheric pressure. Post deployment of the ostial LCX stent, the wire and the balloon were then taken out, and LMCA to LAD stent was then inflated again at 14 atmospheric stent. We can see that the LCX stent got crushed. This is the shot after the stenting. Then we did we recrossed the LCX stent and then inflated with three balloon, and then by this one, and then kissing balloon was then done with 3.5 balloon in the LMCA to LAD and 3 balloon in the ostial LCX. This is the kissing balloon, and then POTS was done with a 4x8 balloon. Then after that, I did the mid LAD lesion also with 2.75 into 38 balloon, and then inflated and then post dilated it. This is my final angiographic shot. We can see that there is well expanded stent in both the LMC, LAD and the LCX with a neocarina. This is the RA caudal view. We can see that the flow is TIMI3 in all the vessels. And this is the post-op ECG. The ST elevation, ST depression has significantly reduced. So post-procedural period was uneventful. The patient was discharged on day 2. He still follows up in OPD and is hale and hearty and stable. Thank you.
Dr. Dipankar, wonderful presentation, beautiful demonstration of bifurcation stenting. Dr. Agarwal, you.
It was a very nicely done. Let us go to the next case.
Yeah, we can go ahead with the next case. It is by Dr. Krishna Narzari. He is a consultant of GNRC Hospital, North Guwahati. May I request Dr. Krishna Narzari to start his presentation?
Am I audible?
Yes, audible, Krishnada.
Sir, you'll have to share again.
Yeah. Thank you, Dr. Farhin. Respected.
Sir, you have to share again.
Respected Judge Sir, and my dear teachers present here, and all the faculties and audience. So thank you, Dr. Farhin, for giving me this opportunity to present CD in this CSI Northeast conference. So when he invited me to present a case, so initially I thought that I don't have any interesting cases. Then later on I decided that some patient with who presented with acute myocardial infarction. So I took 3 CDs actually. One who is very young patient presented with acute atrial MI, and one he is completely who is elderly lady who is completely lack of awareness about any cardiac diseases. In fact, he never visited any hospital. And one patient who presented with very normal ECG. So these 3 patients I'm going to present. I've already mentioned one patient presented with 35 years of male who is a very smoker, but he presented in time, 3 hours of duration. His BP and pulse heart rate was normal. It's a very old case actually. I did attended this patient in 2017, so I don't have that ECG, but I still remember he was having acute atrial MI, ST levels in MI. So we explained the situation and did the angiogram. Right system was normal, and here is the left coronary artery. There was complete occlusion of the in the proximal part of the LAD. So we explained them regarding the revascularization, and they have agreed. So we started doing this one PCI. initially the guide gate was creating little problem. That's why I took wear in the L6 also. Then subsequently I did wearing of the LED. When actually at that moment it was 2000, it was done in 2017. So I thought that thrombus situation will have. So I took half of thrombosuction catheter. But as I was using the 6F catheter, it was not going. So that's why I removed the L6 wear. Then I did the thrombosuction and large amount of thrombus was aspirated. Then after thrombosuction, you can see the flow in the LED. Then subsequently, we did the routine things. I dilated with pre-dilated balloon and then did the stenting. And we got a very good result in that patient. So this young patient, after doing revascularization, subsequently after 2 days, we have released the patient. Another patient, I said that this diabetic patient, he knows me actually. We did pacemaker in his mother. So that's why after 90 minutes of his symptom, he immediately came to my chamber directly. He was profusely sweating and he was having chest pain. We clinically, the pain was suggestive of acute coronary syndrome. ECG and ECG was absolutely normal. In fact, we repeated the ECG after 1 hour. It was also normal, no significant dynamic changes. So ultimately, we explained the situation to them, and we did the angiogram. And you can see there is very critical narrowing along with presence of thrombus in the LCX. So ultimately, we did PCI in that patient also, and we got a very good result. This was the end slide of the patient. And the last patient, Mrs. Khadija Bibi, she was, as I told you, she was the patient who is completely ignorant about his medical facilities or any cardiac diseases. But one good thing is she visited the hospital within 2 hours of symptoms. And she was very unstable when presentation. And systolic BP was 7. This was also done in 2000. The ECG quality is not that good. I have taken this from MRD record. There was ST elevation there was ST elevation in the inferior leads. So we went for angiogram, and you can see the left system. There was complete occlusion of the LAD in the origin, and there was significant proximal L6 disease also. And when we did the angiogram of the right system, you can see there was complete occlusion of the right coronary artery in the proximal part. So ultimately, we have explained the need of primary PCI in the patient. In fact, what one thing I did here, that by the time my guide cat and manifold and other things and Y connector were ready, I did one interesting thing here. Angiogram I did with Tiger catheter actually. As soon as they have given consent for primary PCI, I took the simple guideway and I entered the RCA with across the lesson with this one guideway, and immediately when the little flow came here, her blood pressure became above 90 systolic blood pressure. Then subsequently, I sensed it. By the time my other things, other Y connector and everything was ready, I sensed it with RCA GR 6F guide. Then subsequently, I did PCI in that patient. So her hemodynamic becomes stable. But she refused to stay in hospital for a long time. Immediately next day, we discharged her. She requested us that she don't want to stay in hospital, but by the time she was stable, so we discharged her and in a very good condition. So actually, why I presented this 3 case is that one young person is not immune to develop acute coronary syndrome, especially if there are risk factors. We all know, but it's a very important thing. And ECG may not be diagnostic in all the cases. In fact, not only initial ECG, repeat ECG may also be normal. So when there is clinical suspicion, we should go for angiogram to see the anatomy. And lack of awareness is still there in our society. Very important factor. So last, I want to say that early revascularization should be considered whenever it is possible. Thank you.
Thank you, Dr. Farin. I finished my slides.
I think Farin is busy somewhere. We can have a presentation from Dr. Randeep Sivam.
Yeah.
I think he's the last person to present. Yeah.
Dr. Randeep is a consultant of Apollo Hospital, Guwahati. Dr. Randeep, please go ahead with your presentation.
Thank you, sir. Good evening, sir, and respected Judge sir and all the senior members and my colleagues. Today, I'll be presenting a case which I have assisted under a proctorship. It was done recently in our hospital. So, without so this is a case. We have a 70-year-old female patient diagnosed to have a severe aortic stenosis. On echo, it was a tricuspid aortic valve. The mean gradient across the aortic valve was 52 mm mercury. LV systolic function was good. Patient was in sinus rhythm. Mainly presented with angina on exertion, dyspnea on exertion, easy fatigability. Background history of type 2 diabetes mellitus and hypertension. She was recently detected with COVID without any much of a symptoms, and she was admitted around 2 months back with a heart failure. So we thought about this patient. We calculated the surgical mortality score, and the error score was high and such comorbidities. So we planned that she needed a aortic valve replacement, but surgical replacement risk was high. So we have decided to go for a transcatheter aortic valve replacement in this patient. So we did a 3D CT angiogram. We got the annulus of around size of around 22, and coronary CT angio was normal. And we did a angiogram, a CT scan of the femoral arteries as well as the iliac arteries. So that showed normal, so more than 7 mm size of the femoral artery. So then we proceeded for a TAVR from the femoral approach. So initially we did the pre-procedure coronary angiogram just during the procedure. So both all the 3 coronaries were more or less normal. Then and after that, first we took a 3 axis, two arterial axis from both the right and left side, and a venous axis from the right, and venous axis from both the right and left side also. So we put a catheter. Since we found that the left-sided iliac artery was bigger in size, so we took the left arterial port as the working port, and we put a 6 French pigtail catheter in the non-coronary sinus, and we do the coronary root angiogram, aortic root angiogram, to see the valve morphology as well as the coronary arteries. Then we put a TPI lead from the right femoral vein. Then the next step was going for the crossing of the aortic valve aperture. So we took a M plus AL2 and we directed it towards the left coronary sinus and pointing towards the aortic valve aperture. Since the valve was quite calcified, so we could just make out from the calcification itself. So we took a straight tip software Terumo wire to cross the valve. So after we cross the valve with the straight tip wire, so we put inside the M+ wire, and we exchange the soft tip wire with the extra stiff M+ wire. This is the extra stiff M+ wire which is kept in the apex of the LV apex. So now after that, we exchange the M+ emplaced a wire with the help of another pigtail. The slide is not there. We exchange another pigtail and we put in the safari wire. It's a curved wire like the LA wire for the wire to be stabilized. Then we took a mammoth balloon of the size of 18 into 40 mm and we put it across the aortic valve over the safari wire. So then we inflated it after inflation, we can see the aortic valve is open. The dilatation of the aortic valve has happened. So during that time, the pressure drops, and after that, we take out the balloon as early as possible. The next, we tried for we wanted to take the navigator device with the transaortic aortic valve. But what we found that when we negotiated the Python sheet and the navigator, we could not pass the sheet and navigator through the left iliac artery. So we thought we found that the CT report was a bit anomalous because more than 5.5 mm of iliac artery is sufficient to pass through the navigator device, but maybe the CT report was anomalous. So we planned to do a iliac artery dilatation. So we took a Mustang balloon of size 7 into 60 mm. We dilated the iliac and the femoral artery, and after that, with some difficulties, we could pass the. This is the navigator with the navigator balloon and above which the aortic valve is crimped. So we just passed over. We went inside over the same safari wire. So after that, we took a root angiogram to see the exit position. Generally, we prefer to around 1/3 inside the LV and 2/3 above in the aortic room. After doing it, this is how we deployed the aortic valve. We used the Merrill My valve, the size because we found that it was around 22 mm of aortic annulus. Generally, if the aortic valve is tricuspid, we do around 8% oversizing of the valve. And if it is bicuspid valve, generally we prefer not to oversize much. We generally go around the same size of the aortic annulus. So this is we did the dilatation, and after that, immediately we have to pull out the balloon. Otherwise, it may get stuck. So after dilatation, we pull out the balloon immediately, and also we have to pull out the pigtail catheter, which was in the non-coronary sinus. So we have pulled out the pigtail catheter. Otherwise, the only problem here, it may be sometimes if the sinotubular junction is very narrow, this pigtail catheter may get stuck. So we have to be careful while pulling it out. And after that, we took a root angio. So we see that the coronaries are flowing well, and there is no aortic regurgitation, no paravalvular leak is seen. So this is well deployed. Now our main worry was about, we have dilated the femoral artery. So there may be, because the Python sheet is there, so during that time, we thought that there will be no issue of any bleeding. But when we remove the sheet, we thought that there may be perforation. So we were ready with a peripheral stent, fluency stent, so that if there is any perforation, we'll just immediately do a cover stenting, the fluency stent. So while removing the sheet, so we slightly give small angiogram and to see if there is any perforation or something. So we were lucky, in spite of very small femoral arteries we could do, and there was no any specific definite perforation or any tear. And after that, we closed the artery, the puncture site, with a probe light. So post procedure, the patient was hemodynamically stable. And the echocardiogram showed that prosthetic valve was functioning normally. The mean gradient was 4 millimeter. There was no aortic regurgitation, no paravalvular leak, no pericardial effusion. But what we saw was that patient developed LVBB following the procedure. This may be, it is seen that LVBB may be present especially because of some edema in the septal area, where the edema may lead to edema of the conduction system that may lead to the LVBB. But the regime reverted to normal sinus rhythm with narrow QRS after 5 days, and the patient was discharged on the 6th postoperative day without any complication. And the patient is doing well now, and the symptoms have reduced. So the take-home message is that even if the patient is elderly and she is a high-risk case for a surgical aortic valve replacement, we can always go for a transcatheter aortic valve replacement, which is feasible and which we have started doing in our area also. Thank you.
Rondip, thank you for your presentation. Since we are running late, I request Dr. Chandan to start his presentation. The last presentation by Dr. Chandan Madok, then we can go ahead with the invited lectures. Chandan, please go ahead. You want to ask something to Dr. Rondip? Chandan, go ahead, please.
Yeah. Am I audible?
Yes.
My slides. Can you see my slides?
Yes, sir. Your slides are visible. Please proceed.
First of all, I thank the organizing committee of Northeast CSI, and also I thank Dr. Manoj Agarwal sir and all my seniors for making up some time for us. And I also thank all my juniors and colleagues to participate in this program. So actually, I am presenting a case on this is a acute limb ischemia case. So 50 years old lady, she was a housewife by profession. She presented with severe pain of the left upper limb, hand fingers, and blackish discoloration of the middle finger for last 4 to 5 days. She had a history of surgical resection of terminal ileum with temporary colostomy in the abdomen about 15 to 20 days back. And also she had history of hypothyroidism and anemia. She is not hypertensive, non-diabetic, no past or family history of similar event or any vascular event like stroke or myocardial infarction. On clinical examination, I found that the hand is cold and clammy. Up to the forearm, there is skin change, color change, that is pale, and the capillary fill time was prolonged. Absent of left brachial, radial, and ulnar pulse. BP was not recordable on the left arm. On right arm, there was tachycardia and BP was 110/70. There was sensory impairment in the hand up to the wrist, and no sensation was present in the middle finger. You can see on the photo there was a discoloration of the middle finger, distal fillings, and motor function was almost preserved. Apart from that, the power of the grip and below elbow flexion was weak. So patient was diagnosed as acute limb ischemia of Rutherford stage 2B. Blood samples were sent urgently for complete blood count, RFT, LFT, BT-CT, PTI, NRA, BTT, and full coagulation profile. Immediately intravenous 5,000 unit of unfractionated apparent bolus administered. And attendants were explained about the prognosis of the limb, that it may need amputation, bleeding risk associated with thrombolytic therapy, and patient's history was taken for any contraindication for thrombolysis, and immediate intervention with the catheter-directed transarterial thrombolysis was planned. So by that time, the platelet count came to be 950,000 per cubic millimeter, and hemoglobin was 8.4. Total count was 19,000 with myelocyte and metamyelocyte of 4 and 8% respectively. But coagulation profile reports were pending, and the patient was diagnosed as primary thrombocytosis. The medicine team and a hematology referral was sent. Oral loading dose of that's why oral loading dose of ticagrelor 180 and aspirin 325 mg administered, and patient was taken to cath lab. As the patient had supramesenteric artery thrombosis few days back, so we took a check shot there. Then through the transfemoral approach, to the right femoral artery, we take 6 pence GR 3.5, and we can see there is a large thrombus at the mouth of the left subclavian artery, and also in the left brachial artery, the whole artery is small in lumen, and radial ulnar artery were not visible after their origin. So first of all, I tried with ballooning of the at the ostium of the radial and ulnar arteries, but I failed. There was no flow. And after that, I saw that there was a large thrombus occluding the whole left brachial artery, just at the mouth of the catheter. And by that time, we infused already 5,000 international unit of unvaccinated heparin. And then we took 6 pence export advanced catheter and over the BMW air to suck out the thrombus from the artery. After the thrombus suction, we can see the brachial artery and radial artery completely, but not the branches. And also we can see some clots in the distal radial artery, but ulnar artery was not seen. So we used semi-compliant balloon 212, then export advanced catheter, and using the same guiding catheter with tip kept inside the clot in the ulnar artery and several holes made proximally. We went for catheter directed thrombolysis with tenecteplase 2.5 mg per 2.5 mg bolus, followed by 0.25 mg per hour infusion for 24 hours. On day two, patient was having severe pain after 24 hours of tenecteplase infusion. So we took her again to cath lab, and it showed that there is extensive thrombosis of the left brachial artery. So then we repeated again the thrombus suction, but there was no outcome, and there was thrombus in the brachial and distal arteries. So we have changed the strategy. Catheter-directed reticulous infusion was started with 5 unit bolus and 0.25 unit per hour infusion. This time we have planned for 48 hours of infusion, along with interference F6 bolus, followed by 0.125 microgram per kg per minute IV over 12 hours. This time coagulation profile reports have already arrived, and those are also normal reports except platelet count. So we have infused F6 this time. And after infusion of F6 and then reticulase, you can see all ulnar and radial arteries are clearly visible, except some distal digital branches of the radial artery. You can see the middle finger and index finger. You cannot see the distal phalanges. Otherwise, there was excellent flow achievement in the radial and ulnar arteries. And in proximally, because we infused the thrombolytic only distally, so this time you see the proximal, check the proximal artery, that there are some thrombus in the mid part of the arm in the brachial artery, and also in ostium and proximal part of the subclavian artery. So we continued the same treatment, and on day 4, we took check shot that all thrombus were clear, and the proximal subclavian artery was also bigger now. There is no clot except for a small not sitting eccentrically in the proximal subclavian artery. So at 5-month follow-up, patient came with only the dry ganglion of the middle finger distal fillings, and the same patient also presented 2 months back with bilateral lower limb DVT and acute ischemic stroke 1 week back. So luckily she arrived to hospital within 1 hour, and she received intravenous thrombolytic therapy from neurology side, and there was no neuro deficit. So this time we changed the ticagrelor to pasugrel along with aspirin, and hematologist has confirmed the diagnosis of essential thrombocythemia, which is one of the chronic myeloproliferative neoplasm, and she is under treatment for that. So the take-home message is that although none of the commercially available thrombolytic, that means alteplase, retiplase and tenecteplase has shown a benefit of one or another, but in our case, the retiplase showed better outcome than tenecteplase. And although evidence of adjunctive use of GB2B3 inhibitor in these circumstances is not proven, but it has shown benefit in our case by giving intravenous bolus followed by infusion of F6-MF. And catheter-directed thrombolytic and thrombus aspiration can be successfully done by using all our regular PTCA hardware to prevent limb amputation. And we should always try to find out basic etiology of arterial thrombosis, especially if it occurs in upper limb and in patients without peripheral artery disease, and to treat the underlying cause to prevent recurrence. Thank you.
Thank you, Dr. Chandan. We have almost completed our all CD presentation. So, Dr. Agarwal, hello. Manojda, you want to ask something to our participant or give your final comments before closing the session? Manojda, can you close the session?
Yeah, Farin, let us go ahead. Yeah.
So now we move to our last session, that is the session of invited guest lecture. For this session, I request Dr. Professor A.C. Kalita, Dr. Deepak Sharma from Jorhat, and Dr. Amir Sharma to take over. We have two wonderful presentation by Dr. P.C. Rath sir and Dr. Rakesh Yadav from AIMS. So, Chairperson, please take over. Thank you.
Dipagda.
Okay.
Hi, Rakesh. How are you?
Sir, how are you, sir?
I'm fine, thank you. Very nice to see you over here. Dipagda, can you start?
Okay. Let us, it's always a pleasure to have Dr. Professor Rakesh Yadav with us. So,
Dr. Sharma, sir, how are you, sir?
I'm fine, Rakesh. How are you?
Very nice to see you here.
Okay, I am equally nice to see you too. Anyway, I think it's always a pleasure to see you and have you with us. So I don't think there is any person in Northeastern cardiological fraternity who doesn't know Rakesh Yadav. So I'm not going to introduce him in a typical way. And so I'm just going to give a few insights to his character and his abilities. So Rakesh, as you know, is, I think, one of the brightest minds in this country, and not only in field of cardiology, in general terms as well. So, he's like a brother to all of us. Not only a brother, he's a mentor, and he's also a guide to us most of the time. Whenever we hold a meeting, a conference, we always approach him, and he's always forthcoming in giving us terrific insights and help us to find ways how to go ahead with the conference and all. And whenever we invite him, he always comes, always goes out of the way to come. And interesting thing is that he never takes us any passage to come from us, passage to come here. He pays from his own pocket to come here. I think Rakesh, it's great to have you. I'm not going to tell you how many papers you have published, how many things you have, how many conferences you have spoken to. So anyway, I think the topic is very interesting today. So it'll give us a great insight about the approach and management of STEMI in late presentation. I think it will be very interesting because it is of interest to all of us in Northeast, because here typically the people with STEMI present pretty late, particularly in a place like Jorhat, Dibrugarh, whatever, maybe in Guwahati because of traffic jam also presented. So Rakesh, please go ahead. And can I take one permission from you, Rakesh?
Please, sir.
So though it is a guest lecture, if anybody wants to have any clarification at the end of the topic, can some people have?
Absolutely perfect, sir. There has to be a question answer.
Okay, thank you, Rakesh. Then please go ahead.
Thank you, Deepak sir. Deepak sir and Kalita sirs are like my elder brother. And my second home, always people say your second home is Northeast. So really I admire my second home is Northeast, and I love the reception and love given by them to me. Thank you very much, Pranav, for calling me for this lecture. And today it's a very important topic because it is not the problem of Northeast, it's even a problem of Delhi. The approach to a management of STEMI who are presenting late. Now, that is very, very important. Why it's important? Because in a management of STEMI, the time is important. As soon as you revascularize, it is a more better mortality and morbidity. And if you are late, the benefit of all treatment goes away. We have made a lot of advantage in advancement in last 2 decades. And it has reduced tremendous morbidity and mortality in management of acute STEMI. But the late presenter is a still major problem, even in Western country, because the data says that even in Western country, approximately 15% of the patients present with a late time. How you define late presentation? The late presenter are invariably defined if we are presenting more than 12 hours after the onset of the first symptom of STEMI. So the 12 hours is the basic the time period beyond which you are defined as a late presenter. However, in our setup, significant number of patients came after 48 hours. Even in our aims, we have seen the patients who present after 2 days without any treatment. The major issue in defining the rate presentation is a reperfusion therapy, because all rest therapy is same. So it is a reperfusion therapy which is important, whether to give, whether to not to give in the late presenter. Now, if a patient present more than 12 hours, there are 4 phases of management of STEMI. First, pre-hospital management, a hospital management and discharge. And the most important thing is follow-up advice and rehabilitation of these patients. When a patient presents after 12 hours, the first and foremost thing is that you have to have an ECG. If you are presenting with an STEMI within 12 hours, the guideline says that you should have an ECG done within 10 minutes of arrival to your casualty. But I don't think any guideline mentioned that the ECG for a late presenter should be done within 10 minutes. However, I will always recommend do an ECG as soon as possible. Even a patient who are presenting late, keep that patients in an ECG monitor bed with a defibrillator capacity. And you have to take the blood sample for additional serum markers and other tests. The additional ECG for a right ventricular infarct, for a posterior wall infarct, need to be done in all these patients. On the right side, the guidelines are the patient who presented early. So I have made 2 important things that the guideline says basically of early presenter, but what we should do in a late presenter, what a guideline says, what are the evidences. However, I always say that these guidelines are applicable to the late presenter. Only the revascularization therapy, there is a debate. Now, as far as oxygen is concerned, even a patient who has, because the guideline says that if your saturation is less than 90%, you should have, it's a class 1 indication to give oxygen. Now, if your saturation is not more than 90, is a more than 90%, you don't require to give oxygen. There are a lot of studies we say that these oxygen may be harmful. However, the previous guideline, this is an European guideline. However, the previous American guidelines says that all patients of MI who has presented should be given oxygen for 3 hours. As far as late presenter is concerned, I will always say that if their saturation is less than 90%, only give the oxygen to them. Sedation, yes, a late presenter may have an anxiety, they may have an pain, so you have to give a proper sedation and painkiller. It's a class 2A indication. However, I recommend that all patients who presented late, if they are having any chest pain, if they are having any anxiety, you have to give opioid for the relief of pain and mild tranquilizer for their anxiety. There is no controversy. Within 6 hours, all guidelines says that the thrombolytic therapy or a primary PCI should be done. From 6 to 12 hours, the recommendation is that if a patient presented with STEMI between 6 to 12 hours, all are class 1 indication. You have to revascularize this patient either by thrombolytic therapy or a primary PCI. There is no debate. The literature says that is a class 1 indication. Now the controversy starts. If you have a late presenter, means you have presented more than 12 hours of the onset of the symptom. What is the current status of thrombolytic therapy? The European guideline says that after 12 hours, they have not mentioned thrombolytic therapy as the treatment option. However, this European guideline has come, the last guideline has come in 2017, but the American guidelines, which is last American guidelines is published in 2012, and there is an upgradation later on. They recommend that if a patient of STEMI presented more than 12 hours and less than 24 hours, and if they are having ongoing symptoms, hemodynamic unstable, and there is a large area of myocardium at risk, you can give thrombolytic therapy in these patients. And it's a class 2 indication. Class 2 indication means in our setup, if a patient comes beyond 12 hours with a chest pain, with a hemodynamic instability, with an ongoing ischemia, large area of myocardium, we should give thrombolytic therapy if primary PCI is not available. And once you have given a thrombolytic therapy, try to shift this patient to PCI capable facility. However, if patient is asymptomatic, he is not hemodynamic unstable, the thrombolytic therapy with after 12 hours has no role, and there's no evidence that in these patients you should give thrombolytic therapy. Beyond 24 hours, you should never give thrombolytic therapy in an asymptomatic patients or patients who are presented beyond 24 hours of onset of symptoms. Now, these are the evidence. The first evidence is in 1993, a late trial. Late trial has included 6,000 patients and compare patients who and given ethyl place, which is beyond 12 hours from symptom onset. And they have concluded that there is an ample benefit within 6 hours. From 6 to 12 hours, still there is a benefit, but beyond 12 hours, there is no benefit when you thrombolize these patients. A subgroup analysis of the late trial says that if there is an ongoing symptoms and a significant electrographic changes, still giving thrombolysis has 22% reduction in mortality, but it should be within 24 hours. The ICES-2 trial, which is published in 1988, it also shows the reduction is mortality by 19%, though it's not statistically significant, in a patient who receive STK between 12 to 24 hours if they are having symptoms or they have having hemodynamic instability. Again, this is an EMIRAS trial published in 1993. 4,000 patients included up to 24 hours. And what they say, beyond 6 to 12 hours, there is a benefit, but it is not statistically significant. But after 12 hours, giving thrombolysis, there are no benefit in patients, even they are having a symptom or hemodynamic instability. Then come a primary PCI beyond 12 hours. So now it's very clear that the thrombolytic therapy should not be given beyond 12 hours. However, there is subtle evidence that if they are hemodynamic unstable and if they are having ongoing chest pain, they can be offered primary thrombolytic therapy. And I recommend that in our setup, where primary PCI facility is not available, we should give thrombolysis in a subset of people beyond 12 hours up to 24 hours who are having ongoing chest pain or hemodynamic instability. But what about our primary PCI? Now, these are the recommendation of European Society, which is equally within American Society. They say that in patient with time from symptom onset more than 12 hours, a primary PCI strategy is indicated in all patients who are having ongoing symptoms, hemodynamic instability, or life-threatening ventricular arrhythmia. So it's a class 1 indication, no doubt about it. And these are all evidences. These evidences came in 2011 with PLACS study in which they have recruited 2,000 patients, presented 12 to 24 hours, and they say that invasive approach has lower mortality after 12 months than patient with conservative approach. And what they say that if a patient presented from 12 to 24 hours, even though they are asymptomatic, a primary PCI may lead to mortality benefit. And this is again a study was published in 2009, early study. Infarct size and myocardial salvage after primary angioplasty in a patient presented with symptoms for less than 12 hours and from 12 to 72 hours. However, it's not statistically enough powered study, but it says that final infarct size is larger in late presenter. It is very obvious. And when you revascularize this presenter, it can limit the infarct size. Now, this is again a study which is published in 2005. Mechanical reperfusion in patient with acute myocardial infarction presenting more than 12 hours from the symptoms onset. They have not a very huge population, about 365 patients, which is known as BRAVE 2 study. What they find? That the final left ventricular infarct size was significantly smaller in patient assigned to invasive group if they are late presenter without any symptoms even. And the secondary endpoint of death, recurrent MI or stroke at 30 days occurred in 8 patients in invasive group and 12 patients in conservative group, though it is not statistically significant. It is showing trend toward the benefit of invasive arm. So what they have concluded, an invasive strategy based on coronary stenting with adjuvant use of abscisic reduce infarct size in patient with acute STEMI without persistent symptom beyond 12 to 48 hours after symptom onset. And they have a 4-year follow-up, which again shows that in these patients, it is a mortality benefit what they have found. However, this study is not statistically empowered to say this. Now, this is again a study, a Korean study, long-term outcome of patient with late presentation of STEMI. It's about 13,000 database in which about 600 patients are late presenter. And what they concluded, obviously, late presenter had remarkably worse clinical outcome than early presenter, even they are revascularized in the subset. So what European guideline has recommended at present? A routine primary PCI strategy can be considered in patient presenting late between 12 to 48 hours symptom onset. And this is if you have no symptoms, you have no instability, you have no hemodynamic instability. So now this is a difference between an ACC guideline and a European guideline. ACC guideline don't recommend it, but the current European guideline recommend that all patients who has in the STEMI not thrombolized, if they present late, you can do a routine PCI in this patient. It's a class 2 indication. However, beyond 48 hours, if you do an angiogram and there is a complete occlusion of the artery, you should not open until there is ongoing ischemia or there is hemodynamic instability. It's a class 3 indication. And this is depend upon the O trials, occluded artery trial investigation, which has included a huge amount of patients, follow up for 4 years. And they find that in these subset, after 3 to 28 days, if you open the infarct-related artery, if patient is not having any angina, hemodynamic instability, they have a worst outcome. So at present, after 48 hours, if you have done an angiogram, it is an occluded artery, there's no ongoing ischemia, there's no instability, please do not open the artery because these patients will have a worst outcome. Now, this is a very important study. Percutaneous coronary intervention for late reperfusion after myocardial infarction in stable patient. This is a meta-analysis. This meta-analysis included the O trial also. So again, this meta-analysis says there were no statistical significant difference for any clinical outcome with trend to have an increased myocardial infarction and decrease in CHF in PCI arm. The PCI arm shows a slight superiority in left ventricular ejection fraction, and that was shown in a smaller unrandomized previous study. But after this OAT study, it is very clear that after 48 hours, if patient is asymptomatic, please do not open this artery. It may have an adverse outcome. So this is in current a guideline at present, which I think everybody is following. From 12 hours to 48 hours, if patient is having symptoms, hemodynamic instability or arrhythmia, you should perform a primary PCI. If patient is asymptomatic, a routine primary PCI from 12 to 48 hours is class 2A or B indication. Still, it is recommended if you are doing it, is you are not harming the patient. However, beyond 48 hours, if there's no symptoms, no hemodynamic instability, no arrhythmia, routine PCI will harm the patient. So it's a class 3 indication. Now again, that is very important because it is challenging the recommendation given by all the society. This is a recent study. I think it's published in 2018. What they have done the medical magnetic resonance imaging, MRI imaging in these patients. The patient who presented beyond 12 hours, they have undergone primary PCI. So they have done an MRI imaging within 72 hours and then 30 days. What they have found, that patient who presented late and presented within 12 hours, though they are in fact the equal area of risk, the risk in which myocardial is jeopardized is equal. However, the late presenter has larger final infarct size, even if they underwent primary PCI. It is obvious. If you perform early, there will be less myocardial. If you perform late, there will be more myocardial damage. It is obvious. But what they have done, this is the most important thing in this study. STEMI patient with sign of ongoing ischemia treated with primary PCI 12 to 72 hours after symptoms onset had less myocardial salvage and developed large infarct. That is obvious and we all can understand that late. But what they have said, however, a large proportion, 2/3 patient who are presented late has substantial myocardial salvage indicating a benefit from primary PCI in late presenting patients. So they say even they have a large infarct, they have a left salvage. If you do a PCI in a late presenter, depending upon MRI study, you are able to salvage about 65% of the patients. This is also a Swiss study in which they have done an PCI after 1 to 3 months, asymptomatic patients. And what they find 200 patients, that if they are having a asymptomatic ischemia, and they have defined asymptomatic ischemia, they have done a treadmill test. In treadmill, if there are an STT changes and they have no symptom, they further underwent a cardiac nucleotide imaging or a stress echocardiography. If they are showing positive without any chest pain, then they have included the patient. So out of 1,000 patients, they are only able to include 200 patients. They are entirely asymptomatic ischemic patient. And if you perform PCI, they have a less sudden cardiac death. They have a less LV dysfunction in long term. So it's very, very important. So I think at present, seeing all the guidelines, this should be the recommendation which I should give, that late STEMI presenter after 12 to 48 hours, if they are hemodynamic unstable, they should straightway go to primary PCI, percutaneous coronary intervention. Now we cannot say primary PCI, but if they are not hemodynamic unstable, but still having sign and symptom of ischemia, they should go for a percutaneous coronary intervention. If they are not having sign and symptoms of ischemia, assess timing. It means if they came within 12 to 48 hours, the European guideline says that they should go for a percutaneous coronary intervention. But if they are more than 48 hours, I think you require a stress test imaging. If a stress test is negative, you should not subject to these patients for PCI. But if a stress test is positive, then you should subject them for a primary PCI. Otherwise, you should have a medical management in this patient. Now, if PCI is preferred in these patients, what are the problems you are going to face? These patients who are presenting late have more thrombus burden, believe it. So there is more chances of no flow and slow flow. So you should be prepared for that. You should have all the instrument, all the medicine for preventing of no flow or slow flow. So that is a very important thing. Now the debate starts whether you should only touch the infarct-related artery or you should do a multi-vessel PCI. So at present, if you say me, even though, because the literature at present say when you are doing a primary PCI in a patient who are presented less than 12 hours, you only want to touch the infarct-related artery. You don't want to touch a multi-vessel. However, at present, I still recommend if a primary PCI, if a PCI is done in a late presenter, you should only touch the culprit vessel at first. And if possible, you can do a revascularization of these patients later on, preferably before discharge. Deferred stenting is not recommended in a late presenter STEMI patients. Now, what are other therapy? You have done a reperfusion therapy. I think reperfusion therapy has its own role, but other therapy is very important. What about the antiplatelet? If you have a late presenter, the guideline says antiplatelet who has come early. But I say all these guidelines for antiplatelet fixed with a late presenter. You have to give aspirin to all these patients until this you have to give clopidogrel if these patients are not going for a PCI. If you are not going for a PCI, late presenter, you don't think that these patients should be thrombolyzed or sent for PCI, you should load with them with clopidogrel, 300 milligram. If you are not taking for PCI, don't give ticagrelor and prasugrel. It is not recommended even in late presenter. No role of upstream GP2 inhibitor. If a patient after 12 hours comes to you, he is not having any symptoms, don't load with GP2 inhibitor. It has no role. Anticoagulant therapy. I think I will follow anticoagulant therapy as I was following early presenters. So if they are late presenter, you should give unfractionated heparin or enoxaparin, and this should be given for the hospital stay or if you are going to take this patient for PCI. So unfractionated heparin should be given in all these patients. Now, what are the doses? I have given this slide, but I'm not going to read this slide. Only two things I just want to say. If the patients late presenter are not a candidate for either a thrombolysis or a primary PCI, aspirin plus clopidogrel should be given, no prasugrel, no ticagrelor. And the dose of clopidogrel should be 300 milligram loading followed by 75 milligram orally. If these patients are for thrombolysis, there are a very small subset of patients from 12 to 24 hours who require thrombolysis, please give clopidogrel only. Do not load with them prasugrel and ticagrelor. and the dose of clopidogrel is still 300 milligram. But if you are going to thrombolize this patient, the age is more than 75, loading dose of clopidogrel is only 75 milligram. Don't load them. However, if these patients are being taken for a PCI, the ticagrelor or prasugrel should be preferred. However, I can say you, I am now going to write an editorial on this. Clopidogrel still hold the place. Don't forget the clopidogrel. If you are giving clopidogrel, even a patients who are going for intervention, you are not doing a crime. So if you have a practice of giving clopidogrel, continue it. However, the loading dose of clopidogrel should be 600 milligrams, not 300 milligrams. What about the NTG, IV NTG? If a late presenter has a heart failure, uncontrolled hypertension, ongoing ischemia, I think IV nitroglycerin should be given. And how long it should be given? There's a lot of debate in this literature, even in early presenter, but I will say that at least for first 24 hours to 48 hours, if you are giving IV nitroglycerin, you are not doing a crime. Beyond that, until there is a compulsory indication like ongoing ischemia, uncontrolled hypertension, heart failure, I think routine beyond 48 hours has no role in these patients. And the evidences are not ample, but there's a small studies, and beyond 48 hours, if patient is not having any ischemia, nothing else, you have done a primary PCI, continuing oral nitrates is perfectly a physician dependent. If you say me, I will still like to continue oral nitrate for 6 weeks. So there's no literature, no evidence, no recommendation. Then what is the role of beta blocker? These are the recommendation who was presented early, but I think these recommendations hold true for late presental also. Beta blocker, especially the oral, I don't think that IV beta blocker should be given in late presenter. The oral beta blocker should be considered during hospital stay and continued thereafter in all patients if this is not contraindicated. I will not recommend IV beta blocker in these patients who are presented late until they are having tachycardia, uncontrolled hypertension, there's recurrent VT, and there's some compelling indication of beta blocker. Regarding ACE inhibitor, all these standard criteria for early presenter implies on late presenter. So ACE inhibitor should be considered in all patients in the absence of contraindication. If they are having heart failure, if they are having diabetes, anterior infarct, it is a class 1 indication. However, if they are not having the heart failure or diabetes, still it's a class 2 indication. If you have to ask me, if it's not contraindicated, the blood pressure is not less, they are not allergic to ACE inhibitor and ARB, I will give start ACE inhibitor as soon as possible in all these patients. MRA, mineralocorticosteroid receptor antagonists are recommended in all these late comers. If their ejection fraction is less than 40%, they are in heart failure or they are diabetics. Lipid lowering therapy, I think high dose statin to be given to all patients who are presented late until it is contraindicated. And this guideline implies to same guidelines if they are presented early. And our target, there's a lot of debate which target of LDL should be kept. And I believe that less than 70, not much less than 50. There's a lot of debate on this, that you should achieve less than 50. I will recommend less than 70 LDL in these patients. Calcium channel blocker should not be given in these patients until they are having an ongoing ischemia and beta blocker is contraindicated. And the second important indication of calcium channel blocker, the atrial fibrillation to control the heart rate. Routine use should not be given. Prophylactic lignocaine and amiodarone should not be given. Whether you are seeing a run of BPCs or NSVT on the monitor, don't give amiodarone or lignocaine. They have done more harm than doing benefit. Magnesium should not be given. Glucose, insulin, potassium has a lot of controversial role. So I will not recommend at present to give this. Then there's a complication. all the complications, because there has been a lot of study which has shown that the complication and higher in late presenter, whether it's an RVMI, tachyarrhythmia, cardiogenic shock, volume depletion, mechanical complication, heart failure or arrhythmia, they are more common in late presenter as compared to early presenter. And this should be a standard which has been seen in early presenter. Management of cardiogenic shock is very, very important, because if patient present after 12 hours, he is in cardiogenic shock. Patient present with after 48 hours, he is in cardiogenic shock. Class 1 indication, take these patients for a percutaneous coronary intervention. It's a class 1 indication. There's no doubt about it that these patients should be managed medically if you have a facility of a percutaneous coronary intervention. However, should you give thrombolysis beyond 24 hours in cardiogenic shock patient remain controversial. I have searched a lot. There's no strict data which recommended a patient who came after 24 hours in cardiogenic shock, should you thrombolize or not? I think I have left this on the discretion of the treating physician. However, you have to do a routine echo in all these patients to rule out mechanical complication. And if you have a left ventricular assist device, I think the indication is same as it is presenting early. There's two important studies. Whether if you have cardiogenic shock, late presenter, you will touch only the infarct-related artery, or if you do a multi-vessel angioplasty, the culprit shock says it is basically an early presenter. It says, no, do an IRA. But the Korean acute myocardial infarction registry says, do a multi-vessel. It is still controversial. I will always say that if you have a simple type A lesion in other coronary, they presented late. If you could tackle immediately without a very minimum contrast, do it. But if it's a complicated, complex lesions, don't touch, only do the infarct-related artery angioplasty. If you have an atrial fibrillation, I think the indication, the treatment is same as if atrial fibrillation has occurred in an early presenter. If you want to control the rate, beta blocker is a class 1 indication. Digoxin you can give, and IV imidazole is a good option. Please do not give IV calcium channel blocker in these patients. They sometimes have done more harm. Don't hesitate to give IV imidazole, because IV imidazole in acute condition is not as harmful as calcium channel blocker. And if you want to do cardioversion, if patient is hemodynamic unstable, he is having severe chest pain, his heart rate is too high, he is in LVF, please do immediate cardioversion. Don't wait for the drug therapy to act. Do an immediate cardioversion in these patients so that the AF can be controlled. What happened in a late presenter who has presented with ventricular arrhythmia? If they have a ventricular arrhythmia, they have a ventricular storm, the beta blocker is a drug of choice, not a lignocaine and imidazole. And in a beta blocker, IV propranolol is the treatment of choice. So if the patient has a ventricular storm, try to give beta blocker. With beta blocker, give an xylocaine, give an imidazole, give an IV magnesium. If patient is not, take them for immediately revascularization, put an assist device, or ventilate them with a propofol deep sedation. So these all are for ventricular storm, but beta blockers should be the drug of choice in these situations if they are having a ventricular arrhythmia, followed by immediate revascularization. Prophylactic use of antiarrhythmic is a class 3 indication, and if a patient is asymptomatic and hemodynamically irrelevant ventricular arrhythmia, it should not be treated with antiarrhythmic drug. So if you are seeing a VPCs on monitor in a late presenter, please do not give beta imidazole or xylocaine. If you want to give beta blocker in these patients. And for a long term, it is a standard therapy for ICD. If they have ejection fraction less than 35%, more than 6 weeks of MI, and they are revascularized, you should give ICD. But the second part is very debatable. Suppose you have a ventricular arrhythmia on 4th day of MI. What will you do? Patient is not having ischemic symptoms, but he is a ventricular tachycardia. The recommendation says for 40 days, give them wearable ICD, and I will say in our setup, it is easy to give an implantable ICD than a wearable ICD. So this part in India, I will always say, if they are having ventricular tachycardia, which is a secondary ventricular tachycardia, not a primary ventricular tachycardia, after 48 hours of MI, and you have revascularized these patients, given optimal therapy, I think ICD should be considered in these patients before 40 days of MI. So don't hesitate to give ICD in these patients. After that, the secondary prophylaxis means control of risk factor, lifestyle modification, smoking cessation, weight reduction, regular physical exercise, optimal control of blood pressure and diabetes, then dyslipidemia, dietetic therapy, exercise should be considered equally as they have presented early. And after discharge, I think these patients should be kept on dual antiplatelet at least for 1 year. Beta blocker should be given indefinitely. ACE inhibitor should be given indefinitely. Hormone replacement therapy in post-menopausal women. Calcium channel blocker should not be given. Nitrates if you are suspecting an ischemic symptom. Anticoagulation, yes, at present if patient is in atrial fibrillation, you have to give triple drug therapy, DAPT with anticoagulation at least for a month, and then you can convert anticoagulation with clopidogrel. Rehabilitation of these patients is very, very important because rehabilitation has shown to improve the morbidity in these patients. Rehabilitation means you have to early mobilize these patients, don't make them bedridden, because early mobilization is very important, and at present early discharge is also important. The sexual counseling is often overlooked in these patients, should be considered strongly. The psychosocial factors should be taken, and ideally there's a study that in these patients, post-MI patient, at least 50% will have moderate to severe depression. So a good psychosocial counseling of these patients, I think, should be made mandatory because it will improve the drug compliance, it will improve your advice and patient follow-up. Lifestyle modification, it is being seen that up to 80% of coronary artery disease patients attributable to modifiable risk factor like tobacco cessation, sedentary lifestyle, obesity, diet. As far as diet is concerned, whether you should take more fat or more carbohydrate is a very debatable topic. I always say that if you are taking more fat, take natural fat. Take God-made fat. If you take in more carbohydrate, take God-made carbohydrate. It means the fat which is available in a nature should be taken. The carbohydrate which is available in the nature should be taken. It means what fat, what carbohydrate a man has made should be avoided in this patient. Simply means a simple sugar, a simple thing should be avoided. The dalda, the refined should be avoided. You should avoid a saturated fat and trans fatty acids. So these should be avoided in these patients. So to conclude my talk, I can say latecomers after STEMI, that's more than 12 hours with evidence of ongoing ischemia, should be considered for primary PCI and even a thrombolysis in our setup. Delayed PCI more than 48 hours in asymptomatic stable patient should not be done. It is a class 3 indication. In a latecomers after STEMI who are asymptomatic, stress test can help guiding us for invasive management. However, there's no data, ample data, but I will always say, do an stress test in these patients. If positive, take them for angioplasty. If not, please do not try to take them for a percutaneous coronary intervention. And it is important to have a high index of suspicion for mechanical complications. That is very, very important, because if you don't do a proper echo, don't do this, mechanical complications are very common in late presenter, which can kill the patient. So you should be a very high suspicion that you should rule out all the mechanical complication. And I will say, still it is very confusing. Still after my talk, I am still confused, and the individual patient should be taken individually, and it should be guided by the therapy, by the armamentarium, which is available in particular part of this country. If it is remote, I never say that take this patient for immediately primary PCI. If you can thrombolize this patient, still it is going to benefit. Thank you very much for your kind attention.
Thank you, Rakesh, for your absolutely brilliant masterclass. I think you have covered everything. I don't think there is any question to clarify, but if there is any, we can take a couple of questions.
No problem.
If there is none, we'll have to proceed to the next part. So Professor Kalita, will you take over? It's a really absolutely brilliant masterclass, Rakesh. Beautiful. Beautiful. So I think, Ham, I think we can go into the next part. Can you unmute yourself, please, Ham? Can you unmute yourself?
Amya is here?
Yeah.
Dr.
Amya?
Amya?
Amya, unmute yourself, please.
Dr. Amya?
Yes,
Yeah,
I'm here.
yeah, I could see Professor Roth.
Yeah,
Hello,
can you
hello,
hear me?
Dr. Roth. Yeah, we could hear you. It's
Okay,
amazing
fine.
to have you here. Dr. Amya, would you please introduce Dr. Roth, please? Amya?
Yes.
Yeah, please introduce Dr. P.C. Roth.
Yeah, actually, already we are very much delayed. No, only more than 1 hour delayed. And Dr. Roth, he will be talking on a very important topic, that is intravascular imaging during PCI. And
I think some problem.
The voice is broken. Voice is breaking. And to Ham, I think you should just go ahead yourself.
will be, this prepared for a next lecture for some international webinar. So I request Dr. Roth to kindly start his deliberation without spending more.
Just a minute, Dr. Roth. He's one of the senior most intervention cardiologists in India. He is a very first few batches from CMC Vellore. At one time, CMC Vellore was considered to be the pioneer institute in cardiovascular disease and neurosurgery. So he's one of those very pioneer in this very field, and he worked in Hyderabad in Apollo Hospital for pretty long duration. He has some brilliant activities in multivessel disease and left main disease interventions. So with these few words, I request Professor Roth kindly to go ahead.
Thank you, Dr. Kalita, and thank you very much for inviting me for this Northeast update. I'm thankful to Dr. Pranam, who specifically called me to give this talk. As you know, nowadays we do around 30% of the interventions in complex cases like left main bifurcation, CTO, and venous interventions. And then when you do this, a result should match that of surgeon. Because unless in these complex cases, the surgery, unless you do almost equal or better than surgery, it is not going to be taken by the patient, and we are not going to do justice for that. So traditional angiography alone is not enough. Angiography has a lot of limitations when it comes to assessing the luminal dimension, vessel wall pathology, and the end result of stenting. OCT and IVS are increasingly available as intracoronary imaging modality that provide high resolution imaging for coronary arteries. Compared to angiography guidance alone, use of either OCT or IVS is associated with better procedure success, in-hospital outcome, and lower long-term mortality in both elective and acute coronary syndrome patients. So with this introduction, I just want to show those images. When you see image in OCT, it's just like a histology. You see the intima, media, and ventria. And when you see these images, both IVS and intracoronary OCT, you can assess the plaque characteristic. If you see the A slide, there's a calcium chunk there. You can see the fibrous plaque. All these you can see assessed by OCT and IVS, so that you can decide what type of modality is better, whether it's a routine angioplasty, cutting balloon, or if there's a lot of calcium, you can use a rotator. This is you can really, in OCT images, you can really find out the tissue characteristic. You can see the first one is a homogeneous high black scatter. It's called low attenuation, fibrous plaque. lipid plaque looks like that. That is typical characteristic which is well defined. You can see in OCT. I don't have to go into detail. Calcium nodule you can see, and calcium plaque you can see in OCT very, very clearly. And thrombus. Thrombus, you can see the red thrombus, you can see the white thrombus, you can see the recanalized thrombus, you can see lot of things inside the coronary artery. Pathology, different type of pathology like fibrous atheroma, calcific atheroma, clots, what type of clot, is a recent clot or the old clot, black, is a red or white, retinal, everything you can see very clearly if you are doing OCT. When you do OCT, we calculate the total area, we calculate the diameter of the vessel, we can calculate the percentage stenosis. This is how it's calculated. And if you are putting a stent, whether the stent is well approached or not well approached, you can see through the calculation. These are, I do not want to get into details, but this is how you see a OCT image and you calculate. This is the LED, you can see angio of the LED, this is a critical block. You want to assess by OCT, what is the length of the block, what is the diameter of the vessel, and what is the maximum narrowing. That you can see with the OCT. We have seen the length of this is around 14 millimeters. So from normal to normal, so we know it is a 14 millimeter stent is required. You see the diameter is around 2.25 distally and 2.9 proximally. So you know the diameter and you decide what length and what diameter stent you would need it for this case. This is again after stenting, you do the OCT, you see whether it's well expanded or not. You can see the white dots surrounding the wall. These are the stent, well approached. Diameter, whether it is fully opened or not, that you can see. First one is a cross-section view. Second one is a longitudinal view. Third, you can see the stent. Whether if it's you can see the white. If it is white, means stent is well approached. All these informations you can get in OCT. These are malapposition. Sometimes when you put the stent, you do the OCT, you can see whether the stent is well approached to the wall or not. If it is not well approached, you can see it nicely. You can again dilate it so that it's approached. Because if the stent is not well approached, there's a high chance of stent thrombosis and restenosis. So this you can see very clearly. This is dissection. Sometimes in angiography you missed a dissection. But if you do the OCT, you can see very clearly a dissection. This is the OCT image. In intravascular ultrasound, you don't see that clearly. OCT in bifurcation lesion, when you use two stents, it is very important to see whether the stent cover all the wall and where you are putting the second where, proximally or distally. By doing the OCT, you can see the whole, this is the PTC where middle one and the other one is a stent. You can see it very clearly. In follow-up cases, patients are coming after stent, they have symptoms, you want to know how much is the stenosis, you can do the OCT and you can see whether the stenosis is minimal, homogeneous or moderate or it is heterogeneous. Depending on that, you can decide whether patient this type of instant stenosis will can be treated with balloon or will require cutting balloon or it will require rotablator. So the pathology of histopathology of instant restenosis you can study. This is the difference between IVS and OCT. IVS, you know, it is there for years together. Is what you do is the intravascular image. You just put a catheter and the IVS catheter is there, goes down, automatically scans, and principle is with intravascular ultrasound, it takes the image. But the image is black and white. You don't have to use any contrast. But while in OCT, we put a small camera, goes down, then we inject contrast, make it free, that wall of the that length of the artery, make it free from water, and automatically the camera scans, take the photo, and you see. The advantage of OCT is resolution is on parallel, and you see the automatic playback is there. You can see all this pathology very, very clearly. It's a very high resolution. You can see the lipid, calcium, fiber, thrombus, everything, but more costly than intravascular ultrasound, cannot be reused. And penetration is not very much. You can see if the artery is very big, you cannot see the wall. So up to 3.5 millimeter artery 4, you can see it very clearly. But intravascular ultrasound is a time tested, it is there, it has been there for many years. No contrast is used. Picture is black and white, not as clear as OCT. But advantage is less costly and can be reused. That's very important for Indian context. And lot of data are there in IVS supporting that IVS is better than using IVS. The result is better than OCT because OCT has come recently for the last 10 years. Then I'll show you few cases. I know it's too late, but I'll try to show some cases what you do really day-to-day life. We have been in Apollo, Hyderabad. I started at the OCT first in the country, and I have been doing for last 12, 14 years. My first series was published in Indian Heart Journal, where we saw that series of 50 cases. It was published in Indian Heart Journal. We saw that OCT, by using this OCT, immediate result was fantastic. We could sometime, but in 30% cases, we had to change the size of the stent and balloon, and some additional stent because in routine angiography, it was not possible. This is some of the cases I'll show you, very interesting cases. We use mostly complex cases, left main bifurcation, and wherever there is a complications we suspect, we use it, and we use it quite regularly. Almost 20 to 30% of our cases we use IVS or OCT. This is a 49-year-old male. He came to us with unstable angina. Look at left main critical block, bifurcation block. We decided to stent it because he came for most of the patients who come to us. Me at least, they know that they're coming for angioplasty, not surgery. He was offered for surgery, he didn't want surgery, he was too young. So what we did is, you see the block, left main, so much critical block in the left main. So we use a technique called decay cross technique in this case. We put 2 air in both LAD and LCX. Then we pre-dilated LAD, and then we pre-dilated LCX, and then put a stent in the LCX. And with using a balloon, we crossed it. Then we recrossed the LCX, and then we did the first case. Decay cross has 1 cross and 2 cases. The first case we did it. And then again, we put a left main to LAD stent. Then we do the port, proximally we dilate, it's called port, the technical term. Then we did the second case, and second case, you can see these are 2 balloons, we are making the case, and that is the result, almost normal. So this is called bifurcation stenting by decay cross, and we used in this case OCT because OCT help us in sizing the L6, LAD and left main. We know exact size. Tracking the guide wire, when the second guide wire you put, you should put proximally, that is what we'll see it. Recrossing bifurcation stent, and stent, whether in the end we did the OCT to see that whether the stent is well approached or not. So this is how it helped. First we did a pre-procedure OCT, and this OCT will only show the length, diameter of the left main, diameter of the LAD, and diameter of the L6. Then we balloon dilated. When you dilated the balloon, LAD and L6, the dissection, there is a lot of thrombus formation. We didn't know. Angiographically, we didn't see. So immediately we started glycoprotein 2b3 so that thrombus, it doesn't develop clot. Then we put the stent first and then recrossed. You can see the wear is, you can see that clearly in the OCT wear. We are crossing to the circumflex, proximally the second wear. You can cross it. And in the end, we saw this is the OCT, 3D OCT also we can see in this. In the end, there's a metallic stent we can see inside, like a film tunnel you can see the stent inside. It's white means it's well opposed. It's all white, and that's the circumflex, that's the wear. Two wears they are going. You can see 3D inside the stent, and you are absolutely sure your stent is well opposed. If there is somewhere where opposition is not good, you can take a balloon and do it. If there's a dissection somewhere distal to stent, you can always put a stent. This is the type of result we get it. You, in fact, it's just like endoscopy, what you see, or if you compare coronary angiogram is like a black and white. We are doing those time barium swallow, but endoscopy, what we do is these are the endoscopy, like this OCT. You see everything and treat it. This is another case where he had a critical block in left main, LAD and L6, and this is the block. You can see very, very critical block in left main. We dilated LGL. We decided to stent it because he didn't want surgery. And most of the people don't. We tell them surgery, but they must have sucked everywhere they come for interventions. And we dilated LCH, we dilated LAD, and then that is the result after balloon dilatation. Then we position two stent, one L6, one LAD, and we did a mini cross here. We crossed the circumflex stent with the stent in the left main to LAD. This is called mini cross technique. And after crossing this, we recrossed the L6 where is out, and then we recrossed again, and then we did we dilated the ostium of the circumflex stent, and then we did a two balloon, did a kissing balloon, and that is the end result. It's just like a normal artery. So I show you very complex two left main cases where we routinely would have gone for recommendation is surgery. First recommendation bypass surgery, but with all these gadgets, we can get result as good as surgery. And young patients, they don't go for surgery. We do this type of patients where surgery is contraindicated. Second thing, many patients, young patients, they don't want surgery, they come for this. So we do it. Now, this is the result, end result is just like looking normal artery. And at the end, we do the OCT just to see that all stents are well opposed. And you can see the dot. Dot is, that means it is stents is covering the wall. It's well opposed stent. That is out. This is another case again. It's a case where this patient had stent earlier in circumflex. Now he has come with left main disease, and we put two wires in LAD and L6, and we did the OCT. You see the severe instance stenosis. You can see inside the cell growth, and outside the white one is the previous stent. So what we did is we did a rotablator. We took rotablated from left main to circumflex, and then this was a good result. Then we decided to put a stent from left main to circumflex, and then after that suddenly we see just distal to the stent there is some hazy area. When we are not sure whether the clot migrated, why it happened, or spasm, so we immediately took a OCT, and you can see a very large flap there. Right side, you can see a flap. I have focused it. So when there is a large flap, we immediately put one more stent there. And that's the result. Then we move to the LED, where we move to the LED, dilated the ostium, that stent stent, and put one more 3x15 stent, and this is the result. So the complex case where there is a left main disease, there is instant restenosis, two vessel disease, and we could wait with the stent on the end. We did the OCT as I told you. And this is the last case. This is a young fellow who came from out of the state. He had acute MI, he went somewhere. They did a primary angioplasty. He was discharged. After 2 months, he started having pain again, effort angina. So we did an angiogram. We had a suspicion that there is a ostium of the left main has disease. But for the ostium, OCT is not good. It will not be able to show it. So intravascular ultrasound is the ideal. So we did the intravascular ultrasound there. That was the angiogram. You can see now around 70% block there in the ostium. So what we did is we take a 4.5 millimeter stent, short stent, and implanted it there, and that is the result. Angiographically is clear. This is the stent, and he has gone. He went back without any angina. So there is a trial called IVS comparing in PCI ultimate trial. Just want to share you the result. Result in those cases where IVS is used. This was published in 2021. The result, MACE, target vascular reversation, repeat reversation, everything was less. You can see the left side. Blue one was with balloon alone, and the red one is with IVS, intravascular ultrasound. That was the way. But right side again, when the result after balloon E was suboptimal, either with balloon or this intravascular result was not good. So suboptimal, you shouldn't leave. You should use the intravascular ultrasound to get the best result. Then only we get the 3 years follow-up result. And if you use OCT, many times you find that 20 to 30% patients, you have to change the length of the stent or diameter because angiographically it is not clear. That is why when you do the OCT, you optimize the result so that the stent covers all the disease part and covers the wall well. That is the aim of the interventions using OCT or intravascular ultrasound. This is a new trial, Illumin trial with OCT versus intravascular ultrasound. It was shown that and balloon, and it has shown that the end result with intravascular ultrasound, immediate result, intravascular ultrasound and OCT is same, balloon is inferior. But there is a large trial going on, multicentric randomized trial to compare the outcome of OCT versus angiographic guided PCI. That result will come very soon, and I'm sure that result will show that OCT, if you're using, the result, long-term result also will be very good. So, ladies and gentlemen, in performing complex PCI, angiography alone is not enough. Imaging modality like OCT, IVS help in optimizing the PCI result and are associated with better procedural outcome in hospital and also long-term outcome and mortality. Newer modalities like 3D OCT, what I showed, metallic stent optimization, you can see like tunnel inside. This offers a better view for bifurcation stenting. These are, you know, the guide where to put the second air, all these technical details you can see and do it. These techniques helps in visualizing the stent strut after stent implantation in greater detail and can detect unexpanded and malposition with creatives. So we have been using in my lab, around 20 to 30% of cases, we mostly use OCT because that's more clear. But in cases where there is a renal failure, osteal disease, severe lipids dysfunction, we use intravascular ultrasound. So I am a proctor for the OCT. I go all over the world to treat. But I think now, presently, when you are doing complex interventions, you should have these imaging modalities to get a very good result, immediate and long term. Thank you for your attention.
Thank you, Dr. Raj. I think you have brought the cath lab right into the seminar hall, and we are delighted to have this. And obviously, with a proper view with OCT and IVAS, the implementation and outcome is expected to be high and definitely high with various trials it has been shown. I just can invite 1 or 2 questions if at all, because we are running nearly 1 hour behind, because now we have to go for general body meeting probably. Just 1 or 2 questions if anybody do have. Yeah.
Just 1 or 2 questions if anybody do have. No, we have cancelled our general body meeting today.
Oh, I see.
Tomorrow during the plenary.
So get the opportunity to have some. Get the opportunity to have some things to be cleared from Dr. Rat.
Hello.
Well, not a question, but a comment. Fantastic presentation, Dr. Rat.
Yeah.
Fantastic, brilliant presentation of a new modality, which is not done everywhere in India, unfortunately. I think should be done. From your presentation, we could understand that. Yeah, I think if there's any question, I'm a non-intervention person, so even there I got a very good perspective of the situation. And if there's any interventionist want to ask any question, more than welcome. I think Dr. Rat will be quite happy to answer that.
I have a small this query to Dr. Raj sir. First of all, thank you very much for your brilliant presentation. While using this, this OCT, is there any chance of, giving more heparin or using more heparin, which could lead to some more this problem? Can there be a situation like this?
Not clear. Can you repeat it?
The dose of heparin, do we need to give more heparin?
Dose with?
Heparin.
Yeah.
Do we need to give more heparin while going for imaging?
No. It takes 10 minutes. 5-10 minutes to set up and do it. No extra heparin and nothing. Only we use contrast, more contrast, and sometimes we dilute the contrast also. Now we are using sometimes patients who are renal compromised, dextran also. So nothing, no extra heparin. It's just a routine thing. Once you do it, it takes 5-10 minutes to start, do the first run, and then after that 5 minutes alone. But you see so many things. You see so many
things. Completely visualize the inside of artery and
I can tell you, just like we are seeing in the olden days this barium swallow, all imagining things. You can compare barium swallow with your regular angiogram, but OCT is just like endoscopy. You see everything.
Thank you, Dr.
sir. Wonderful.
Yeah, please, Pranam.
I have one question.
Please.
Sir, one last question.
Yeah, go ahead, please.
Hello, am I audible?
Yeah.
Yeah, one last question, sir, if permission.
Go ahead, please.
Sir, would you recommend having both an OCT and an IVAS in your cath lab?
OCT definitely get much more information than intravascular ultrasound. I told you 3 instances only where you can use the intravascular ultrasound. Osteal lesion. Second, patient with renal dysfunction. Third, patients with LV dysfunction. All other cases, OCT gets superior result. Only thing is, financially, in OCT, intravascular ultrasound can be reused more frequently, but OCT not more than 2, maximum 3. So cost is the concern and limitations are 3. Ostium, renal dysfunction, severe LV dysfunction. Okay. And if there is
I think we can conclude the session, Professor Kalita.
Sure. Yeah, please conclude.
Yeah, you can. Go ahead.
Yeah. Thank you very much, because Professor Yadav and Dr. Rath for wonderful 1 hour, more than 1 hour deliberation of by both of you, and thank you very much. So today is already more than 10, so let us conclude here. Pranab, do you have anything to declare? Any message from Pranab or Amya? Because when is the general?
Yeah. Yes, sir. I have the results of the competitive CD presentation, which was judged by Dr. Manoj Agarwal from Hyderabad. So I would like to announce the results of the competitive CD presentation. Can I have this? So to announce the